LVF, and then you look at you look at the LVF mean at the relevant times of follow-up. And most important, if you look at the difference column, that's the easiest way to look at it. You can see the difference between the follow-up measurement at whatever month we are looking at, and the baseline is always very minimum and almost always not exceeding 1. That's an absolute 1 figure. And in fact, most of the time it's below 1. And the difference is never being statistically significant. So the differences between LVF at a certain time point and the baseline is extremely minimum, if any. And we tried to look at, so basically we conclude that compared to baseline, mean LVEF was not significantly different at any of the subsequent time points, and the range of changes was between a decrease of 0.9 to increase of 1.087, and that was not significant. And we looked at those delays. We had omission of administration temporarily once for 2 patients, so for 2 patients once each, and that was based on clinically suspected cardiac toxicity, which was later on excluded on further investigations. And these are the stories of 2 patients, but both of them did not have cardiac toxicity, and it was unrelated to trastuzumab and pertuzumab. This is the NewSphere study, and I put it here, I sort of documented here as a reference. They concluded that the mean maximum decrease in LVF measurement was very low, 4 to 5%, and was balanced across treatment groups. And they reported no significant changes was detected when pertuzumab was added to trastuzumab in terms of cardiac function. And they also documented no patient had an LVEF decrease to less than 40% at any time during the study. 4 patients showed LVEF decline of 10 to 15% from baseline and to less than 50% during the neoadjuvant therapy. So even the NewSphere had showed minimum impact or detrimental impact on cardiac function. And similar interpretation was quoted by the investigators of the Cleopatra, and they said mean LVF value remained generally stable over the treatment period in both arms, with or without the addition of pertuzumab. And this is again in Cleopatra, as you can see at the bottom, in the arm of trastuzumab and docetaxel, and in the arm where pertuzumab is added, you can see there is no detrimental effect of adding pertuzumab to cardiac function. In fact, if anything, numerically, for some reason or another, numerically, it looks better when pertuzumab is added. So very quickly looking at the efficacy in these patients, if we look at the neoadjuvant cohort, 28 patients, we don't have to look at all patients' characteristics, but for an example, about 71% of patients had positive lymph nodes, and about 43% had positive lymph nodes in the ER and negative and ER positive respectively. Complete response in the breast and the axilla was seen in 53.6% of patients, and as expected, the complete pathological response was higher in the ER negative cohort, 64%, and a bit less, 42 or 43% in the ER positive. And this compares well to the NewSphere. If you look at the NewSphere, I think the complete pathological complete response was about 46%, and in our cohort in the routine practice was 53.6%. And when it comes to ER and PR status, in the NewSphere, the pathological complete response in ER negative disease was in the region of 64%, which is very close to our figure of 64% as well. So looking at a relapse-free survival in the neoadjuvant cohort, keeping in mind the very short follow-up of 15 months, The median relapse-free survival was not reached, but the estimated figures at 3 years was 82%. In the palliative cohort, 39 patients treated in the palliative cohort, 17 were previously exposed to trastuzumab. Objective responses were evaluable in about 37 out of 39 patients, and complete response was seen in 5, i.e. 13.5% of patients, and partial response was seen in 27% of patients. That means we will have objective response rates of about, and I'm calculating now, 40% or something. So that is quite reassuring, keeping in mind many of these patients were exposed to trastuzumab. The median follow-up in palliative setting was 37 months, and the median progression-free survival was 18 months, and the median overall survival was 38 months. So this is putting it in graphical presentation. The progression-free survival was 18 months, and the overall survival was 39 months. So basically, we conclude that in this cohort of our relatively small initial experience, including 4 centers or 4 hospitals, dual anti-HER2 therapy using antibodies trastuzumab and pertuzumab in combination with chemotherapy was not associated with significant cardiac toxicity, at least in these patients. And we're wondering what is the wisdom of doing routine echoes every 3 months. So maybe we need to look at least in a study session, in a study context, maybe checking if every 5 or 6 months will be more reasonable. And also we conclude that in a routine practice, combination anti-HER2 antibodies with chemotherapy provides a meaningful pathological complete response, relapse-free survival in the neoadjuvant setting, and meaningful overall response rates, progression-free survival, and overall survival in the palliative setting that are in line with the results of landmark studies. Thank you. And of course, I would like to thank the contributors, Dr. Halim Rasool, Dr. Sayed Azhar from the UK, Dr. Ihab Mus'ad, Ayman Rasmi, Abul Khair Al-Jahmi, and Kamil Faraj. Thank you again.
Good morning. Thank you, Dr. Jamal. And now we're presenting the third winner, the abstract number 20, the incidence of osteonecrosis of the jaw in cancer patients treated with zoledronic acid or denosumab at tertiary care hospital, a retrospective study, will be presented by Mohammed Al-Mutairi, a pharmacy practice resident at King Fahad Medical City in Riyadh.
Assalamu alaikum. Just to correct, I'm not a resident. I'm a clinical pharmacist covering hematology and oncology at King Fahad City. So firstly, I would like to thank the organizing committee for accepting my abstract and to be presented here in this conference. So I have no real potential conflict of interest related to the subject that will be presented. Here's the outline. So firstly, I think everyone here expert with this subject, which is the osteonecrosis of the jaw. It has been associated with the anti-resorptive agents, the bisphosphonate, zoledronic acid, and denosumab. It is a very serious and rare condition that, if happened to the patient, might affect their lives. There is limited trials that has been published about this subject. I have found retrospective trials. This trial found that the percentage of osteonecrosis of the jaw were 4%, and the associated risk factor were diabetes or number of zoledronic acid or denosumab doses given to the patient. So this agent has been used widely for certain conditions in cancer patient, hypercalcemia of malignancy with multiple myeloma, for example, and bone metastasis with the breast cancer, for example. So the aim of this trial was to evaluate the osteonecrosis incidence and the risk factor associated with this condition amongst all the population. This trial has been conducted at King Abdulaziz Medical City National Guard. Based on my search, I have not found any trials in Saudi Arabia that has been conducted in this matter. So I think this is the first one to be conducted to find the incidence and the risk factors. As I said, this trials has been conducted at King Abdulaziz Medical City National Guard. So this trial is a retrospective trial that has been conducted from 2017 to December 2019. The inclusion criteria for our trial were we include patients more than 14 years of age, and we decide that at least 2 doses should be administered to the patient to be included in the trial based on the previous trial, because they found that 1 dose might not associated with the osteonecrosis of the jaw. The exclusion criteria, thank you. The exclusion criteria, anti-resorptive agent used for non-cancer conditions, for example, osteoporosis. So our primary outcome was to estimate the incidence rate of the osteonecrosis of the jaw associated with zoledronic acid or denosumab and the associated risk factors. The secondary outcome was to evaluate the rate of compliance with dental clearance before initiation of these agents, because any dental issues that the patient has with this agent, based on the trials, has been associated with the osteonecrosis of the jaw. So we want to check the dental compliance with the clearance. So the statistical analysis, the association between the dependent variables and each independent variable were tested using Fisher exact test, and the level of significance was determined to be less than 0.05. So here is the patient characteristics. We tried to find if there is any association between any patient characteristics with the osteonecrosis of the jaw. We found that there is no association, as we see here. We include the gender, the body mass index, and the smoker status, and we found that there is no association. For patient diagnosis related factors, we include chemotherapy, oncology diagnosis, indication for anti-resorptive agents, and the exposure time of treatment. And the only associated risk factors that has been found to be associated with the osteonecrosis of the jaw were type of treatment. We found that zoledronic acid has been associated more with the osteonecrosis of the jaw as compared to denosumab. And we found that if the patient used both agents, zoledronic acid and denosumab, this will associated with osteonecrosis of the jaw. For the comorbidity of the patient included in the trial, we include diabetes, hypertension, CKD, osteoporosis, liver disease, and anemia. We found that there is no association between these risk factors and these comorbidities and the osteonecrosis of the jaw. The trials found that diabetes and number of doses has been associated with the osteonecrosis of the jaw, but our trial didn't find any association. For dental characteristics, we found that the strong association between the osteonecrosis of the jaw and this agent were the dental disease. If the patient has dental disease and there is no dental clearance, this will be associated with osteonecrosis of the jaw, as we see here. 10 patient has dental disease, and this was associated with the osteonecrosis of the jaw. And regarding the dental clearance before initiation of anti-resorptive, we found that only 4% were compliance to do dental clearance before initiation of anti-resorptive agent. Here is the odds ratio. As I said before, compare the patient who was taking zoledronic acid with the patient who was taking denosumab. We found that this patient has been associated with the osteonecrosis of the jaw. And if the patient taking both agent at any time period, this will be associated also with the osteonecrosis of the jaw, and the strong association with where the dental disease. So interpretation of our data, the total number of patients including the trial were 281 patients. The incidence rate of osteonecrosis of the jaw were 4%. Comparing to the international data, it is comparable. The international data report that it is from 2 to 4%. So comparing the patient using zoledronic acid versus denosumab, patient with denosumab were significantly less likely to have osteonecrosis of the jaw as compared to zoledronic acid. And using anti-resorptive agent with dental disease, this has a high risk of developing the osteonecrosis of the jaw. And the rate of compliance with dental clearance before initiation, the anti-resorptive agent were 4%. So the conclusion of our trial, the osteonecrosis of the jaw is serious and rare complication associated with anti-resorptive agent. The associated risk factors found were using zoledronic acid and denosumab, and patient with dental disease. Patient screening before starting this agent is fundamental modality to decrease the risk of osteonecrosis of the jaw. And thank you.
Thank you so much, Dr. Mohammed. I was wondering about the compliance rate, why it's low. Probably there's many reasons, and probably we might leave this to the discussion part. It's 2 or 4% is quite low. I know there are some reasons, probably those who started zoledronic acid before they come to the hospital, or some endocrinologists, they don't think the clearance is important, especially for 1 or 2 doses. So, but we'll leave it to the discussion. We'll move to the next abstract for today. We have the next abstract will be presented by Dr. Mundir Al-Alwan from King Faisal Specialist Hospital and Research Center. The topic of the abstract is promising biomarker for therapeutic targeting in a triple negative breast cancer. So it's a complex disease, complex biology. So we'll see what we go. Thank you.
Assalamu alaikum, sabah al-khair all. I would like to thank the organizer for selecting our abstract for oral presentation. And hopefully in the next 10 or 15 minutes, I would be able to convince you in the markers that we take from the basic science till it reached the clinical application. Right now, it's in the clinical trials. So for the sake of time, I don't have to convince you on incidence of breast cancer in Saudi Arabia. So I'm going to jump on these slides, and I'm going to go to this slides, which show you that of the 4 main subtypes, breast cancer subtypes, triple negative is or has the most aggressive behavior and has the worst clinical outcome. As you can see here in both disease-free survival and the overall survival, always triple negative breast cancer cells do the worst. in terms of the available or most common in practice recommended treatment for triple negative is systematic administration of chemotherapy. And sorry, how do I go back? And just a few facts about triple negative. It accounts for less than 20% of all breast cancers subtypes, and has, as I said, the most aggressive phenotype with high recurrence and worse clinical outcome. And it lacks biomarkers or valid targetable targets, I mean. So with these limitation of a therapeutic option, we aim with this study to identify biomarkers and or signaling pathways that are associated with these biomarkers that are enriched in these triple negative breast cancer cells for potential therapeutic targeting. One of these markers that we are working on is called FASN. It's an actin bundling protein that has been shown in many normal cells as well as cancer cells to promote cell migration and invasion. It has restricted expression in vivo in normal tissue, mainly in immune cells like mature dendritic cells and neurons. But it's negative in epithelial cells. Unless they are transformed, these epithelial cells, then they become positive, which include, of course, breast epithelial cells. So we found that these FASN expression in breast cancer, it strongly correlate with the tumor size and with the ER negative, PR negative, and HER2 negative borderline, but some other studies, they found it's also correlate with the HER2 negative. Most importantly, it's highly correlated with the PD-L1, the immune modulator PD-L1, and it also strongly correlate with metastasis. And as you might expect also, it correlate with shorter survival. So FASN positive patients are normally do very bad compared to FASN negative patient. And because it correlate with metastasis, we want to see whether FASN is the what promote this metastasis. So we bring an triple negative breast cancer cell lines, we downregulate FASN, and we show that when we downregulate FASN in these cells, they become less invasive in vitro. And we delineate or dissect the pathway, and we found that this is happening through the NF-kappa-B and matrix metalloproteases pathway. By the way, we were among the first group to describe this in triple negative breast cancer cells, but many other groups subsequently show this high FASN expression, mainly in the triple negative breast cancer cells. And on the right, you will find the percentage of FASN positive in triple negative breast cancer cells and how that correlate with our finding as well. We then look at FASN expression and how it correlates to the chemo resistance in breast cancer patient. And this has been done with great efforts from Dr. Tahir Twajri, who's present here. And we found that FASN positive breast cancer patient who been given chemotherapy, they do actually worse than those who are FASN negative, both the overall survival and the disease-free survival. Now, this is a correlative study. How do we prove that this is FASN mediated? We went back again to our in vitro studies. We knocked down FASN in triple negative breast cancer cells, and we found when we expose these to doxorubicin in vitro, normally the FASN positive, they do resist or they survive much better than the FASN negative. We did also some in vivo study where we transplant these cells in animals, immunocompromised animals, and then we found that the FASN positive treatment of animals that are injected with FASN positive cells, they do worse than those that they are injected with FASN negative cells. We dissect the pathway also. I don't want to take you too much moleculars, but we dissect the pathway, and we found that FASN expression is activate one of the pathway that is known to activate the PI3 kinase. Mainly, it's called focal adhesion kinase, or FAK. And this, by activating this pathway, actually they suppress the apoptosis pathway, and they promote the anti-apoptosis pathway, and thereby they are facilitating the cell survival. Interestingly, subsequent studies show that there is a direct binding actually between FASN and FAK after we published this work. So the effect of FASN on this pathway seems to be a direct effect. Because FAK is known to bind to beta-1 integrin, and FASN and act through FAK, and also FASN bind to FAK. So we ask whether actually FASN affecting this FAK AKT pathway through the beta-1 integrin. So what we did is we asked if FASN do that through integrin. When we knock down FASN in triple negative breast cancer cells, we found that the beta-1 integrin goes down. So, and then what we did is we want to look at the downstream pathway, and we found that when we downregulate integrin in the FASN positive cells, I don't know whether I can, yeah, when we downregulate FASN, when we downregulate integrin in the FASN positive, then the FAK, I cannot move this. Then the FAK, phosphorylation of FAK goes down. It goes down also in the FASN negative, but it dramatically goes down in the FASN positive. Importantly, again, in collaboration with Dr. Tahir Twajri, we found a strong correlation between FASN expression and beta-1 integrin expression in patient, actually. This is like, I think, 137 patient. And importantly, patients who co-express high FASN and high beta-1 integrin, they do the worst among the other combination. That tell us that actually FASN activation of the beta-1 integrin promote the disease progression by decreasing survival. Another pathway we looked at, which is how whether the FAK AKT pathway, which is known to activate the beta-1 integrin, is also affected by FASN. To do so is we knock down FASN in these triple negative breast cancer cells, and we found both beta-1 integrin and the downstream target, which is T3 cyclin D, and CMYC goes down. When we activate the beta-1 integrin pathway with a treatment with GSK3 inhibitors, we found that we induce the beta-catenin and the downstream target in the FASN positive and the FASN negative, but always we see more of that in the FASN positive compared to the FASN negative. To prove that this activation of the beta-catenin is going through the FAK pathway, we basically, as you can see here, we look at the beta-1 integrin in the FASN negative compared to FASN positive. We induce it with GSK3. We see induction in the FASN positive, always more than the FASN negative. If we treat with GSK3 inhibitors and inhibit the FAK, then we could not see this induction, meaning that this induction is mediated through the FAK pathway. Of course, we look at the downstream target. Just for the sake of time, I will jump to the next slide. When we look in patient, we found always FASN co-suppression with FAK or with the downstream pathway of beta-catenin pathway. They always, these patients, they do the worst, as you can see here with the black line, you know. Importantly, if we segregate the data into FASN high and FASN low, we found that FASN always give advantage, of course, with the worst clinical outcome, compare to FAK and the downstream target of beta-catenin. We don't see that much if we look at in the FASN low group. We finally did a comprehensive transcriptional analysis studies, and we in triple negative breast cancer cells, and we found that there is 129 gene upregulated in the FASN positive and 114 downregulated. We look at the top genes that are downregulated and the top gene that are upregulated. And we found a lot of genes that are involved in regulating the cell proliferation, cell cycles, and apoptosis pathway. Importantly, when we co-express these FASN with the high expression of these top upregulated genes, or the low expression of the top downregulated genes, we see the worst survival, recurrence-free survival in the FASN positive group, as you can see here. Importantly, this significance increased dramatically when we look in the triple negative breast cancer cells. Both the hazard ratio and the p-value goes high in triple negative breast cancer cells. So in conclusion, I think FASN expression in triple negative, I convince you, it regulates key signaling pathways. And by doing so, it promotes the disease progression. And I think the FASN beta-1 integrin FAC beta-catenin signaling axis, I call it the axis of evil. I think it presents a novel therapeutic window for triple negative breast cancers. And I think there are targeting agents are actually right now in clinical trials. FASN inhibitors right now is in phase 1, 2 in advanced or metastatic solid tumor malignancy. And there is FAC inhibitors also in clinical trials. And there are more in the market right now. So at least I think, I hope I convince you that we should look into the expression of this markers next time, if you, especially in triple negative breast cancer cells. I'd like to, at the end, to acknowledge, this is the teamwork. I'd like to acknowledge the works that's been, the team that I work with, you know, especially Dr. Tahir, Dr. Dahish, Dr. Asma Talba from pathology. Thank you very much.
Thank you, all speaker. Excellent presentation. We will come at the end of this session. I would like again to thank Dr. Malkhair, successful and great organization. Congratulations, all winners. We will give 2 or 3 questions. Okay.
Now I would like to call the winner, number 1. Wait. Number 1 winner. Take picture with the whole committee, with the background of the committee as well. The committee member. You want to take picture for?
Yes.
Second winner, Dr. Jamal Zikri. And the third winner, Mohammed Al-Mutayri.
Very good presentation.
Thank you. This year, we received 32 abstracts. We select the most, what we agreed as a committee, they are the best top 4. But there are many of them excellent. So what we will do this year, we are going to do Bust of San Antonio, again, in collaboration with the United Arab Emirates Society, Oncology Society, Prof. Hamid al-Shamsi. And we will extend this abstract from the Middle East as well, will be reselected, some of them to be presented there, inshallah. The date and time, I will announce it later in the coming few days. And thank you, Prof. Lubna. Thank you, Prof.
Good morning,
Naj.
Dr. Khair.
Thank you for your being a member in the committee, reviewed the abstracts, and for your presence with us today. As well
I enjoyed
as
it.
Dr. Atlal. Thank you, Habibi. Now, Roland.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I'd like to start by thanking Dr. Khair for this excellent 16th Best of San Antonio symposium and conference. I would like to present the next speaker. Our next speaker is Mr. Anas Nofal. He's the Senior Director of Greater Middle East and North Africa region. He is based in Dubai, United Arab Emirates, and he oversees the business development and client relations, as well as the project management of all Axios healthcare access programs in the MENA region. Mr. Anas Nofal, if you could kindly...
Thank you, Doctor. Assalamu alaikum. Bismillah wa salatu wassalamu ala rasulillah. Allahumma shrah li sadri wa yassir li amri wa hlul 'uqdatan min lisani yafqahu qawli. I will speak in English, no worries. Thank you, Dr. Rula. Thank you, Dr. Khair, for the invitation. I have one disclose that I am under Brochure because I have only 10 minutes. This is the only brochure I have. So I will start with a question to refresh. Okay, I cannot move. I would like to start with a question to just refresh the audience. And we could get maybe one answer if the moderator allow us. How we could put an elephant in a fridge? Okay. Another answer? Sorry?
Or maybe cut the elephant.
Shrinking it.
Cut it in pieces. Okay, I could open the fridge door, put the elephant, close the door as well. What do you think? Good. So today I will speak about how we could have an innovative solution to be able to maximize the patient benefit. I am from a company called Axios. Axios is a healthcare consulting company. We have been specialized in something called access. Access, how you could let the right patient reach the right treatment on the right time in the right way. And we mean in the right way, in sustainable, innovative way. I am supporting a team, almost 200 warriors among 35 countries. And today, in specific, I will speak about two topics. So I don't want to go in details about Axios. So I'm skipping this slide as well, and this slide. And even this slide as well. Maybe I want to say something. All of you, and even us, we have recognized that outside the hospital is, if not more important than what happened to the patient inside the hospital. And this is very important usually when we want to think about serving the patient, how we could serve the patient outside the hospital setting. Because your patient visits you for 1 day or 2 hours or 1 hour, but they are at their home for 3 months. So how we could serve them when they are at their home. And I will address two main topics. The first topic, it is how we could understand the patient needs, and then how we could be innovative to address these needs and find the solutions. And the first topic will be, I could say, science-based. And the second one, it is Axios experience and point of view. So you could debate with me regarding that. Axios use usually two methodology to be able to define the patient needs. The first methodology, it is what we call the 5-dimensional methodology. You will not be able to serve the patient if you don't understand the need and you structure it in a way you could define a clustering or a grouping for the patient need. The 5-dimensional approach here, which is the socioeconomic dimension, the therapy-related dimension, the patient-related dimension, healthcare system-related dimension, and condition-related dimension. It's very important that usually we feel everything, it is the patient, and it is the patient's fault. And we have this feeling, especially with the compliance and the adherence. So if you look to this 5-dimension, you will understand that the patient need, it is beyond the patient awareness and education. And very simple example, I have a physician. He is a neuroscience physician, neurologist, and he treats almost 200 MS patients, and he's not compliant to MS treatment because he's a MS patient as well. So this patient doesn't miss education. He knows very well about the disease and about the treatment. And that's what I mean by it is not only patient related. If I have the time, I will tell you two stories about the 5-dimension where it is very important also to understand the sub-factor of the 5-dimension. Each dimension has 10 to 15 sub-factor. Second, it is how we could understand the patient journey. The patient journey, usually it is 6 stages. And when we say 6 stages, it starts by the signs and symptoms until the continuation of a treatment. And between each stage or each station, there is many steps. If we are not able to understand the 5-dimension and also to understand the 6 stages, we will not be able to define what are the patient needs. And if we are not able to define the patient need, we will not be able to define the right solutions. Why? Because we are in 2022. Customization and personalization is very important. We are talking about gene therapy. We are talking about customized and personalized treatment. Then we need also to have customized and personalized services toward the patient to address their real needs. This is how the patient journey look like. This is from a study conducted on 150 patients from multi-specialty, not all of them oncology or hematology patient. And each step, it could limit the patient go for the next stage. So it's very important when we are thinking about any service or about any solution to see, is this address one of the challenge we could face at any point of stage? To be honest, the challenge we have, who create usually the solution, they look to the challenge from their point of view, and they don't look from the challenge from the patient point of view. And here what we call the patient voice. We need to understand what are the challenge based on the patient point of view. Sorry, not based on the physician. The physician could have the same point of view of the patient, but again, we need the patient voice, not from the pharmacist. Again, I'm not saying we don't need to listen to the pharmacist or the physician, but if we want to consider solution, we need to have the patient point of view. And to be able to have the patient point of view, we need to understand the 5 dimension and also to understand as well the patient journey. Maybe I will go more in details about, okay, we understand the patient challenge. We understand what are the needs, what could be the solution, and how we could have innovative solution. To have innovative solution, and this is what I start my my speech by saying, okay, how we could put elephant in the fridge. Simplicity is very important. Usually when people start to think about solution and to call it innovative solution, they think it should be complex, which is not always the situation. Even if you think out of the box, you could think in very simple way and still you get the same result or more impactful. Give permission, and here I mean give permission, you need to imagine as well. And I recall in the brainstorming, they tell us if you want to start imagine from the environment around you. Look to the people, look to the floor, look to the walls as well. So you need to give permission to your imagination if you want to be innovative. The third point is to give it a structure, and I mean here in a structure, you need to have goal. Why I want to do that? What's my objective? What I want to achieve from this solution? So if you have a clear objective, why you want to implement this solution, you will be able to create very impactful solution. Third, keep it at it. And here I mean you need to ensure that there is nothing perfect. And this is what we face as a challenge in innovation. You go and you address your solution or your innovative solution, and you start, a lot of people start to asking you a question where it could be a challenge for you. Usually also, which is very important, now we understand how we could be innovative. What I need to consider in specific when we are talking about innovation for patient services, there is a 3 pillars you need to consider, and there is 3 countries now. They put these pillars as what we call part of their framework and policy. The first pillar is maximizing medical benefit. If your solutions will not maximize the medical benefit, it will be rejected. Second, which is very important, it is the financial and operational sustainability. And I mean the financial sustainability, you could have a solution, but this solution, it's too costly. So you could shut it down after 6 months. So because of that, you need to ensure as well that you have a solution which is sustainable from financial point of view. Third, you need to ensure your solution, it is compliant with the local and international regulation as well. What I want to say, that one size doesn't fit all. And as we are saying about personalization and customization, we need to ensure that any solution, including these 3 pillars, should be personalized and customized as well. I will give you just a head up of 3 solutions we have implemented in Greater MENA area, and it works very well. And here what I mean in simplicity. The first solution, it is about, we have in RCC, TKIs, usually it do food syndrome and patient could stop the medication because of such side effect. So what we have done, or what usually they do, they try to educate the patient how to manage such side effect, but still patient stop because of such side effect. So what we have done, we have sent someone at the patient home, and we call it Badukir and Monokir, or whatever it is you call it, ladies. I don't know the pronunciation, Badukir and Monokir, and it works very well. We have increased the stay on a treatment and the DOT, the duration of a treatment, to double. So instead of 3 months, and this has happened in one of our beloved country, in Lebanon, to 6 months. Access to diagnosis, and access to diagnosis, access to diagnosis, usually people think that if I have done the screening, I could increase access to diagnosis. There's a lot of issue and challenges associated with access to diagnosis, or the diagnosis journey in general. We have a project where the challenge was that patient has to jump from hospital to a hospital, and this happened in UAE. And we have been able to diagnose the patient with a 3 to 4 months, where normally even the data is showing that it takes 2 years to diagnose the patient. Peer-to-peer app, or what we call it Access Plus. A lot of apps are in the market, and it is target a lot of patients, but usually the challenge that there is no utilization. In Malaysia, for example, they have a patient app as a reminder, but the utilization means how many one use the app. It is 11%. In other app, it is 30%. So to be able to have a technology which to be utilized by the patient, you need to ensure that this technology, it is very interactive, it is proactive, and also the patient enjoy it. If the patient not able to enjoy it, they will not utilize it. And the example here, in MS patient, we have give them a game where this game, it is enhanced memory, because most of them, they suffer from memories issue. How I could measure the innovative solution? We need to look for 4 areas, and in consideration, I could say increase compliance rate. And compliance rate here, if patient has to take 100 tablets over 100 days, they take all of them, which is 100% compliance. So if our initiative be able to increase the compliance rate, this is showing the success and of the program. If we are able to decrease the dropout rate, and the dropout here, I mean, it is the patient decision to stop the medication without going back to their treating physician. Third, which is very important, it is shortening the diagnosis journey. Diagnosis journey these days takes 6 months, 1 year. If we are able to make it 2 months, and here I am talking in general, but any solution targeting access diagnosis, if we are able to shorten in the period, in this case, we have a successful program. What I want to say, our ultimate goal from all these initiatives is how we could enable the patient to cope with their disease, and how they could utilize the tools we give to the patient to be able to fight this disease as well. I could see that it is humble attendees, but you will have the chance to learn. I don't use, to be honest, to speak behind the stage. So I usually carry my mic and go around. بعد ما خلصت يا باشا. طيب. So how many minutes left for me, or already it's done? Okay. So This, what Majdurin is giving to you, it's a very international game called Marshmallow Challenge. And Marshmallow Challenge, it's an interesting challenge. Usually they give it in Harvard for executive program. And I have the chance to get trained, not how to build, to eat the marshmallow. This challenge is asking you by this spaghetti stick, that's fine. By this spaghetti stick, you have a spaghetti stick, how you could build the highest tower. And then you put the marshmallow on that. You have tape and you have as well sting, so you could use it. What it is interesting, when they have, there is thousands of people has played this game. And usually, who are the winner are the kids. You know, and I believe, yes, it is in the slide. You know why it is the kids? Because they just build. And this is what I mean by innovation. Innovation, you need to start. If you start criticizing your idea, you will not start. And this is what the kids, they do. They just start building and build, build, build. Where the executives, you have 7 points of views, and each one has to do it differently. Then you have the engineer, they are a planner. So the planner, they need to sit and okay, how we could do it. And usually time end before they start build. What I want from this marshmallow challenge, it is very nice. You could give it to your kids and you compete with them. Each one has an innovator in his brain and heart. And if you have the core value, or what we call the spirit, and the spirit that really you want to serve the patient, you will start yesterday with an innovative solution. I have almost more than 300 ideas. It saves a lot of patient lives. But it is only about you have the intention and also you have the framework. We are more than happy. I have a lot of slides about how you build a patient support program. We have an academy, we will launch it soon with Ministry of Health here in Saudi, how we build patient support program from A to Z, where maybe after that we could see who built the highest tower from this sting and the spaghetti stick. Thank you.
Thank you very much, Mr. Anas Naufal, for this elegant presentation. And allow me to ask you maybe a few questions, if you don't mind. So I'm familiar with the Axios program, and we have started to have with Ms. Majdurin some patients adopted in this program. So in real life, you know that our society is very complex, our patients are very complex. Just making it simple, for example, for my patients who are receiving, let's say, LHRH monthly injections. So what are the services that Axios can provide and help in with this patient, elderly patients with multiple comorbidities, social issues, financial issues, psychological issues? So just in a few words.
Perfect. So I will return it to the 5-dimensional. Socioeconomic dimension, you need someone to hear you and to listen to you. So we do what we call psychosocial service. When we are talking about healthcare system, we could talk about home care injection. So we go to the home and we give them the injection at the level of their home. So they don't need to go to the hospital every month. Or if they need any diagnostic test, we could do it also at the level of their home. If we talk about disease-related dimension, some disease, it is connected with, let us say, what we call depression. So we do what we, life coaching, we do mindfulness for the patient as well. If we are talking about also disease-related, We have very innovative education related to the disease, not only to the patient, also to their ecosystem. I mean, maybe to the daughter, to the son, or to the husband, or to the wife. If we talk about therapy related, one of the most important part in the therapy related is side effect management. So we help the patient to manage the side effect. As we said, if it is tablet, we do the reminder. If it is injectable, we do it at the level of the home. This is what I have in mind, but I want to tell you something. In Axios, I don't know what they call it. We have a program where ankylosing spondylitis patients, they are rejected by the society. So we introduce ankylosing spondylitis to ankylosing spondylitis patients. So at the end of the day, innovation, the limit is the sky. It's just about you have the patient centricity in the mind.
Amazing, amazing to hear that. And actually, I was dreaming when I was living in France. I lived there for 7 years, and I was dreaming to come back home one day and find services provided to patients at the level of their home. Just a final question, if you allow me. So we know that we have limited resources. How are you planning on doing that? Are you outsourcing the services to other companies or nursing services? How are you planning to do that, to provide the services to millions of patients in Saudi Arabia?
Good, good. There is the most important part. Well, I don't want Dr. Mulkhair to get upset from me. So what I will answer you, if you remember in my slide, I said financial sustainability. So no worries about that. When we build any program, we look to the financial sustainability, where if this program starts, it will not end. We have, it is a framework, how you build the resources, but all it will be in-house. It is not outsources. So we are building a big team in Saudi, in Jeddah and also in Riyadh.
Thank you very much. And I hand the mic to Dr. Mulkhair. So we will pass to the next presentation. Thank you so much for this elegant presentation.
Thank you.
Now we will move to the satellite symposium. During this break time, which is lunch, you can bring your lunch, it's lunch boxes, and you can eat. And we will start the satellite symposium first with Pfizer. My honor to introduce Dr. Prof. Jane Mark Nables, who will present the first satellite symposium for Pfizer.
Thank you very much, Dr. Mulkhair. So I will try to speed up a little bit to gain some time. I'm going to talk about real world and pooled analysis of palbociclib in breast cancer. In fact, we know clinical trials very well. I think some of us in the room have done a lot of trials. But what is real world studies bringing? And do we need both, actually? In fact, when we look at the registration trials, the phase 3 trials, really asking specific questions with a high methodology, very high level methodology, we get information like here in the Paloma 2 in terms of progression-free survival, which are showing significant differences here. And these data are very strong in terms of methodology and potential conclusive effect you can get from there. So the randomized clinical trial, well, they really look at the efficacy, safety in a well-defined population, and this is very important to notice. They are showing causality, so really the link between the effect of the treatment and the outcome. Randomized protocols are developed in a very strict way. A statistical methodology is explained, and usually patients are randomized. It could be non-blinded or blinded. And the patients are followed very, very strictly with criteria which are usually verified, and the outcome actually is monitored and validated. So these trials are very powerful to ask one question. There's been a tendency in the past to try to ask multiple questions because the sample size usually are high. But from statistical point of view, usually a good trial is one question, well done, and you can answer. Then you can use other results to generate hypotheses and go beyond that. The real world observational studies, they're actually going to measure effectiveness and safety of an intervention. But in fact, the problem, they are not causality. I think they are just going to give you potentially hypothesis generating processes. And from there, you are going to look at outcome in a non-randomized process, usually retrospective process on large databases. This program has become important because the regulatory agencies today are liking, in fact, this type of approach, because in fact, when you start to look in the population, you might understand efficacy, but also safety, I think, on a large scale, and the way the medications are being used in clinical practice in the fields. It can bring to some interesting aspects. For instance, here, I will show you data at the end of the presentation. Male patients, usually with breast cancer, it's very rare. So there are no prospective clinical trials asking questions in male breast cancer. It's impossible to do. These approaches that we are allowing us to give an idea. In fact, it's not as powerful a clinical trial, but it gives an idea. And for instance, here it led to the approval by the US FDA of palbociclib in men with luminal HER2 negative breast cancer. So real world data are interesting also because they can give you some information about the change of practice. And for a long time, first-line metastatic luminal HER2 negative between here, 2002 and 2012, around 60% of physicians were using hormone therapy, but still we had a lot of chemotherapy. 2017, the analysis through a large scale process showed, in fact, a change, significant change. We were giving a lot of talks and information saying, well, the international guidelines are saying start with, in hormone sensitive population, first line metastatic, start with hormone therapy. And then you are going to exhaust the hormone sensitivity, and then you go to chemotherapy. And you see on the right here, clearly a change. I mean, chemotherapy went from 40% of strategies in first-line metastatic to 13% in 2017, so which is significant improvement in the situation. And this is allowing us to actually understand. So we are going to look at very quickly at the overview of the study with palbociclib. There's been a bunch of studies around more than 250,000 patients prescribed worldwide since the approval in this analysis. Four body of information: the IRIS trial, which is a retrospective medical chart review and a multi-country, mostly US, Argentina, and Germany, so 3 continents, in fact. Flatiron analysis, retrospective analysis again, but from a database comprising more than 2.2 million cancer patients, so it's a humongous in US. Polaris, which is a prospective non-interventional studies made in US and Canada, and in fact the expanded access program in US, but which stopped very early because the drug was actually approved. So then the expanded access program stopped. There are some programs outside in GCC, the Treasure program and the Pressure study, but we don't have the data at this point. See, the IRIS program, as I was saying before, is a retrospective medical record review, 3 continents. The physician to be eligible, must have been oncologist, hematologist, or gynecologist, treating, in fact, breast cancer with luminal HER2 negative profile. Patient eligibility, well, a patient more than 18 years old, pathology confirmed, breast cancer, luminal HER2 negative confirmed, and receiving palbociclib according to the labeling, the labeled indication. When you look at the some information, in fact, and comparing the countries is quite interesting because you look in terms of disease site comparing non-visceral to visceral. the American continent was relatively consistent with each other, but in Germany, in fact, majority of visceral disease, interesting, while in North America was the majority of non-visceral bone disease. When you look at the grading, at the ECOG performance status, again, there were differences. America's very similar, and in Europe, more patients with performance status 0-1. Starting dose, I was very surprised by that, actually. Starting dose, as you can see, I wasn't aware that the starting dose at 75 or 100 was something to do, because we know the toxicities are not that dramatic. But I was very surprised that in US and in Germany in particular, I mean, when they use palbociclib and fulvestrant, I mean, 1/3 of patients, they started at 100 milligrams, which for me was quite a surprise. But this is something you see in the real practice, actually. It is true that there has been some issue with the neutropenia, palbociclib. We have seen that even in this region. I mean, sometimes I have seen people manipulating the neutropenia toxicity, not within the guidelines, the approved guidelines, and here it's probably the same. Dose adjustment is something interesting, because are you decreasing the doses and which frequency according to the, as you can see, those decreases are, the maximum of 20% of the population, and sometimes even significantly less, in particular with fulvestrant. So interesting information here as well. When you start to look at the response, it's becoming difficult, because response is not a hard endpoint. I mean, it depends a lot on the interpretation of the physician looking at the radiology or looking with his eyes. I see very high clinical benefit. I was kind of surprised, I think, but there might be selection of patients. So overall, the message here from my point of view, there is efficacy. I mean, I cannot say that I would not focus on specific numbers, but when you look at complete response, partial response, well, you are in 70 something, so which is, I think, probably overestimated by the selection of patients. So interpretation of results, not completely professional or unblinded, but anyway, it's showing it's working. When you look at progression-free survival and overall survival, well, it's a little bit easier to assess when tumor is progressing. You can see, so you can see that there is efficacy. I think the progression, I look at 24 months, you didn't even reach 50%, which in randomized trial, the median usually progression in the registration trial, first-line metastatic, is on 24 months. So we see that there is some consistency, a little bit more optimistic. Again, maybe a selection of patients. Survival, same thing. I mean, it's just for indication, but you can measure this. And when you look specifically at the progression-free and survival in US only, so it's really a 12-month progression, you realize that if you look at the first line and second line, results are pretty good. So there is efficacy, I mean, clearly. So the conclusion of that really is bringing some interesting information in terms of patterns as well as in terms of efficacy and toxicity. The Flatiron study is kind of interesting. It's a comparative effectiveness of palbociclib plus letrozole versus letrozole. It's not a randomized trial, but it's a comparison face-to-face between those two in US real-world clinical practice. So it's a large-scale program. A patient, again, a luminol HER2 negative in first-line metastatic over a period, analysis over a period of around 3 years, around 1,500 patients. Palbociclib letrozole was close to 800, and letrozole alone more than 600. So you have decent cohorts. The outcome was looking at the real-world progression-free survival and the overall real-world overall survival. So one-to-one score matching. I will explain to you a little bit. I mean, the statisticians are playing, because you look at the data, indeed, they are not consistent at time of accrual in the study. And then there are some tricks, statistical tricks. Although I'm a statistician, I'm very careful with the statistical tricks. So I'm also a medical oncologist. So I'm really careful in the interpretation. when you look here, there are two tricks actually which were used, which is stabilizing the probability of treatment weighting. I mean, we know that has been used for the aromatase inhibitors, in particular with letrozole. I mean, there were some tricks we use here, and propensity score match analysis. They are slightly different, but the end goal actually is to try to harmonize the two groups. Well, it's not randomized, so they try to, and they give weight to some of the factors in order to try to harmonize as much as possible. So this is the main principle. I don't have time to go into the detail. For instance, the stabilized inverse probability of treatment weighting. It's in fact you weight, you have in fact characteristics, and you for patients, and you are going to give scores and try to balance. So some of the score could be more powerful than some other one, and then you try in fact to get in fact two cohorts which have balanced characteristics. But that's a statistical trick, and you need to be very, very careful with interpretation of this data. So when you look at the real world PFS here, you look at it and you have three type of results here in the slides. On the left is the unadjusted analysis. When you look at the unadjusted analysis, where you look at the hazard ratio, you are in the range we know from the randomized trial, in the range of 0.5, which is now well known. When you look at IPTW adjusted analysis, well, there are some modifications. In fact, the hazard ratio are slightly different, not massively different, you can see here. And the adjusted, PSM adjusted, yeah, the PSM adjusted is same thing. So there are some slight variation. The goal being to say, well, in fact, from a medical point of view and statistical point of view, well, it's very similar. I think there are some variations, but the variations are not that dramatic. I mean, we are all in the range of the between 0.5 to 0.6. Which is consistent with what we have seen for the randomized trials. When you look at overall survival, the same exercise, although yet we are only having emerging data in the overall survival in advanced breast cancer. But you can see you are on the unadjusted, you are in the range 0.6 to 0.7. And when you look at here, the adjusted is a little bit more advanced, I would say, but still in the same range. So what I'm saying is there is some consistency, which somewhere is slightly more advanced than what we're getting from the randomized trial, because randomized trial, we need to really wait to have really the confirmed data. So I found that kind of interesting, in fact, and but you just get some global high-level information, which somewhere are consistent with what we have seen in the randomized trial. So the applicability coming from the field is actually reassuring. And I think the regulatory agencies, they start to lack this type of information, because it's somewhere giving them on a different scale that the results from the randomized trial are actually applicable in practice outside of these controlled trials. Well, then there are other trials, the palbociclib, the Polaris, which is palbociclib in HER2 positive advanced breast cancer, multicenter prospective non-interventional study. Here, the goal was slightly different. It's more look at standard of care data collection, but look at quality of life information. They also look at they took some blood sample and look at potentially some biologic information. When you look, you can describe the population here in this type of program. Not very wide, I think 412, this is not too much. Patient who got at least 6 months or more of treatment. And then you look at the characteristics of the patients, giving you some information on the, when you look at the endocrine partner in first line, 46% of patients where they were first line and they use aromatase inhibitor with palbociclib, while 27% use fulvestrant. So it's giving an information. I mean, fulvestrant, the randomized trials initially were mostly in second line metastatic, and first line metastatic was AI trial. but you need to realize that when you develop a drug, you go to the regulatory agency, US FDA and EMA in Europe, and you show them the trial, and they are saying they like to have the standard of the moment as control. So all these first-line metastatic, they had AI as standard. It was CDK4/6 here, palbociclib plus AI. Second line, the standard was Faslodex. So a lot of the trials were Faslodex. The problem in between, Faslodex is getting up in first line. So, so today, this is reflecting somewhere the practice, which is looking at the process after the randomized trial being initiated. So that's something you need to realize is important. Second line, same thing. I mean, we have the balance, but here the fulvestrant was more frequent. Then when you start to look at the type of metastases, ECOG, menopausal status, no big surprise, because in the West, menopausal status, a lot of postmenopausal ladies, we know that. I mean, this is not a big surprise. When you look at the disease, a lot of non-visceral, I mean, close to 3/4, I mean, a little bit less. And then when you look at at bone metastases, you have bone only, quite high, actually, which is well known in the West. So this is not very surprising. Again, starting dose, very interesting, but here more 125, virtually none at 75, very little. And then when you look on the right, in fact, it's kind of very interesting here, because the dose modifications, actually, on the right, in a kind of a cross thing, you have what was seen in the randomized trials, actually. And the percentage of dose modification was very high, because the criteria was extremely stringent. And you look in practice, I was very surprised by this information. You are barely at 30%, I mean, around 30%, while in those interruption is double, actually, in the clinical trial. So it was very interesting information here. Adverse event, no surprise, neutropenia is seen to be the main side effect, so we know that. So there is no problem there. And when you look at the effect of, that's an information which was, I think, important from this trial. This is one of the main information I'm actually getting from this program. They looked at elderly people. I mean, elderly in brackets, more than 70. In some years, with hair will be there, and we don't believe we are yet elderly. So anyway, so they look at more than 70 years. We're not yet there, but that way is coming. So just showing that, in fact, the tolerance and the quality of life, in fact, in those elderly people, was not affected, in fact. So that's something which is important, because we had at the beginning a lot of the trials, they were not having a lot of elderly, the 80, 85, something like that. Here we saw it. So that's a very interesting information. So in fact, so potentially we can say that it is safe to give this drug to elderly people. So same thing, quality of life here after 6 months of palbociclib in elderly people, so no significant impact. The expanded program are going to be very quick. I think it's a really limited number. It was stopped in US relatively quickly because the drug was approved. As you know, in US, they approve the drug quicker than everywhere else when they believe it's potentially working. So I'm passing that. Palbociclib in combination with letrozole here, dose intensity, well, it's showing that overall in this type of program, there was not a lot of decreased doses, so which quite interesting, 90%. Okay, adverse event, again here, when you look at the bottom, there was some significant adverse events somewhere, but not, I found that the results were showing that they were not that frequent, which, so is it from the fact that they didn't start all of them, those at 125? Well, maybe, so we cannot conclude more than that. Long-term follow-up, PFS and overall rate, well, this is in keeping first line, second line with the observation we had already in the other program I showed you. Well, and then what you can do is looking at patient satisfaction, quality of life. I mean, this is a kind of interesting process here, processes here. This was done in multiple countries. Again, a web-based cross-sectional survey of 450 patients in the US and Canada. Again, the criteria were more than 18 years of age and luminal breast cancer, HER2 negative in a metastatic setting, receiving palbociclib either with AI or with fulvestrant. So in the country depended, I mean, in Canada, for example, palbociclib letrozole was actually the treatment. They didn't use Faslodex. And they gave a 38-item questionnaire in which, in fact, 3 aspects were looked at. The expectations of therapy, the feeling about side effects, and the satisfaction with therapy. So it was, and when you look at the results in the patient satisfaction survey, US, Canada, and Germany, so 3 different countries. You looked at the expectation therapy score was very high. I mean, I was surprised, 70%, or 70. The feeling of side effect score was overall more than 45, and the satisfaction therapy score was very high. Score above 70 and quite consistent between the countries. So there is not big difference between the countries. So showing that overall this is well tolerated, because as soon as you have too many side effects, the satisfaction is not there. So, so it was interesting information. So 90, I mean, close to 94% of patients indicated that they would probably or definitively take palbociclib again. So, which is very interesting, because if you give them chemotherapy, usually they don't want you to, they are very leery to continue the same treatment. Males, that I was saying to you, males, this led to the approval by the US FDA of palbociclib in male patients, while there was no trial, no prospective trial. I mean, impossible to do. So they really look
minutes and we'll be back online again. Sorry for the interruption.
meta-analysis in my mind are the same thing. I mean, you take various trials. I was interested to show you, because although I'm not fanatic of meta-analysis, and as a statistician, I don't like it. But the comparison of palbociclib in combination with letrozole or fulvestrant with classical endocrine therapy. Well, when you look, this is a network meta-analysis, I mean, a very large, you look, I mean, it's a very small, but globally speaking, it's confirming what we know from the randomized trials, actually. Because when you look at palbociclib plus letrozole compared to letrozole, clearly the PFS, there is a large benefit, which is corresponding to what we know. And whichever type of hormone you take, and even compare no CDK4/6 to whichever hormone, with whichever hormone, you find very closely what we have seen in a randomized trial, indeed, and it's a large scale randomized trial. So, systematic review of network analysis comparing palbociclib with chemotherapy agent for treatment of postmenopausal patient with luminal HER2 negative metastatic breast cancer. It's clearly showing, when you look at the hazard ratio on the right, 22 randomized trial, first line setting here. Virtually, overall, it's better to start with hormone therapy, in particular with CDK4/6 inhibitor, as opposed to chemotherapy. This is something we know now, we have applicable, but it's nice to see these, all the trials are there, which is very interesting. Second line, same thing. We see either monochemotherapy or polychemotherapy. So 44 randomized trials here. So it's confirming that our practice today, actually, at least for me, but some of our friends, is based on these results. So in conclusion, I think I will have 1 minute 45 left. So, so real world data. At the beginning, I was kind of leery. I mean, I was looking at this, but in fact, it's providing some very interesting information, the specific type of information. And it's not a randomized trial. You cannot conclude the same way, but it's supporting somewhere in the world, in the practice outside of clinical trials, some evidence, and it could help in some aspect to draw some conclusion, or at least to like the males in so it helps there. Indeed, there are methodologic limitations. I mean, I don't have time to enter into them, but they are not randomized trials, I can tell you. In the Middle East, well, can we apply completely? Well, globally, probably yes, I would say. However, the population we have, it would be very interesting to see the data from the Middle East, from GCC countries, because our population is significantly younger. The proportion of younger patients is much higher. We have more de novo advanced disease. I mean, the West, first-line metastatic is 7%, and so it's very low. So, and safety, same thing. I mean, safety. We did a randomized trial with palbociclib in neoadjuvant setting. We published the initial data, and the final data. The manuscript is going to Journal of Clinical Oncology. It has been sent, where we have prospective toxicity data in the region, so which is prospective. And I can just tell you, without, in fact, we are very close to what we have seen in the West, and far from what was observed in East Asia. So we are much closer to Europe and North America than Japan and China. So they significantly less than in the Far East. So overall, I think this is kind of interesting to look at it and taking it for what it means, but not more than that. Thank you very much.
Thank you. Thank you, Prof. Naples, for this comprehensive overview for the real-world experience. And we can take one question. Dr. Abdullah.
Thank you so much, Prof, for outlining the real-world data. I was wondering, when you look at the tolerability, the toxicity, it's looked like that we are seeing less dose modifications, discontinuation in real world compared to the clinical trials. And probably we know that when it comes to palbo and probably also ribo, the same thing, we have the dose limiting toxicity, probably the bone marrow, especially the neutropenia, And we know this is not really quite serious because very rare we do see febrile neutropenia, and most of us in real world, we don't really make more kind of discontinuation and probably few adjustment. I was wondering whether this real world data could be reflected on the clinical trials in a way to have more or less restrictive criteria for adjustment. And this is probably the issue that we have with the clinical trials, especially the adjuvant where we have more discontinuation rate. Would this provoke something to do with the clinical trials?
Yeah, I think you are right. I think at the beginning when you develop a drug, you are very careful with the safety profile because we have had some bad surprises in the past. I mean, in hormone therapy, the development of AIs in metastatic, we didn't see the bone problem. Because we're giving the treatment at that time for a period of 5 months, 6 months. So the osteoporosis was not yet installed. When we did the randomized trial adjuvant setting, we were giving the treatment for 5 years. I was co-chairman, I was vice chairman of the ATTACK trial, so anastrozole versus tamoxifen. We were more advanced than the other trial. Well, at 3 years, I remember we had a meeting in Lugano, where in Switzerland, where the rate of fracture was like, at some point we said we're going to stop the trial. I mean, we were completely stunned, actually. And we warned the guys doing trials on letrozole and exemestane, saying careful. Immediately, we worked on understanding very quickly what was happening. We really introduced some preventive action, which solved the problem. But we were very, very careful. So here is the same. Neutropenia in the psychologic program of medical oncologists in breast cancer is difficult to manage because we are thinking about neutropenia from chemotherapy, from docetaxel. I remember when I was developing TAC, I mean, the proportion of for neutropenia was extremely high. I mean, I was close to 100% actually, and febrile neutropenia 25% without GCSF. But the death rate was very low. But still, I mean, we had to use GCSF. We did randomized trial with that BCNG004, in which we showed that with that there was no big problem. It was like giving TAC, it was like going FAC. But despite of that, TAC had a lot of problem to be worldwide accepted. We're more using sequence, which is while the results in terms of efficacy were the best ever obtained. I mean, 5% absolute improvement of survival at 5 years. So in the psychological aspect of medical oncology, neutropenia, this is why here, when they started to see neutropenia, they say, ooh, neutropenia. So the guidelines at the beginning were very strict. Too strict. I mean, day 14 you have to do, and blah, blah. And people were thinking it was going to be like chemotherapy. Well, in fact, not. So that's the reason why the initial you find only what you look for. So if you do nothing at day 15, you are going to see less neutropenia. What we know today, it's a benign neutropenia. So now I agree. In clinical practice, people understood. I mean, I have a lot of friends who are using diesel like all of us. They understood it was nothing actually. When you have done TAC, neutropenia management, and you have this, it's a joke. So now in the trials, you are right. I mean, we should be looser in terms of looseness, in terms of neutropenia problem.
Okay, Prof. Nabels, do you have any idea about the project? I remember Pfizer, we started to collect the data from Saudi Arabia on the use of palbociclib. Do we have any results on that or not?
I've seen nothing so far. So hopefully, inshallah, we'll get something. It will be interesting to see.
Yeah, to see our, like, for example, dose modification, is it higher or less than the other real world experience?
Well, you have to be careful because even in our prospective trial, which is a control, but you cannot control people when they are in the clinic. We have had another decrease of doses. In some cases, when we looked at the data, we validated the data actually. When we did monitoring validation of data, we were very surprised to see that some investigators decrease the doses while the criteria put in the trial, they should have not actually. So we may overestimate actually the dose decrease because if the applied guidelines are not applied, you are going to overestimate. So it will be an interesting information to maybe do some education and say, well, follow guidelines because it's not that dramatic, in fact.
Okay, thank you, Prof. Nables. And now I'll call Dr. Abdullah Tuergi.
Thank you so much, Dr. Al-Khair. So we'll switch gear now from hormone positive to HER2 breast cancer, from Pfizer to Roche satellite symposium. With this, I would like to invite our speaker for this satellite symposium topic will be Dr. Ahmed Al-Wabari. Dr. Ahmed is a medical oncologist at King Fahd Specialist Hospital in Dammam. He will outline the data about the HER2 positive breast cancer and how to improve our experience with anti-HER2 treatment. Welcome.
So due to time, we will be really very brief. This is a commercial talk, so you will not hear much of data on the trials, the original trials. This is the agenda. Background, and we'll talk about the agents of concern today. So the recombinant hyaluronidase is an agent that was produced by Roche. It's a vector for the medication to be injected in the sub-Q compartment. What it does, it hydrolyzes the connective tissue and it allows the connective tissue space to expand. It's a reversible, short-acting with a short half-life and transient effect. So this is essentially what it does. It hydrolyzes the connective tissue in a sort of a reversible form. So a 10 cc injected under the skin without the hyaluronidase will cause a bulge, while with the enzyme hyaluronidase, essentially there is no bulge. Now, sub-Q Herceptin has been there for a very long time. We've been using it certainly in our center, for instance. We've been using it for 5-6 years, and that was based on the trials, and that I will present one of them that showed the equivalency or non-inferiority trial between the sub-Q Herceptin and IV Herceptin. So we know that the IV Herceptin has been there for 20 years. Sub-Q is a flat dose, 600 milligrams, not based on weight. And what it does, it's just basically 600 milligram, you give it every 3 weeks. The HANA trial tested in the early breast cancer. The primary endpoint is pharmacokinetics here. So between the IV and the sub-Q, it showed non-inferiority in terms of pharmacokinetics efficacy as well as PCR rate, which is a co-primary. Now, 3 years event-free survival, total PCR were the same also in both the IV and the sub-Q, with no change on side effects, no new signal in side effects, or with cardiac toxicity. Let's move on to the other format or formula here, which is the Perjeta, pertuzumab, and trastuzumab in one injection. And this combination have been used in multiple, it's a routine practice in Neosphere, Affinity, and Cleopatra. So in the neoadjuvant, as well as the adjuvant and metastatic, we all use the combination of trastuzumab and pertuzumab. And in the IV form, it roughly requires at least 2 hours to inject trastuzumab and pertuzumab without even the observation. If you keep a patient for observation, that's an extra added time. And obviously, these are long-term treatments, so you almost always need IV access in form of ports. And if you have 500 patients, you need 500 ports, and they will be changed every 2 years or so with their complications. So the lines and complications and vascular access has their own problems. Based on the experience with the sub-Q Herceptin, Roche goes also the same story. There is no change in side effects. These are the side effects that we have known, the combination that have been used doing for very long time. And as far as cardiac side effects, also there isn't really any difference in terms of side effects between the IV and the sub-Q form. Now, any time we add a compound to a, for instance, the hyaluronidase or the hyaluronidase with both pertuzumab and trastuzumab, we run the risk of developing antibody or drug antibody that neutralizes the medication that you're given. So here's the emergence of antibodies less than 5%. And in fact, the emergence of antibody did not change the rate of PCR. So even though there is detectable antibody, it didn't change really the PCR rate in both the IV and the sub-Q. Now, the Francesca is a trial that it's in the adjuvant setting of pertuzumab and trastuzumab. Basically, it's in a crossover trial. Those who started with IV changed to sub-Q and the opposite. And then at the end of the study, they asked the patient preference. It's a preference study. And it showed that 85% of patients, all patients actually preferred the sub-Q over the IV. Around 15% they said no, they would like to stick to the IV form. And then the last trial that I would like to mention, this is the Metaphor trial that has, it's actually comparing the IV and the sub-Q in Cleopatra setting. And I don't have much to say that basically we still need to have details about this trial, but in general, it gave similar. The primary results here are similar in terms of safety, tolerability, but the progression-free survival. I don't have much data. The exploratory PS investigator-assessed PFS seems to be the same, as well as objective response. So this is a medication that actually improves the experience and lessens the time to inject. For instance, our infusion area in our hospital cannot tolerate the number of patients that we have. So IV form takes time, and then the sub-Q format help us treat more patients. Remember, 5 minutes per patient versus 2 hours. It really makes a huge difference for the patients and the healthcare facility. With that, I'd like to stop here and thank you very much.
Thank you so much, Dr. Ahmed. Probably because of the sake of time, I think we can have only one question. Probably I will start with this question. So I was definitely having a sub-Q formulation from an IV. This is innovative by itself, and having 2 drugs also that we use for common indications in a one sub-Q formulation. This is also another innovative approach. Short duration in the chemo unit, it's also another important experience, also another issue, another also benefit. I was wondering about, because this is kind of a fixed flat dose, I was wondering about, is there any weight limitation for those patients? Do we have any range or any restriction?
That's an excellent question. The patients who are morbidly obese are still under question with the fixed dose. In fact, I was looking at this specifically for sub-Q Herceptin as well as for Fisgo, and those with morbid obesity, we probably should stick to the IV format. Otherwise, in patients who are in average weight, this should work fine.
Thank you so much, Dr. Ahmed. I think we will conclude from our symposium. I would like to invite Dr. Tahir. I think you are with the next satellite symposium. You have the topic. What's your topic? Yes, so with this, I would like to invite Dr. Tahir Tuwajri. He will give us his talk about the PARP inhibitor with the AstraZeneca symposium.
Hello. Can you just? Where is the share? There is no. السلام عليكم ورحمة or they discover the BRCA mutation in breast cancer. And in fact, the first patient in Canada was my patient in February 1996, where we tested for BRCA1 and BRCA2. At that time, we are learning about this, and that patient turned to be BRCA negative. And Canada may be the first country, who is strongly now at the present time involved in the PARP inhibitor in general, including the clinical trial. First of all, this is my conflict of interest. Number two, just always I am go for clinical part. If you are looking for the gene or the major gene associated with increased risk of breast cancer, we have BRCA1. And as you can see here, the incidence or the breast cancer risk close to 85%. But importantly, and we are very sorry in this country that we are not testing for very important one, which is the BALB2. And in fact, if you have a patient with the BRCA1 and BRCA2 negative, you will stuck with the BALB2. And BALB2 has been shown today as good as BRCA1 and 2 to give olaparib. So, we have deficiency, at least in this country, to look for the BARB. Now, once I have a patient who is negative, I declare to them, I don't have the BALB2, go and find, we're going to test it. And in fact, when we are looking for a couple of patients, went to United States and they did again, the genomic profiling turned to be BALB2 positive, and they offered them bilateral mastectomy. So this is the first lesson from today, that still we need to know about the BALB2. Very, very important. So tell the patient the truth if you don't have it. Number two, slide is very important. When you are looking for the FDA approval of the PARP inhibitor, the one that we have is olaparib, ovarian, breast, pancreas, and prostate. And then the second one, which is very interesting, is talazo, which is known as talzenan, and it has been approved only in breast. And, it may be coming at the end of this year for the prostate, maybe. And then we left with two, one called niraparib, and another one which is called rucaparib. And both of them, they will have no single rule in breast cancer. Why? The rucaparib, they tried with the cisplatin and doesn't work. And rucaparib, if you have a germline mutation for BRCA1 and BRCA2 is not working, it is good in ovarian cancer. And that one, it's reflecting the heterogeneity of the BRCA1 and the BRCA2 in breast cancer versus ovarian cancer. And this is a big topic for understanding the biology between the two. So you have to think, is it the ovarian cancer and the breast cancer for BRCA mutation are similar? The answer is not, because the medication that it can be used in breast may not used in the ovarian cancer. It is very interesting now, just in 2021, in October 21, there was a registration study for niraparib, and because of the futility, and it was not working, it has been removed from the market. So today, since 1961, we left with two molecules. Either you are going in breast cancer, either you are going to use olaparib or you're going to use talazoparib. And we will learn today, that maybe olaparib is number one, maybe talazo is problematic in some concern, and we are going to explore that. This is the slide that shows you a very important information about the application of PARP inhibitor in different cancer type and germline, not somatic, germline, BRCA1 and BRCA2. And we have two just from now, and just keep awake. We have two, is it Olympia A, well, which is Olympia. This is for early stage breast cancer. And as you can see here, the difference in invasive disease-free survival at 3 years is 8.8 in favor of olaparib. And then Olympiad, this is in metastatic breast cancer, where olaparib versus standard chemotherapy 7 versus 4.2 months. It is very interesting. You know, we have a company. They are doing 2 clinical trials with different patient population. You will see now when we go to the patient characteristic, you learn that the highly who is in early stage are more resistant to olaparib. Despite of this, the olaparib in progression-free survival win the game. So remember this, that we have early versus late, and the patient population are completely different, and I will mention that. The other one, to give track of this satellite symposium, Talazo, as you can see here, 8.6 versus 5.6 or 9 versus 6 in patient versus taking this medication versus best selection. Now, when we are looking for application of the BARB, different cancer type, which is HERD, homologous recombination deficiency, the only thing that, as you can see here, when you are giving to the germ line bulb, you have the BFS of 13.3. We never see that with olaparib. And then the second one there is a somatic not a germline mutation, and gave about 6.3 months for the olaparib. This is, we are not at the present time considered to do somatic for olaparib for breast cancer. But if you have that somatic in next generation sequencing, just go and look for germline. It may be they have germline too. Other things which is important, that when you have a new medication called inaparib, and this one has been shown in deficiency syndromes, they give the overall pathological response rate, it is about 36%. Yesterday, you saw this slide, triple negative, how much high mutational load. We are talking about the DNA damage program. We are talking about the DNA damage response. And then we are going to talk about factors and so on. So this is the landscape for today's talk. Now, this is maybe the first time you see this, this family. Whereas, this is the BARB family. We have from 1 to 16. The most important, as you can see here, is this BARB1 and BARB2 and BARB3 family, who is our work as a physician on them. As you can see here, the function of this family, it is enzyme. It is super family. And as you can see here, it is affecting almost every aspect of cellular life. It is amazing in DNA repair, which as I'm going to talk about, transcription, heat shock, cytoplasmic stress, response cell division, and the protein degradation. Not only this, if you are looking for in the table, there is transcription regulation. They have also antiviral response. It is involving in inflammation, but mainly it is cell cycle regulation, DNA repair, and also resolution of HR event, which is the homologous recombination. But in mind now, with learning about BARB1 and 2 and 3 family, now we are starting to learn olaparib with family 14, 15, 16. This is new data, it will come soon. And there is a high possibility that this is giving us information more about this group. And in fact, at the end of this talk, you learn that the molecule, which is olaparib, it may going to be used even in non-germline mutation for BRCA1 and BRCA2. Let's take you for something which is very interesting. Subhanallah, for the DNA damage, there is, it is very in regulating cells and the replicating cells, which is the tumor cells, one cell of the cell. Now, when you are doing a damage for that, It is different from one which is saturated DNA damage in, let's say, ischemic heart disease, stroke, septic shock. It is completely different. What happens with that? That, when you have this DNA damage, the DNA damage activating the BARB1 and BARB2 and BARB3 family, and there is a possibility today that including the BARB14 family. So the activation of that, starting the DNA repair process. The DNA process requires the DNA repair factor, and the most important of that, there are a ton of them, is XRCC1, and we will come to this. Now, at this point, the only one that God knows, what the cell they are going to do. Now you have a damage, you are activating family, you try to DNA repair. The DNA repair, they call factor, recruiting factor, and then the cell, they will decide. They will go for cell cycle arrest, apoptosis, or survival and making a cancer growth. Now, when we are giving the BARB inhibitor, as you can see there, it is immediately preventing the DNA repair process, all the process. I will show you the details of that. And then they go to apoptosis. This is the whole idea from the BARB inhibitor in BARB family and the DNA response issue. Now, when you're looking for this, you have a DNA damage. The first thing that you have single strand, which is called DNA break. Now, for that one, the BARB family 1 and 2 and 3 activated. And then, the DNA repair starting, recruiting the factors, and the most important is RCCC1, and leading to cell survival. But what happens when you are giving the BARB inhibitor there? You are blocking that. So you are converting from single strand to double strand. And then the double strand, if the cell is not mutated, it becomes as a cell survival. But if it is mutated, it leading to the lethal synthetic death. So it is very simple, a damage, activation family, DNA response, but it is very complicated issue. Look for this. This is important for all of you in terms of learning. Now, what is the story of the DNA repair? The DNA repair is more error that you can see when the BRCA1 and BRCA2 protein are deficient. And we have two major mechanisms of that. We have something which is called HR, forget about the H. So it is, forget about the R, it is HR, homologous recombination. And the other family is NHEG, which is non-homologous end joining. Subhanallah, that when these two families working or they try to DNA repair, what they do, they have to work together. This HR or NHEG, they cannot work alone. They need to be together. And I will show you how they are going to work for that. Now, as you can see here, non-functioning HR in the BRCA deficient, or that the NH, which is less precise, more error-prone, accumulation of additional mutation, chromosomal instability, and increasing risk of malignant transformation. So what happens here when the single strand, they go to double strand, specific signaling pathway and repair cascade, it is very complicated, and DNA damage response starting. For the single strand, can you give me the microphone? For the single strand one, the only family that dealing with this, the only family they are dealing with this is BAIR, which is base excision repair. But for double strand, they need the two. As I said to you, one of them, they cannot work. Two together in between. And then there are DNA repair factors recruiting all of these companies. So that means in single strand, we are going to see XRCC number 1. And the others, as you can see here, SHEC1, SHEC2, BRCA1, BRCA2, ATR, and so on. And the most important for the other side, which is the NHEG, is the DNA protein, which is called DNA phosphorylation K protein. This is the most crucial in making the DNA repair and functioning at that level. Let's make a little bit complicated for you like this. So what we need to know here, that you have a damage, you have a single strand, you have a double strand, then you are activating the single strand repair family, HR, and both of them together. So basically, this one, they go through this cascade. You see the PARP inhibitor, tolazirib, rucaparib, niraparib, olaparib, and all of them, how they are blocking that. Now, the most important thing now we learn, at least in the last 3 or 4 years, that the cascading in the double strand, they need ATM, ATR, and this is maintaining the replication of the fork stability. And the check 1 and the check 2, this is main for the control of checkpoints. And the other one here, as I said in the green, which is the DNA protein kinases, we have 3 molecules now, they are dealing with that to block, which is the NHEG. As you can see here, we have a lot of molecules coming soon. Beside that, we have all of this where I mentioned. We have something for ATR, we have some for ATM, we have something for check 1, we have one for the check 2, and so on. So this is the picture. It will be complicated a little bit soon, in maybe 3-4 years from now, in understanding the PARP inhibitor. Other things, which is a year ago, we learned about the PARP, and I'm sure that many of physicians, they don't know about this, has amazing immune modulation. And the discovery of one of the best signaling pathway for humans to understand that when you are giving PARP inhibitor, it is impairing the double-strand DNA, and at that point, they are activating, which is called the C-gaze pathway, and this is just discovered about 18 months ago, and it has been shown that increasing interferon and other cytokine. Once we have that, you see the PARP inhibitor that every day we learn about the functionality of the olaparib in this, in the area of the oncology. And as you can see here, then after that, when the C-gas signaling pathway, it is starting, interaction between the N-killer T cell, tumor cell, dendritic cell, and the CD8 T cell. But there is something which is recently has been very well known, that we have a new family which is called natural kill group 2 D membrane. Both is a family and ligand with the activation of ADCC, which is antibody cytotoxic dependent cytotoxic cells. All of this leading to kill of the cell, beside what we learn about how the DNA damaging. This is a new era for understanding the immuno-oncology for the PARP inhibitor. So in future, there is a high possibility that PARP inhibitor with immunotherapy, it will have some impact on that. So again, so this is the Olympiad. So Olympiad, it is very simple. As you can see here, and yesterday I have one question about the stratification. Prior anthracycline is necessary, less than 2 prior chemotherapy. And in hormonal receptor positive, progressed disease on at least 1 endocrine. And then, as you can see here, very simple, olaparib versus chemotherapy. You give capecitabine good, you give eripulin good, you give navalbine is good, and the primary endpoint here, progression-free survival. Now, as I said today, there is a huge difference between Olympiad versus Olympia. And here, as you can see, ER positive, PR positive is 50%. In the early stage, it is only 18%, a huge difference. And here, the triple negative is only 50%. Again, as you can see here, the BRCA one is 57%. In the study that we are going to mention to you is almost about 70%. So you cannot compare this one with the other one. The other one, maybe it is more toxic, okay, in terms of the patient characteristic. This one is simple to some extent. However, it is ER positive and PR positive, hormonal positive, is 50%. Now, When we are looking for the prior chemotherapy, almost about 33% de novo, 1 and 2 the rest. And then, you are coming for this, which is very nicely seen, looking for the hazard ratio of 0.85, 7 versus 4.2. And then you are coming for who has hormonal receptor positive versus triple negative. This is something unique. However, the hazard ratio is 0.88 versus 5. But look for the triple negative one. This is the first time that we see some patient who is germline mutation with the hazard ratio is only 0.43. This is amazing, a result for the olaparib. We can say congratulations. Other things, when you are looking for the BFS2, and I think that there is a very nice article just published 3 weeks ago in the Lancet Oncology, looking that you are comparing the F2 to, in future, the approval of a drug of the FDA, especially in metastatic breast cancer, that, maybe you are using this instead of overall survival. And I encourage everybody to read about this one. I think that it is free online. Just put BF2, you will get it. Now, for that BF2, okay, that you see here, the hazard ratio, it is maintained. And it is 13 versus 9.3. And the benefit, as you can see here, despite 6% of patients who receive subsequent treatment in the arm of the physician receive PARP inhibitor as their first subsequent treatment. So that means there is a crossover, and indicating that, patients, they are benefit from this molecule tremendously. Now, when we are looking for the benefit here, seeing you had chemotherapy versus no chemotherapy, indeed, the patient who didn't receive chemotherapy, as you can see here, the progression-free survival is 7.7 versus 3.9. Now, if you are looking for this plot, the benefit for all subtype, I mean that all things, it is in favor of PARP inhibitors. Now, this is the side effect. I can tell you from our use or my use of this medication, there is nothing much, you can tell there is a little bit of nausea, vomiting, maybe a little bit of fatigue. You have to see in the first 6 to 8 weeks about the anemia and so on. Now, when you are looking for the update on overall survival, that, this is maturity, we will need to wait more. As you can see here, it is about 19 months versus 17, and the hazard ratio of 0.84. So putting this all together, you see that, the overall survival benefit appeared to be greater in patients to receive a treatment in the first line, which is there, with the hazard ratio is 0.5. So in conclusion, I don't think that there is any doubt about using this medication as per indication, either by approval of FDA, including the Saudi Arabia. Now, just I would like to, this is the publication, which is in New England Journal of Medicine. And then, we have to talk about a little bit of Taliso. And the Taliso, again, if you are taking the progression-free survival, it is about 8.6 versus 5.6. The hazard ratio is almost about the same like olaparib. And then, looking for triple negative versus hormonal receptor positive, almost the same like what we see in olaparib in the term of the progression-free survival. But there is one thing which is very important, that this is just published now for the overall survival, which is 19 versus 16, so that both of the drugs so far has not been shown that a survival advantage. But this is very important slide for you. First of all, if you are taking the anemia, the grade 3 and the grade 4, it is almost about 40% in Taliso, and it is only 16% in olaparib. And I give attention that, patient on Taliso, maybe they are suffering and need blood transfusion on short run and long run. Other things, you see the fatigue is higher and the alopecia is higher. However, the nausea and vomiting are the same. And the thrombocytopenia in the grade 3 and grade 4, it is almost about 15%. so that this drug, however, we don't understand the mechanism of action, why they have this severe hematological toxicity. Now we are shifting to the early, it is very quick. The Olympiad, as you can see here, we have neoadjuvant and adjuvant, and the indication, any patient triple negative, no PCR, or hormonal receptor positive, no PCR, or clinical pathological feature, including the estrogen receptor and the grade score, which is online, more than 3. Now, for the adjuvant, they have to be triple negative T2 or not positive. But if they are hormonal receptor positive, must be 4 positive node. Otherwise, you cannot use it. Now, as you can see here, as I mentioned, it is very clear that the BRCA here 71 versus the Olympiad other one, it is 50%, indication that this is a most likely more aggressive disease. Other things which is here, that the hormonal receptor positive is 18, there it is 50%, triple negative is 82%. Now, premenopausal, it is almost 62 versus 37, which is in the other study, it is 50-50. Now, other things which is very important, that the majority of patients are stage 2, 2B, and stage 3A, which is, maybe like what we have in this country. Now, when we are going to look at 3 years, the difference between two, it is 8.8. The B value is significant, and this hazard ratio, it is 0.58. Now, when we are looking for the mature cohort, first 900 entered with the median follow-up of 3.5, as you can see here, still maintain the 3-year 8.6 in favor of olaparib. Now, overall survival so far, it is short, but again, the difference in 3 years, it is about 3.7, which is not bad, and the B value is okay. Hazard ratio, it is 0.68. Now, when we are looking for the subgroup, all in favor of olaparib, and then, interestingly enough, that the side effect is not like the metastatic, is less in everything. So you are not going to see much with the olaparib in early stage. Now, the adverse event of interest, the only thing that there is some of acute myeloid leukemia, pneumonitis, new primary, but again, it can be expected. In conclusion, as you can see here, I think that it is the standard of care at the present time. Just we are waiting maybe for the approval of Saudi FDA to start some of these patients in early stage. I'm not going to talk about this because there is no time. It is only have maybe 50 seconds. But the mechanism of resistance is something need at least maybe 20 minutes for understanding. And this is another new data about the resistance to PARP inhibitor in breast cancer and ovarian cancer. I would like to share with you, this is a very important slide, where at the present time, triple negative 15%, currently we are using PARP inhibitor both in mutation, in both in early as well as the metastatic, but there is a predicted potential for PARP inhibitor soon in triple negative, regardless of the BRCA mutation, and we are going to see some data maybe early years, and then with the using of chemotherapy, olaparib, it will be 80% of the breast cancer, they are going to receive this molecule. Now, at the end, this is the adjuvant has been published, and this is the ASCO guideline update, and you can go and look for that. At this point, I would like to thank you, and remember, it is a drug of value for a germline mutation patient. Thank you. And also they have a unique biology as I described. I'm sorry that I cannot give a time about the mechanism of resistance. There is a lot of fun, in the mechanism of resistance for all PARP inhibitor, not olaparib, for all of them. Thank you.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome to general session, and thanks to the organizing committee and scientific committee for inviting us and bringing us all together in this very successful 16th Best of San Antonio. So congratulations on this really success year after year. I am Fahad Ibn Shams. I'm a medical oncologist from Dammam, and I'm privileged to moderate the session with my colleagues, Dr. Hiba Dawahri, who's a professor of medical oncology from Cairo University. We're happy to have you with us. I think you're with us online, Dr. Hiba. Also, I'm privileged to co-chair the session with my dear senior master and medical oncologist, Dr. Ahmed Abdelwarith, who is one of the establishers of oncology service in Dammam before he moves to King Saud University. I'm highly privileged to be with you, Dr. Ahmed Abdelwarith. Also, I would like to invite Dr. Sadir Rifai, who's a new medical oncology star from National Guard in Riyadh, to chair this session with us. So we'll start straight ahead to the first presentation. Before that, I think the organizing committee told me that you can grab a lunchbox from there just to use the time, as long as you leave a couple of boxes for your moderators. And so the first presentation will be presented by Dr. Shahina Dawood, who's a senior medical oncologist and medical oncology leader in United Arab Emirates, and also the president of the Oncology Excellence Meeting. So we're happy to have you with us, Dr. Shahina. Dr. Shahina will present us the abstract study of comprehensive genomic profiling of patients with breast cancer identifies germline somatic interaction mediating therapy resistance. Dr. Shahina, mic is yours.
Thank you for the lovely introduction, and thank you for including me in the 16th Best of San Antonio. I wish I could have been there personally, but as you know, with the COVID situation, it's getting rather difficult to travel. So I was given an abstract that I think was perhaps the most interesting abstract at San Antonio. It was led by a medical oncology fellow at the Memorial Sloan Kettering, who presented the comprehensive genomic profiling of patients with breast cancer, identifying germline somatic interactions mediating therapy resistance. So just as a background and introduction, we know that germline mutations in susceptibility genes such as BRCA1 and BRCA2 do predispose people to development of tumors such as ovarian cancers, breast cancers, pancreatic and prostate cancers. And at the same time, we know that their presence allows for sensitivity to targeted agents such as PARP inhibitors. We've just seen a very eloquent presentation looking specifically at this topic. And just as a summary, you can see the results of the Olympia D trial over here, where the PARP inhibitor olaparib was far superior to physician choice of chemotherapy in patients with breast cancer who also had a germline BRCA1, BRCA2 mutation. Interestingly enough, the biological and the clinical characteristics or behavior of patients with a BRCA1, BRCA2 mutation depends not only on the presence of that mutation, but also depends on zygosity and histological context. And there's been a lot of data, in fact, looking specifically at this. And what you can see on the slide over here, that genomic imprints that allow you to be more sensitive to agents such as PARP inhibitors really require the presence of biallelic pathogenic mutations rather than monoallelic pathogenic mutations. And we're going to be discussing more about this because this is what's been presented at the presentation at San Antonio. We also know from large data sets such as the pan-cancer data set, as well as data sets that have come from Memorial Sloan Kettering, which you see on the right side over here, that they've begun to investigate the interplay between the presence of these germline variants and the presence of somatic variants. And essentially what they've shown is basically an inverse correlation between the presence of germline variants and those somatic drivers. So in this particular study, what they did, the investigators, was to look at how the germline somatic interactions associate with the clinical outcomes to both lineage-directed as well as targeted therapy. What they did was they took a data set of 4,640 breast cancer patients who were treated at Memorial Sloan Kettering and who had been prospectively followed and whose tumors were sequenced using their own NGS platform known as the MSK Impact. Plus, they had matched germline data for these patients. These patients were treated between April 2014 to May 2021. Now, they did do a number of analyses, but what they really did focus on was looking at that allele-specific copy number analysis, really delving into deep deletions, amplifications, monoallelic loss, as well as copy-neutral loss. For this particular data set, they looked at common germline pathogenic variants such as BRCA1, BRCA2, CHEK2, ATM, and PALB2. They compared the number of somatic variants, including mutations, copy number alterations, and fusions between patients with both germline pathogenic variants as well as wild-type pathogenic patients. This was accomplished with the first penalized logistic regression. I am not a statistical person, but I believe that they use this particular methodology because the number of patients with germline pathogenic variants are obviously smaller. So this method of analysis accounted for the small sample size of patients who had either a BRCA or a CHEK or an ATM or a PALB2. And the analysis was obviously adjusted for sample size as well as receptor status. Analysis was repeated for both biallelic loss, which is known as loss of heterozygosity, as well as monoallelic loss for each of the predisposing genes. Now, in terms of the data set that they used specifically for the presentation that they had at San Antonio, they focused on the group of patients that had BRCA2 and BRCA1. And you can see about 122 patients had a BRCA2 mutation, about 101 patients had a BRCA1 mutation. And if you just look at that demographics, you can see that in patients with a BRCA2 mutation, almost 80% had hormone receptor positive disease, while in patients with a BRCA1 mutation, interestingly, only about 60% had triple negative breast cancer. And in the literature, patients with BRCA1 mutations tend to have a higher percentage of triple negative breast cancer. So they presented the analysis using a volcano plot, and basically a volcano plot that you see here on the slide. Basically, if you go to the left, it indicates genes of mutual exclusivity. If you go to the right, it looks at genes where they were enriched. And if you go up, it basically indicates increasing statistical significance. And basically what the authors were able to show that in patients who had a germline ATM, they had enrichment of TP53, and you can see that over here. And in patients who had a germline BRCA1 mutation, so these were all cases of BRCA1 mutation, you can see that they had enrichment of TP53. When you're looking specifically at that association of germline BRCA1 with TP53 enrichment, the authors then went on to see if there was a variation of this enrichment across receptor status. And what they essentially found was that amongst patients with triple negative breast cancer, you can see that in the germline type, although it was higher at 96.7% for TP53, even the wild type was high at 83.2. But again, they mentioned that this could be a play for the numbers that they had, but still higher in the germline mutation positive patients. Then when you looked specifically at the patients with hormone receptor positive HER2 negative disease, you can see quite nicely that there is an enrichment of TP53 mutation in the germline BRCA1 at 66.7% versus wild type at 24.6%, really together showing us that this enrichment in TP53 is seen across receptor status. When you're looking specifically at germline BRCA2 cases, they did find some interesting results. They saw that there was a distinct somatic aberration profile compared to the wild type. you can see specifically in terms of mutual exclusivity, PIK3CA and TP53 tended to be mutually exclusive in the BRCA2 patients, while in terms of enrichment, you can see there was an enrichment for RB1, AGO2, as well as MYC in those patients who had a germline BRCA2 mutation. Now, when you're looking at the interactions between germline BRCA1 and BRCA2, really looking at that RB1 specifically, you can see that in germline BRCA2, and I've just shown you this, RB1 tends to be enriched, but in the BRCA1 patients, you can see that RB1 is not enriched. So this enrichment of RB1 seems to be exclusive to patients with germline BRCA2 mutation. Now, this is an oncoprint of the cases of patients where there was a germline BRCA2 mutation. As I mentioned, this was associated with a distinct somatic aberration profile. They found that most of the aberrations were spice site mutations, truncating mutations, as well as fusions. And when you look specifically at that interplay of RB1, what you essentially see is, in those patients who have a somatic RB1 mutation, if they were germline wild type, they tended to have lower percentage, and you can see that in that pink graph there, a lower percentage of hormone receptor positive disease compared to the patients who had a germline BRCA2 mutation and a somatic RB1. You can see a higher percentage of patients who had a hormone receptor positive disease. And this was irrespective of, in fact, whether they had somatic RB1 wild type or mutation positive disease. You can see that so long as you have a BRCA2 disease, your percentage of patients who had hormone receptor positive disease would be higher. Interestingly, when you looked at the frequency of the mutation of RB1 by the site of metastases, you can see amongst patients with germline BRCA2, it tended to be higher in that metastatic setting. Now, they went and they delved in specifically looking at the clinical implications of RB1 BRCA2 co-alterations. As you know, both of these genes are actually located on chromosome 13q, actually quite close to each other. And we also know that large segmental loss is a common loss of heterozygosity mechanism in patients who have a germline BRCA2-driven tumor. And in their specific cohort, what they found was that if you had a germline BRCA2 loss of heterozygosity, as well as an RB1 monoallelic loss, you can see a very high correlation between the two. So they took this to look at patients who had hormone receptor positive and BRCA2 positive disease who'd been treated with a CDK4/6 inhibitor, because one of the mechanisms that we know that confers resistance to CDK4/6 is an alteration in the RB1. So when they looked at their data set, they looked at data set where patients had either BRCA2 or BRCA wild type. And you can see amongst patients who received CDK4/6 in that first line setting, patients with BRCA mutation positive disease tended to do worse. You can see a median progression-free survival of 7 months compared to patients who had wild type, where it was 14.7 months. And when you looked at the progression-free survival at any time point if CDK4/6 inhibitor was used, that means either first line or beyond, you can see again, if you had mutation positive disease, again, 4.4 months progression-free survival versus wild type, where the progression-free survival was 10.2 months. And this data or this evidence is actually not new. We did see some very provocative data last year at ASCO from Professor Yap's group that came from Korea that also showed in a prospectively followed group of patients who had received CDK4/6 inhibitor with palbociclib, if they had a BRCA mutation, they tended to do worse. And this has also been corroborated by a large data set from the Flatiron group as well. Now, how do you account for this? What could be the possible reason for this happening? Well, we do know that in a normal cell of a patient that's a BRCA2 carrier, RB1 may be intact. But when oncogenesis actually happens, you may actually develop an RB1 monoallelic loss. So what the investigators went on to do was they took the group of patients whose tumor samples were sequenced prior to them receiving CDK4/6. Now, in the previous analysis, they just took everyone. It didn't matter when they were analyzed. But this group of patients, they were analyzed, or the tumors were sequenced prior to giving a CDK4/6 mutation, CDK4/6 inhibitor. And what you essentially see is, amongst those patients who have an RB1 monoallelic loss, you can see that they do tend to do worse irrespective of their BRCA1, BRCA2 mutation. You can see the best group of patients are those patients with a germline BRCA wild type RB1 intact, where their median progression-free survival is 26 months, while those with a germline wild type RB1 LOH, it's 12 months, while those who have a germline BRCA2 plus an RB1 LOH, you can see at a very abysmal 7 months progression-free survival when you're treated with a CDK4/6 inhibitor. Now, in their previous work, which was presented in 2019 at ASCO, what they essentially did was they had taken a group of patients who had received a CDK4/6 inhibitor, irrespective of their BRCA status, and they looked to see what were the mechanisms of developing CDK4/6 resistance. And they found that a large group of patients actually had developed some form of an RB1 mutation. And these patients, when they went back to their original tumor samples, pre-CDK4/6 inhibitor treatment, they also found that a majority of these patients did have an RB1 monoallelic loss. So one of the hypotheses that they have put forward as perhaps an explanation as to why these patients were doing so much worse when they're treated with CDK4/6 inhibitor and they had a germline mutation positive disease is perhaps a lot of them are starting off with a BRCA2 biallelic loss and an RB1 monoallelic loss. And when treated with a CDK4/6 inhibitor, they're eventually developing biallelic RB1 loss as well. And this may be one of the reasons why there is a rapid progression of disease. Some of the alternative hypotheses could be that homologous recombination deficiency itself may be predisposing to poor outcomes, and maybe these are the patients that we need to be thinking about using a PARP inhibitor first line, or perhaps even haploinsufficiency of RB1 may be another possible mechanism. So in conclusion, the authors did conclude that obviously from the data that I've shown, that when you have a germline BRCA2 mutation and you're treated with a CDK4/6 inhibitor, you tend to have an inferior prognostic outcome compared to patients who have a BRCA wild type disease. Obviously, some of the possible mechanisms may be predisposition to biallelic loss of that RB1, HRD itself, or maybe even a conditional haploinsufficiency of the RB1 BRCA2 combination. And perhaps future clinical trials need to start looking to see how to best sequence PARP and CDK4/6 in these patients. They also showed that integrated germline somatic analysis reveals distinct patterns of enrichment in a manner dependent on germline variant. They did see that in patients with germline BRCA2 mutation, there was an RB1 somatic enrichment. In patients with a germline BRCA1 mutation, they did show a somatic TP53 enrichment, and they found mutual exclusivity of PIK3CA in the germline BRCA1 as well as BRCA2. They did manage to show that pre-treatment allele-specific copy number analysis revealed importance of LOH in shaping the tumor evolution and therapeutic outcomes, and RB1 monoallelic loss in the absence of any germline alteration confers inferior outcomes to CDK4/6 plus endocrine therapy. So maybe this is something that we do need to be thinking about beyond patients who've got germline BRCA mutation. And again, clinical trials are needed to see if CDK4/6 is the best treatment for these patients. So I think it'll be exciting to see what comes out next from this study. And I think all the clinical trials that are going to be planned around the data that we've seen today. And thank you very much.
Thank you very much, Dr. Shahina, for this very informative and enlightening study. And now I would like to give the microphone to Professor Dr. Ahmed Abdelwarith to present the next speaker. Dr. Ahmed.
Bismillah ar-Rahman ar-Rahim. It is my honor and great pleasure to share this session with my dear colleagues, Dr. Fahd bin Shamsa and Dr. Sadel, and Dr. My dear colleague from the National Cancer Institute, Dr. Heba Zawahri, a dear colleague and an eminent professor in medical oncology. It gives me a pleasure to introduce our dear colleague from the Hussein Cancer Center in Jordan, an eminent medical oncologist, Dr. Hikmat Abdulrazak. He is the Chief Medical Director, and he is going to enlighten us about the value of adding fulvestrant to palbociclib versus continuing with only aromatase inhibitor in palbociclib in patients who have developed ESR mutation metastatic breast cancer. The microphone is yours, Dr. Hikmat. We are very happy to have you with us.
Thank you, Dr. Ahmad. Thank you, Dr. Khair, and all our colleagues in Riyadh for the invitation. My talk will focus about the clinical use of liquid biopsy in a clinical practice, and you will see how we translate our knowledge in liquid biopsy into clinical practice. So this is a study about the fulvestrant plus the balbo versus continuation of aromatase inhibitor and balbo upon detection of circulating ESR1 mutation in hormone receptor positive HER2 negative metastatic breast cancer. This is the result of the BADA-1 study, which was presented by Dr. Baider from Institute Korea. This is the disclosure of the authors of the study. And this is the background that ESR1 mutation is clinically important. We start to talk about it. ESR1 restored the ligand independent ER alpha activity in ER positive metastatic breast cancer. Interesting enough that this kind of mutation will drive resistance to ER positive metastatic breast cancer for aromatase inhibitor, but not to other hormonal therapy, which means that if there is ESR1 mutation, that patient will have a resistance to AI, but not to the fulvestrant, for example. And this ESR1 can be detected in cell-free circulating DNA, or what we call liquid biopsy. So ESR1 mutation is extremely rare at the initial diagnosis of metastatic breast cancer, less than 5%, but this kind of mutation can go up to 30 or 40% upon disease progression. So we start with no mutations. As the disease progresses, that mutation can be detected up to 40% of those patients. As I said, it does inform a resistance to AI, but not the fulvestrant. So the hypothesis of the authors of this study that if we can monitor the progression of the disease by looking at the ESR1 in liquid biopsy, and once this has been identified, the increasing in level, then if you can then detect it, then you switch from AI to fulvestrant. And this is the whole theme of this study. So this is the main inclusion criteria. Performance status has to be good, 0 to 2. Patient have to have the hormone receptors positive in more than 10%, HER2 negative, obviously. No primary resistance, meaning the no relapse below 12 months from the adjuvant utilization of AI. No prior systemic therapy, so this is the first-line treatment. Obviously, adequate liver and the kidney functions, and the absence of a visceral crisis, of course. So this is the theme of the study. So this is the first-line metastatic breast cancer, and at the inclusion, patient will get at the start, at the baseline, the blood ESR1 mutation level. Then we'll do it a month later. Then after that, they will continue every 2 months. And as long as the patient with no progression, then those patient can be randomized to either continue aromatase inhibitor plus balbo or switch aromatase inhibitor to fulvestrant plus the balbo. This is only if there is the arise in ESR1 and there is no clinical disease progression. So if the patient progress clinically, then they go off the study. So this is also statistics. This is an event-driven analysis. So the author would like to have more than 120 event, and with the hazard ratio of 0.630 and an 80% power at two-sided p-value, then the author estimated that they would need close to 200 patients randomized, which means they have to start with 1,000 patients. Lots of the secondary endpoint, including the second progression-free survival, overall survival, and non-hematological side effects. So this is how they started. This is as of the last summer, July of 2021, 1,000 patients were included, treated. Those patients, 407 patients, had progressed clinically, so they were taken off the study. And the 256 patients had no rise in ESR, so they continue with their treatment. This will bring us to 279 patients with little drop. So ultimately, they had only 172 patients with rising ESR1, and those patients were randomized to AI plus the palbociclib to continue on AI and palbociclib, or to switch to fulvestrant plus the palbociclib. This is the characteristics of both the group. As you see here, 80 patients or 90 patients in both the groups. The median age is 60 and 62. Prior adjuvant aromatase inhibitors were taken in a little more than a third of those patients. Metastatic, lots of those patients did have a visceral only metastasis or visceral plus the bone metastasis. Only a quarter of the patient had bone-only disease, which means those patients are a higher risk patient. This is their findings. This is primary analysis, progression-free survival after randomization. This is the curve in blue. This is the progression-free survival for those patients who continued on palbo and aromatase inhibitor. You see the median progression is only 5.7 months. But for those patients who were randomized to switch to fulvestrant, they had a better outcome, median progression-free survival close to 12 months, 11.9 to be exact, and that obviously was associated with a very significant p-value. So this is an extremely important slide just to illustrate that by monitoring, doing liquid biopsy for ESR1, and if you switch upon the start of the rise of ESR1, you can double up your progression-free survival from little less than 6 months to almost 12 months, and this is exactly double of the progression-free survival. These are the subgroup analysis, and as you see here, almost all group benefited. However, those patients with bone-only disease had the least benefit, which are the lowest risk patients. These are the grade 3 and 4 adverse events. As you see here, there is not much of a difference between the two groups, and this is basically because both the group received the palbociclib. Lots of the side effects clinically encountered are due to the CDK4/6 inhibitor. There's not much of a difference between AIs and fulvestrant in terms of the side effects when we talk about grade 3 and 4 side effects. And however, only 6 and 7 patients in both the group had dose reduction with the palbociclib. Now, they had also another step, and they did allow those patients who continued aromatase inhibitor and the palbociclib, if they progressed clinically, to be switched to fulvestrant and palbociclib, and that did by sometimes for those patients at a median follow-up in step 3. This is the step 3. You had the median of 14.7 months, 37 progression-free events only noticed of those patients. And this is the second progression-free survival in those patients who crossed over to fulvestrant and palbociclib a little more than 3 months in this group. So to conclude, this is the first clinical trial to demonstrate the clinical utility of liquid biopsy by doing the blood, the cell-free ESR1 mutation monitoring, and this monitoring the blood allow optimization of the endocrine therapy in addition to CDK4/6 inhibitors. Upon the detection of a rise in ESR1 detected, then if you switch to fulvestrant and not to continue aromatase inhibitor, your median progression survival will double, as I showed you, from 6 to 12 months. And safety-wise, there was no added toxicity by doing so. The observed clinical benefit might be underpinned by a lower burden of ESR1 tumor cell at the fulvestrant initiation and not to be catched by the standard fulvestrant-based second-line therapy. However, that finding may justify the implementation of this BADA-1 trial by monitoring the ESR1, which is clinically doable, feasible, and should be available by doing liquid biopsy. And if so, that would prevent us reaching the clinical disease progression by switching to fulvestrant and obviously to continue the CDK4/6 inhibitors. This is the slide of their acknowledgement. With this, I'll stop here and thank you again for the invitation. Thank you.
Thank you, Dr. Hikmat. Elegant presentation of a very exciting data, a very important piece of information that we can build on the future. The need of like more of a tailoring of treatment according to the change of the tumor biology and the tumor marker. Thank you very much. The microphone will go back to our chairman of this session, Dr. Fivedimensional.
Thank you very much, Dr. Hikmat and Dr. Ahmed. And now I'll give the mic to Dr. Hiba Al-Zawahri to present the next speaker. Dr. Hiba? Are you muted? Okay, so till we fix the sound with Dr. Hiba, so I'd like to the next speaker.
Assalamu alaikum.
Dr. Hiba, go ahead,
Now
please.
you hear me now?
Yes, Dr. Hiba, تفضلي.
Okay. Assalamu alaikum. Thank you very much. I am very honored and pleased to share this session, and I would like to thank Dr. Khair for her continuous effort to do this very good and high caliber scientific meeting year after the year. I would like to present Dr. Hamid Shamsi. Dr. Hamid Shamsi is a well-known figure in the Gulf area. He is a professor of medical oncology and he is a chairman of UAE Oncology Society. And actually he will deliver a very important presentation in the San Antoniao, how we can use circulating DNA mutation for tracking minimal residual disease in breast cancer. So please, Professor Dr. Hamid.
Assalamu alaikum. Thank you, Dr. Hiba, and I hope you can hear me very well. شكرا جزيلا على هذه الدعوة الكريمة وأشكر القائمين على 16th Middle East Best of San Antonio. أخص بالشكر الأخت الدكتورة الخير على الدعوة الكريمة وكنا نتمنى نكون معاكم in person ولكن today is my first day COVID negative after a mild الحمد لله mild COVID infection فإن شاء الله in the near future إن شاء الله we'll be joining you in person. So my task is to present this primary result of the C-TRACK TN trial by the British group led by Dr. Nicholas Turner. And the idea is to understand how can we predict which patient with high risk or moderate risk of triple negative breast cancer who may have recurrence based on the circulating tumor DNA. And the title of this trial is Clinical Trial Utilizing ctDNA Mutation Tracking to Detect MRD and Trigger Intervention in Patient with Moderate and High Risk Early Stage Triple Negative Breast Cancer. This is a disclosure of Dr. Nicholas Turner. So background, most patients presenting with triple negative breast cancer are cured by current treatment. I have slight modification to this slide. I will just highlight, the 5-year relative survival rate for localized disease, 91%, regional 65%, distance 12%, and all stages combined 77%. So I propose minor changes. I will say many patients presenting with early triple negative breast cancer are cured by current treatment, and you may disagree with me, but this is my take on this statement. We need to improve the ways of selecting who will relapse. It's required to focus also on escalation of the adjuvant therapies to those patients. In the last few years, we started to use, for example, Xeloda as an adjuvant treatment in patients with residual disease and TNBC. So we are still trying to understand how can we improve the outcome of these patients in the escalation of the treatment, and also including the ctDNA. Also, detection of the circulating DNA in TNBC patients who have completed primary treatment is highly predictive for future relapses in retrospective studies. Again, this is important. This is retrospective studies. There were no prospective study in this regard. This is a multi-center prospective phase 2 pilot study to the use of the ctDNA assays in patients treated for early stage TNBC who were at higher risk of relapse. This is the trial design, and this is a very nice design and flow. Patient with early stage triple-negative breast cancer who received the neoadjuvant chemotherapy followed by surgery and who had residual disease post-chemotherapy were included. Also, patient who had primary surgery and who had a tumor more than 20 millimeter or not positive, completed surgery and adjuvant chemotherapy were also included. They look at these patients and they included them for design ctDNA assays, including registration and also primary tumor sequencing and also digital PCR assay design. And then there were active ctDNA surveillance, double-blinded with baseline ctDNA and also 3 monthly until 12 months. And based on that, patients who had any relapses prior to the ctDNA positivity, they went to receive a standard therapy. Patients who had positive ctDNA were randomized 2-to-1 to either intervention, pembrolizumab, 200 milligram IV every 3 weeks for 1 year, and monthly ctDNA samples for 12 months, versus observation to continue standard follow-up ctDNA samples every 3 months for up to 2 years. So the method included, as I mentioned earlier, tumor tissue sequencing to identify somatic mutation with sequencing panel. Also, personalized digital PCR ctDNA assays were designed with 1 to 2 mutation track per patient. Also, ctDNA extract from 4 mL of plasma analyzed for each mutation using Biorad digital PCR. And active ctDNA surveillance with the blood samples were done every 3 months to 12 months. Again, there were potential up to 18 months if the samples were missed during the COVID-19 waves. So the statistical design for this were aiming to register around 200 patients and recruiting 75% of these patients, that's 150, with trackable mutations into ctDNA surveillance, assuming 30% of these patients would become ctDNA within 12 months, allowing ctDNA rate to be estimated with around two-sided 95% confidence interval of plus or minus 7.3%. And they anticipated at the statistical design that around 20% of these patients would have metastatic disease on a staging scan and at the ctDNA positivity. A treatment group actually were compared with observation group. And again, this was not statistically powered for formal comparison. And again, this is very important because the result will be interesting as the observation group tend to do better in this trial. But again, there are small groups and they are not tend to be compared to each other. And we're just trying to describe the rate of the clearance of the ctDNA in the treatment group versus the observation group. The trial had some adjustment for the criteria, as we're going to discuss in this slide. So the ctDNA testing was suspended during the first COVID-19 wave in the UK, and active ctDNA surveillance was extended between around 15 to 18 month time points to replace I should say, missed samples. Also, the initial entry criteria allowed entry up to 6 weeks after the end of the adjuvant radiotherapy, and amended to entry within 6 weeks of the surgery after neoadjuvant chemotherapy or before the 3rd cycle of the adjuvant chemotherapy after primary surgery. And this is again after 75% of all the patients were included or enrolled. That's 154 patients. And following advice from the independent data monitoring committee, the observation group closed on June 2020 after all the patients were recruited and 39 ctDNA positive, with all subsequent ctDNA positive allocated pembrolizumab as well. Endpoints were interesting, primary endpoint and also secondary endpoint. The primary endpoint was the rate of the ctDNA detection by 12, around 1 or 2 years, 2 years from the start of the ctDNA surveillance. Also, the rate of sustained ctDNA clearance on pembrolizumab defined the absence of detectable ctDNA or disease recurrence 6 months after starting pembrolizumab. Secondary endpoint including the time to ctDNA detection of the overt disease at the time of the first ctDNA detection in patient allocated to the pembrolizumab, lead time between the ctDNA detection and the disease recurrence in the pembrolizumab treatment and the observation group, absence of detectable ctDNA or disease recurrence after 6 months in the observation group, safety and tolerability of the pembrolizumab, commencement of the pembrolizumab in the treatment group as well. Looking at the pre-ctDNA surveillance, 208 patients were registered between January 2018 and December 2019 from 16 recruiting centers. 77 were high risk and 131 were moderate risk. And I'm going to define the high risk and moderate risk. High risk were neoadjuvant chemotherapy patient who received neoadjuvant chemotherapy and who had residual disease in the axilla, primary surgery, tumor more than 50 millimeter and node positive or more than 4 nodes. So this high risk were 77 cases versus 131 moderate risk cases. The moderate risk included the patient who had neoadjuvant chemotherapy but had residual invasive in the breast and node negative. Again, this is different than the high risk. The high risk had positive lymph nodes after the neoadjuvant treatment, primary surgery, tumor more than 20 millimeter or axillary macroscopic lymph nodes. When we look at the 208 patients registered, 171 patients were with tractable mutations and 10 patients not continuing the ctDNA because 8 had recurrences, 1 withdrawal, 1 had meningioma. So we end up with 160 patients continuing to ctDNA surveillance. 108 patients had 1 mutation tracked, and 53 patients were 2 mutation tracked. When we look at the surgery and the treatment, most of these patients actually, they received mastectomy, 55%, grade, mostly high grade, 77%, tumor size was around 30 millimeter, nodal status were mostly actually macroscopic disease, 70%, and the chemotherapy the one who received chemotherapy were around 51%. Again, I'm talking about the high risk group, but we talk about the total group here also, we will have other differences. When we look at the BRCA germline mutations, 3% had BRCA positive and 3% also had BRCA1 positive and also BRCA2 positive. Both had 3% in this group. When we look at the ctDNA surveillance result, the median follow-up was around 20.4 months. All patients completed active surveillance. The proportion of the ctDNA by 12-month time was around 27%. So if we look at this graph, which has all the patients, and you see the proportion of the ctDNA here plotted against the month from starting the ctDNA over 2 years, we see around 26%. Again, 27, 26, not much difference between these two, and this for all the comers. When we split them between high risk versus moderate risk, as we anticipate, patients with high risk had higher proportion of the ctDNA positivity, 55%, versus moderate, who had 11% here. We can see the red color versus the blue color, moderate versus high risk. So now we're going to look at the treatment group. So when we look at the patient who reached the stage 45 patient into the therapeutic trial, 32 patients of this patient went to the treatment group. We're going to look at the rest of the patient who went to the observation group. The treatment group, 14 went to the observation, 32 went to the pembrolizumab, and the overt metastatic disease on staging at the time the ctDNA was 71%. And again, this is very important. We're going to have a slide at the end, look at the reason why this patient had metastatic disease at the staging. And again, this is very high, 71% of all the comers had, 23 out of the 32 in the treatment group had positive disease in the staging workup. And when we look at the treatment group, 32 high risk, 9 moderate risk, 23 high risk, 16 had overt metastasis, 3 declined treatment, 4 commenced treatment, and only 1 patient is still on treatment, 3 discontinued treatment versus the moderate risk, 1 discontinued treatment due to the disease progression. So this is the ctDNA trajectory for the patient who received treatment for pembrolizumab. 4 out of the 5 patients who received treatment had discontinued treatment because 3 had recurrences, one had a adverse event, and one patient remains on treatment. These actually are the same graph here when we look at the magnitude of the change in the mutation copies versus the month of the start of the treatment. This is just zooming into the y-axis, and you can see the patient with the pink color had positive ctDNA, but remains also on treatment. But no patient exhibited sustained ctDNA clearance 6 months after commencing pembrolizumab. Again, very small number of patients, and none of them had, sustained clearance of the ctDNA in this treatment group. Safety, I will not go through this. We know the pembrolizumab, not much to say here. Grade 3 diarrhea was one patient experienced diarrhea plus enteritis. When we look at the observation group here, we look at the 14 patient, one of them was reallocated to a treatment group. I'm not quite sure why this patient was reallocated, as what I'm not mentioned in the presentation. 13 went to the observation group, 9 were high risk, 4 moderate risk, 7 of the 9 high risk had recurrences, and 2 continued to do ctDNA surveillance. And for the moderate risk, 2 had recurrences, and 2 complete 24 months ctDNA surveillance. Looking at the observation group, the ctDNA trajectory, 4 patients remained recurrence-free. All 4 actually became ctDNA negative after initial ctDNA result. 2 of these became ctDNA positive again. So this is just illustration of the mutation copies per mL for this patient over the period of the study. We look at the blue color and the green color here. They're actually, they didn't have recurrence yet, but the proportion of the recurrence-free with the ctDNA clearance after 6 months in the observation group was 21.4%. Sorry about this here. So factors contributing to a high metastatic rate. When we take the account variability of the time study DNA entry, ctDNA result actually reanalyzed based on the calendar windows. When we look at the proportion of ctDNA positivity here, when we look at the month of the calendar window here, so this is the time. When we look at the ctDNA here positivity and also the overt metastasis, when you look here, you see that there's more ctDNA positivity at the beginning of the study here, and this declines over time. But also we see more overt metastasis here at the beginning of the study. And again, this was very important to look at this finding for future design of the study. Again, this is a pilot study. So early ctDNA detection was associated with high rate of metastatic disease, as we can see, blue color followed by red color here indicating recurrences, and estimated 1.4 moderate and 28.5 high risk had metastatic disease by the time of the baseline ctDNA. So in conclusion, the CTRAC TN trial is to the best of the authors was the first prospective study to assess the proof of the principle whether ctDNA assays have clinical utility in guiding further therapies in TNBC. At enrollment, patient had relatively high rate of undiagnosed metastatic disease when imaged, and also relatively few patients commenced pembrolizumab treatment, precluding assessment of potential activity. So the findings have implication for, again, this will not be practice changing, but certainly very important, points to be taken from the study for future trial design, including the start of the ctDNA testing early, as we've seen that, after enrollment of the 75% of the patient in this study, they made some changes to enroll this patient earlier than later, as we are seeing more and more ctDNA earlier and at the time of the enrollment, because there was some delay in the enrollment, or the design was actually after finishing the chemotherapy, radiation, and definitely we know this is a very long time for patient high risk with the TNBC. Employ more sensitive ctDNA assays that track multiple variants, and this is related to the positivity and negativity of some of the patients that we had. So maybe we need to have a better, sensitive ctDNA to avoid this. Again, we're not sure, but this is one potential issue with the ctDNA assay. Potential more frequent testing in 0 to 6 months and the first 6 months, given the rapidity of the disease evolution, and consider also ctDNA surveillance and during the adjuvant capecitabine, as I mentioned earlier. Also, high-risk patients may not be appropriate for ctDNA surveillance. Before I close, I would like to announce that we'll be launching the Cancer in the Arab World, which is a free open access book authored by many experts in the Arab world. This is the first book about cancer in the Arab world, and it took many years from conception until release. You can use your phone. You can take a copy, also print screen, where you can have access. Hopefully in the next few days from Springer website. And I would like also to highlight the breast cancer in the Arab world chapter, which has been authored by my colleague, Dr. Hikmat Abdelrazak, who presented just a few minutes ago, and Dr. Salwa Saadiya. And again, the book is available for free from Springer website in the next few days. And thank you so much. And we look forward, inshallah, for very fruitful discussion at the end.
Thank you very much, Dr. Ahmed, and alhamdulillah ala salamtek. Your efforts in mitigating the pandemic and researching COVID in the United Arab Emirates are very well noted. Alhamdulillah ala salamatkum. So now I'll give the mic to my dear colleague, Dr. Sadl Al-Rifai, to present the next speaker.
I would like to present our colleague, Dr. Shadi Khayat. He is an associate professor of medicine and medical oncology, Department of Medicine at King Abdulaziz University in Jeddah, Saudi Arabia. Dr. Shadi Khayat, are you online?
Yes, can you hear me, Sadel?
Yes.
Well, thank you. Thank you all. Well, it's my pleasure to be here among all speakers today to present in this yearly event that everyone is waiting. And the special thanks to organizing committee for the invitation, and special thanks and also congratulations on the success to the organizing committee with the head of Dr. Al-Khair for this success that I believe it has been the first established meeting for breast cancer in the country that's been happening on a regular basis. So it has been our honor to participate and exchange knowledge among these. So with the in the next 10 to 15 minutes, like I was given the task to present about the abstract for the circulating DNA. So this abstract is presented by Prof. Giampaolo Bianchini, who has presented this abstract with the title of Circulating Tumor DNA Dynamics in Patient with Hormone Receptor Positive and positive cancer and HER2 negative and advanced breast cancer, treated the first-line treatment with the ribociclib in the BioItaly trial. So I think this is just like, it's another, sorry. Okay, I'm having problem in moving my slide. Okay, so here it is, okay. So this is just like, continuation with the previous presentation that Prof. Shamsi has presented about the circulating DNA. We know that now we're moving toward the molecular and how those molecular signatures will be making a big difference either from prognostic or predictive value. So this is an introduction that we know that the CD46 inhibitor, and specifically ribociclib, has significantly improved the progression-free survival and overall survival regardless on the hormonal partner. What line of treatment, menopausal status in all three phase 3 trials. So we know that the Mona Lisa studies has kind of confirmed that in multiple lines of therapy. However, do we have any predictive biomarkers in this response? And this is where I believe that we treat all population, yet there might be some population that have a better response than the other. And I guess this is the value of this abstract. The circulating DNA analysis has been emerging right now as an attractive option for non-invasive approach to characterize the biology, the evolution over time, and predict the prognosis and benefits. And I believe the evolution over time is the most important things about the circulating DNA, because they're very accessible that we can take a blood sample to get the result of that. We assess the impact of the baseline dynamics in the circulating DNA analysis in the study in the postmenopausal patient, HER2 negative and hormonal positive advanced breast cancer treated with ribo plus letrozole. So if you see the study design, sorry, just I'm trying. Okay. So I'm just going to keep this mode because like, for reason or another, it's getting like, to be a smaller mode when I make it as a full screen. So this is the study design. You can see clearly here, the most menopausal woman, they have like, 287 patients that was screened. And the selected criteria that those based patients like be like the first line treatment, hormonal treatment, and the treatment free interval, it was 12 months. So that's like quite important to make sure that it's a first line treatment and they're not resistant. The patient willing to undergo blood sampling, because if you see the study protocol is kind of like required multiple blood sampling. So it has been taken at a baseline, which is labeled as day 0, then like 2 weeks, and then like at the first day of cycle 2, which should be at the day 29. And then that's like, where's the imaging happens after that to assess the correlation between the tumor change in the circulating DNA and the tumor response that would have a radiological assessment. Okay, so in a method, so this is like, simply they took the circulating DNA analysis that was carried out using the 500 application, the AmpliSeq high definition panel. And the target mutation that was screened, like, has been known from the beginning, and has been labeled as variant allele frequency. So the number of the target mutation that we found, and that's like, was the highest. So like, they took the one of the highest variant analysis to consider the VAF. And then the clearance, which is kind of defined as the 100% decrease in the target mutation. And this is like, what is like, being correlating at the end of the study with the prognosis and the predictive value. And if you see here, that's like, when they did the correlation between the progression-free survival and the circulating DNA, they did the multivariate Cox model. They included that the patient status, the tumor type, the absence of them, the presence of the visceral metastases, which is, I guess, it's an interesting finding. And then the number of organ involved, because like, depend how much of this is, if we can say that this is a busy, heavy disease burden or not. We see clearly here that this is the mutation they included in the panel when they screen the circulating DNA. So I'm not going to go like, in all of them. However, we see like, those are the common pathways that we be including in metastatic patients. So like, cell cycle related pathways, then the MAPK, the RTK, the PI3K, the P53, the HER2 family, and the FGFR, the CDK4/6 pathway, the DNA repair, and the RNF pathway. So these pathways has been suggested before that they are involved heavily in the resistance and like, the response of patients who are starting hormonal treatment from different molecules, whether they've been tested with the ribociclib or the palbociclib. So this is like, the panel that was created as the circulating DNA to be screened for. So this is like, the initial, as we said early, 287 patients, they were screened. However, like, we lost 24 patients as because of like, violation of the protocol or the sample was not collected. So ended up by 263 patients, which is reasonably, it's a good number of population that should be giving us like, an idea about what's happening. So again, like, the study protocol, as we said, at the first day, day 15, and the first day of the cycle of the next cycle. And if you see here, that's until the first day of the next cycle, 90% of the sample were like of the patients, they have like no sample, which was kind of like, a very good accuracy. Then like, the third sampling was kind of then like, when the first imaging was done in 3 months, and we see that some samples has been lost by that time. Looking to the patient characteristics, I believe like, this is the majority of patients that we see here. There's no any specific things that's important, but like, we see significant number of population, they're elderly patient, or majority of patients, they have a good performance status. And we see here, like, majority of patients, they were like no luminal B. And then like, we see the number of patients here. So patient who had like, by number of metastases more than 3 types, like, was 20%. So there's a population on this study has been like, with the heavily like, loaded patients with the metastases. So that was kind of like, the first finding. So they checked like, patient who has no target mutation at the baseline, and they have like, a good prognosis compared like, to the population. So if you see here, this, the Kaplan-Meier curve, this is like, in orange color, the patient wild type. So they they didn't harbor any target mutation that has been as the screening. So this population, they did better with a significant improvement in progression-free survival compared from both. So that was kind of the first important features from this. So population without any mutation, they do better than patients who has mutations. So this was the first finding. This is kind of when they go to the variance allele fraction reduction. So that was observed from the 2 weeks, and then after that by 2 weeks, which is the first day. So the standard deviation was kind of all the same. However, it has been observed the drop was almost in half of the population by day 15, and then out the second part was by the the second half of the cycle. Would that make a difference in prognosis? This is belief was going to show here. So this is patient who has at day 15, they have who has a significant drop at day 15. They were better than the population who did not have the significant drop of the mutations burden at day 15. So patients now, this is the second finding. So patient who had initially no mutation, that's a better prognosis, and patient who had a good response at day 15, those considered to be of more of a predictive value here, that will have a better outcome of the disease. So this population is better. Whether that means they are more sensitive to disease or not, I believe still further study need to be done on this. However, patient who achieved this target at day 15, they have been better than a patient who did not achieve that. So this is kind of the clearance now. So this is what is the most important findings here, that patients that were able to be cleared at by second cycle, they were better than patients who did not achieve clearance with the hazard ratio that was quite significant. So this is very important, that they have a delayed response for the clearance of the mutations at the second cycle. Still, those patients who achieve that, they will be better than people who did not achieve. And we know there was only 1 week of treatment after day 15, because usually we give this treatment for 21 days. However, still there was a difference in the outcome of this population. So as fast you can achieve these decrease in the mutation in the cell, that would be of more benefit. So if you see here that this is now we talk about the post-baseline detection mutation that showed less co-progression. So this is kind of another way how we look for this interesting way. So patient with the detected mutation later timetable. So still, if even they are not patient who had a no detected mutation right now, see that how the hazard ratio is 0.45 compared to the other population. So this is the main aim. However, if you see whether there's a difference in different population by time, this I believe where it's needed to have a little bit more time to mature. But still, if they have no mutation, still the progression-free survival hasn't been reached well, because the study has been followed or assessed as still as 33 months here. But further separation of the curve will be looked at later on, I believe, on the further application of that. But if you see here, the patient who had a mutation low at 15, still the hazard ratio of this, still patient is having the high VAF, still the progression-free survival, yet if you have a reduction in the number of the mutations or complete no mutations, that would be of a better value in these population. So this is kind of the progression-free survival. Now, if you combine it according to what we have at day at the start, or day 15, because this is a different 2 points where the blood sample has been checked. So we see clearly here that patient who had a wild type or no mutations, they are the best population compared to all the others. Why so this is patient who has no mutations, the initial mutation. However, by day 15, it has disappeared. They have the second kind of progression-free survival, and there's still patient who's having the mutation at day 15, and they don't have mutation, and also they have mutation from the beginning. These are the worst population. This is something to be of more prognostic or predictive? I believe this is what we need to. But if you see here, so wild type versus mutated type, they have the best kind of difference that was discussed significant. And then it starts at day 15. If you have no mutation at day 15 versus mutation at day 15, again, it was statistically significant in these population. So in conclusion, the presence of detectable target mutation baseline has a negative prognostic factor set even before getting exposed to the treatment. And then among patients who start the mutation at the baseline treatment with the ribo plus letrozole, and they have the valve clearance more than 50% of these population early 2 weeks, and this the pharmacodynamic modulation circulating tumor cell can give us that they have a good outcome, and their risk of progression will be low. So even it's only 2 weeks of treatment, that was enough to be predictive of a progression. And this is it's still how much the potential of adding the CD4/6 inhibitor to the hormonal treatment to improve the response as early response that we see in this patient. The no appearance of dictal mutation after the baseline stated is again, it's another kind of a good point for this population that would suggest a low risk of response. So the pre-treatment and early dynamic has been shown to be a good prognostic, kind of a good predictive marker in patient hormonal positive HER2 negative advanced breast cancer in a first-line treatment when they receive the ribociclib and letrozole. Whether this could be generalized with other CD4/6 inhibitor, well, we don't have an evidence right now with that. There's some other studies in a different style that they also suggest that valciclib. However, this is has been dedicated for this answer, and this is show clearly that the absence of mutation and early response to the combined treatment is of prognostic and predictive value. So I believe this is it's not of a clinical practice at this time. However, it will need to have more dynamic, whether we're going to see a concept of escalation or de-escalation hormone treatment. I believe further study to this finding would able to support such a protocol. Shall we if there's certain patients that we need to continue combined treatment while the others they don't need to. So I believe this is just a finding and an idea generation for further study to be included later on. This is the acknowledgement from the investigator about the patients who participated in this trial. With these, I come to the last slide of my presentation, and back to you, Fahd.
Thank you so much, Dr. Fadi, for your elegant presentation. I will move to the next speaker. The next speaker is Dr. Atlal Abu Sanad. She's a consultant and associate professor of internal medicine and medical oncology, Department of Medicine at King Abdulaziz University Hospital in Jeddah. Dr. Atlal, the floor is yours. Are you online, Dr. Atlal?
Yes, thank you very much for your introduction, and I would like to applaud Dr. Khair for this continuing successful efforts over the years. Thank you very much. And I'm going to present a very nice work that's done by Dr. Coombs from Imperial College, UK. It's a study of samuribaciclib, which is first-in-class selective inhibitor of cyclin-dependent kinase 7 in combination with fulvestrant in patients with advanced hormone receptor positive HER2 negative breast cancer. Perhaps we have all faced this challenge after having a patient progressed on cyclin-dependent kinase 4 inhibitor, 4 and 6 inhibitor. So usually we ask ourselves, what is the next in line? And we have options between chemotherapy, mTOR inhibitor, PIK3CA inhibitor if the patient has PIK3CA mutation. However, there are unsatisfactory results sometimes, specifically with toxicity, and to a lesser extent with efficacy. Hormonal treatment alone without targeted therapy is well tolerated. However, the efficacy is limited if the patient has had already cyclin-dependent kinase inhibitor. The cyclin-dependent kinase 7 inhibitor, samuribaciclib, is a once daily oral small molecule that is binding to ATP competitively and subsequently inhibiting the phosphorylation of CDK7. CDK7 is known for oncogenic activities in form of propagation of cell cycle through the phosphorylation of other cyclin-dependent kinase, as it's shown in the slide. Also, it is responsible for transcription of oncogenic and anti-apoptotic genes and activation of hormone receptor, estrogen and androgen receptors. It's been shown that it has synergistic effect when it is combined with endocrine therapy, specifically tamoxifen and fulvestrant. In vitro, the first picture shows us different concentration of samorocyclib in combination with tamoxifen and fulvestrant. And as you see here, the maximum inhibitory effect was achieved with the combination with chemotherapy, with endocrine therapy. In xenograft model, the green line shows the maximum efficacy for the combination, and it's been combined with tamoxifen. And on the last image, there is Western blot that is showing the inhibition of phosphorylation of the estrogen receptor, the first line, and subsequent also inhibition of the cyclin-dependent kinase 1, as well as RNA polymerase. So it is suppressing the CDK1 as well through inhibiting CDK7 and suppressing the RNA polymerase, which is going to reduce the oncogenic transcriptions. The study was designed to include female patients who are older than or equal to 18 years of age, histologically confirmed metastatic or locally advanced ER positive, HER2 negative breast cancer, who has a measurable disease and has had prior cyclin-dependent kinase 4 and 6 inhibitor therapy, no prior fulvestrant therapy. And they allowed patients who received one or no chemotherapy at all, and the ones who received 2 or less lines of endocrine therapy for advanced disease. The initial dose was 240 milligram once a day, combined with the standard dose for fulvestrant. And then it was escalated to 360 milligram once daily. The objective was to measure the clinical benefit rate and the objective response rate, and also to investigate signs of activity and potential biomarkers. Median age of the participant were 60, mainly, or most, all of them were females. And of course, all of them were ER positive. And majority had visceral disease at that point. I would like to withdraw your attention that liver involvement was in 45% of the patient. And almost all of them received at least one or more line of endocrine therapy. The prior cyclin-dependent kinase inhibitor therapy was given in all of them. And chemotherapy was almost in 70% of the population. This shows that the response rate or the clinical benefit rate, and you can see here, it is quite prominent in the ones who did not have liver metastasis. And the star sign indicate they were continuing on the study at the time of reporting these data. The ones with liver metastasis, though they responded as well, however, to a lesser extent than the ones who did not have liver metastasis. What was found, interestingly, is that patients who are carrier of p53 mutation did not respond to this molecule. And they are highlighted in orange or if you want, yellow. bars. The waterfall plot shows responses in the patients who did not have a B53 mutation, and the non-responder mostly has B53 mutation in blue bars. Likewise, looking at the progression-free survival by B53 status, the ones who had wild-type B53 reached up to 32 weeks of progression-free survival in comparison to only 7.9 in the ones who had a P53 mutation. So the author concluded that B53 is predictive for response of the combination of samuraciclib plus endocrine therapy. And also they reported that there is a greater impact of P53 mutation than any other study with similar medications. Patients with B53 wild-type tumor represent 70% of patients in this setting, meaning that this medication has the potential to benefit the majority of patients. Also, they looked at whether the patient has liver metastasis versus no liver metastasis, and they found that the ones who had liver metastasis did worse than the ones who did not have liver metastasis. The median progression-free survival did not reach in the patient without baseline liver metastasis. And the presence of liver metastasis is a known poor prognostic factor in patients with hormone receptor positive breast cancer. What about side effects? It was reversible, and according to the author, are quite manageable. Mainly GI toxicity of low grade. 90% of the cohort suffered diarrhea, and to a lesser extent, nausea and vomiting. Zofran or aldosterone prophylaxis was added to the protocol in the patient who was receiving samuraciclib. Neutropenia did not occur or other kind of myelosuppression in any of the patients. To conclude, samuraciclib plus fulvestrant is active in patients who already treated with cyclin-dependent kinase 4 and 6 inhibitor. Baseline tumor B53 wild type status, and it was tested through circulating DNA, may predict extended benefit from this combination in this cohort. It is going to be tested also with the oral SERD to see if it is going to duplicate the same result we're having here with the fulvestrant. And obviously it has granted fast track status by the US FDA. Thank you very much. This is the acknowledgements by the author, and I believe here we're dealing with a promising molecule for later line of treatments in patients with ER positive, HER2 negative breast cancer. Thank you.
Thank you very much, Dr. Atlan, for this outstanding presentation. Now we move to our next presentation, which will be a discussion of the previous abstracts. This will be presented by Dr. Julie Nangia. Dr. Nangia is assistant professor in the Lester and Sue Smith Breast Cancer Center, apart from the Dan Duncan Comprehensive Cancer Center at Baylor College of Medicine. Dr. Nangia, mic is yours.
Thank you. Good morning, everyone. How are you? Can you see my screen okay?
Thank you very much. We are glad to have you with us today. We can hear you very well.
Okay, perfect. So I'm going to mainly do a, today I'm mainly going to do a discussion of the circulating tumor DNA because I think in this session, those are the 3 abstracts that really go together and are worth discussing and how we move forward with this data. So there were 3 different studies, the PATA-1 trial, which was looking at circulating tumor DNA and predicting resistance in the metastatic setting, the C-TRACK-TN study that looked at ctDNA detection of relapse in early stage disease, and the BioAlta-Lee trial, which was the ctDNA looking at prognosis and response in the metastatic setting. So I'm so sorry. The screen's not working. Like, give me just 1 sec to fix this. Okay, can you see the presentation mode?
No, not yet.
I'm sorry.
No problem.
Okay, is that better?
Yes, now we can see your slide. If you can flip them. Go next slide.
Okay, are they advancing? Is it the right screen?
No, not the right screen. So we'll ask our colleagues here with technical support to help. Okay, now we can see your slide.
Okay, so in this study, I'm just going to leave it on this mode. The presentation mode's not working. So I want to give a little bit of background to this because there is a lot of evidence emerging, mainly in colon cancer and now in breast cancer, that ctDNA is really prognostic and that we may be able to start using it to target minimal residual disease in early stage, locally advanced, and metastatic disease. But this data is just emerging and we don't know the impact on things like survival, quality of life, burden of disease. So I want to share 2 kind of background studies that I thought were interesting, and then we can go into the abstracts from today in discussion. So this was data published based on the I-SPY 2 data. And what's interesting about this study is they looked at 3 different groups. And in the blue line, which is the top line here, we know that past CR is associated with very good outcomes. And when in this study, all the subjects that had past CR also had negative circulating tumor DNA. The second thing that they looked at, which is the green line under it, is patients that achieved a non-past CR but converted to negative circulating tumor DNA. And interestingly, the outcomes in this group were almost equal to those that had past CR. And this is not something that we have really been looking at as past CR plus circulating tumor DNA. So I bring this up because I think this is an area that we can maybe start to look into even retrospectively in trials that have been done. Now, this third group is the subjects that did not have past CR and had circulating tumor DNA. And as you can see, they had a very high rate of distance-free recurrence. And so those are really the target population where we can try to change therapy and prevent recurrence or at least try to increase survival. The second kind of background study I want to look at is this meta-analysis looking at circulating tumor DNA. And this was in all settings, early stage, locally advanced breast cancer and metastasis. And this was published in JAMA just this year. And what they found was that elevated circulating tumor DNA, regardless of the setting, was associated with poor outcome. And this just kind of is a re-emphasis of the data that we know and a summary of the data to date. So let's first go and review kind of a summary of the data from the BioAlta-Lee trial. So this was a very interesting study. This was in metastatic patients. They were 287 patients that had hormone receptor positive, HER2 negative breast cancer. They had no prior systemic therapy, and they had to have at least 12 months before they had progression of disease and became metastatic. In this study, they got first-line ribociclib at standard dosing plus letrozole. And they looked at circulating tumor DNA at 4 different time points. They looked at baseline, day 15, day 1 of cycle 2, which was day 28, and then 3 months after therapy. And the primary objective of this study was to really look at circulating tumor DNA alternations, how they evolve, and evaluate their possible associations with clinical outcomes. So to evaluate the circulating tumor DNA, each of these studies are using a little bit different panels, but in this study, they used the 533 Amplicon Custom HD panel, and they found target mutations. And if there were multiple mutations, they picked the one that had the highest variant allele frequency. And it's difficult to do studies like this, but you do wonder, does type of mutation matter? So it would be nice to see some of those details of the study. For example, ESR1 mutations versus FGR versus some of these other mutations. So I think that when this data is published, that's something that I really look forward to seeing more information on. And they defined variant clearance as 100% in the target mutation so that it was undetectable. And they then did multivariant Cox models to look at the patient status, if they were de novo recurrent versus previously treated, luminal A versus B, if they had visceral mets, and the number of organs involved. So this next chart is looking at response. So this top curve is the rate of variant clearance at day 15. And the bottom curve in blue is if it was not cleared at day 15. And what you can see is there was a huge difference in progression-free survival. It was 12 months versus almost 22 months. So there was almost a doubling in progression-free survival in those that cleared the variant if it was detected. Okay, so this next slide is looking at acquired mutations. So about 22% of these that had no baseline variant mutation acquired mutations, and those were also associated with worse prognosis. So this curve is basically looking at wild type, so patients that did not have any variant mutations in this blue curve, mutated with low variant frequency, and mutated with high variant frequency. And you can see that the progression-free survival goes down with the more mutations that you acquire. And what the other thing that is very interesting in this is the top line is the wild type, and this light blue line is actually subjects that had high variants but cleared it by day 15. So that actual clearance of the variant is very important in prognosis and how patients do. And then in subjects that were wild type initially and acquired mutations, they did not do as well as those that had mutations and cleared them. And then subjects that had variants and did not clear them had the worst prognosis in this group. So in summary from this study, good prognosis was associated with no detectable mutation at baseline if the ctDNA cleared by day 15. Poor prognosis was associated with the presence of detectable mutation at baseline, and if they had any detection of ctDNA at day 15, even if it was negative at baseline. So I think the big thing that we can take away from this abstract is that the clearance of ctDNA, it is very clear, has prognostic value. We know that when someone has positive variant mutations, that they do not do as well. And the bigger question is, what do we do with that information? Can we change their prognosis? Do we actually increase their overall survival if we change therapy sooner? So for example, the next abstract I'm going to present is looking at that. Or do we just burn through therapies faster and the overall survival is the same? I think that's one of the biggest questions that remain out there. The other thing that's important is maybe if overall survival is not changed, do we change their quality of life? Do changing them from pills to injections cause worse quality of life? Does having a lower disease burden because we control their disease for longer improve quality of life because they don't develop painful bone metastases or fractures or end up hospitalized with different things? So I think it's important that we also look at quality of life when we look at these things. So the next abstract, which is a good lead in from this first one, is an incredibly interesting design where we're looking at basically minimal residual disease in breast cancer patients. So these were patients that were started on AI and Palbo, and then if they detected an ESR mutation, that was only in blood, so they did not have progression of disease radiographically. The treatment was changed to AI and fulvestrant. And so the idea was, does early change of therapy improve outcomes? So in this study, they had about 1,000 patients included that were treated with AI and Palbo. They had 400 of those that had a progression-free survival that did not acquire an ESR1 mutation. So this was really targeting patients that acquired ESR1 mutations in the blood. Of those that acquired ESR1 mutations, there was 279 patients. 60 of them had a radiographic progression. So those patients were excluded because they were targeting minimal residual disease, so only detectable in the blood and not on scans. And of the 172 patients, 84 were allocated to continue on AI and palbociclib, and 88 were allocated to change therapy to fulvestrant and palbociclib. And from the background of this study, I think we all know that fulvestrant is known to kind of help overcome ESR1 resistance. So what you can see in this study is the top line in light blue is the palbociclib fulvestrant, and the PFS was 11.9 months in this arm. The bottom curve in navy blue is the Palbo plus AI, and the PFS was 5.7 months. So there was a doubling in progression-free survival, but the question is in this navy blue arm that was standard of care, if they had just changed therapy at the time of radiographic progression, would they have done just as well? And from this study, their conclusion was no, that you do gain some progression-free survival time. So they crossed over patients that were on this AI Palbo arm, the standard of care arm, and at progression changed them to fulvestrant Palbo to try to address this in the best way that they could. And although there was a doubling in progression-free survival, when you add the fulvestrant, which you've burned through that therapy now, you gained about 2.7 months. And you also gained perhaps some quality of life there. We don't know because they didn't report out that data. And so I think the question is this going to really have an impact on overall survival? Does it change quality of life? But this data really is very interesting, and I think we need to design more studies to look at these outcomes and perhaps go back to some of our older studies that we have where we have information on circulating tumor DNA and see if the patients that had detectable circulating tumor DNA had worse outcomes. I think that's something we can do retrospectively. So the third study in this group of abstracts that was looking at ctDNA was presented by Nick Turner, and it's the CTRAN-TN study. And this was really looking at minimal residual disease in triple negative patients, and can we target it? And Nick did a great job with this study. It was complicated because of COVID, and so they were unable to do everything in the way they originally intended to. So in this study, they looked at early stage triple negative breast cancer, and they had neoadjuvant chemo. If there was residual disease, they got chemo after. And they defined patients in this study and basically pulled out patients that were moderate or high risk for recurrence. And when patients were actively getting surveillance with ctDNA that were moderate or high risk, so these are patients that had tumor left or were node positive, they basically randomized them in a 2-to-1 fashion to intervention with pembrolizumab versus continuing standard of care and looking at ctDNA samples just to see how they did. And what you can see was that there were 208 patients that registered. Of these, 171 had trackable mutations. 10 of them withdrew mainly because of recurrences withdrawal. And then 161 of these subjects continued to the ctDNA surveillance. And they defined, and I think this is really important because I think they were targeting high-risk disease, but they didn't realize how poor the outcomes with these high-risk disease patients would be. So in the high-risk disease, they defined it after neoadjuvant therapy as having residual axillary lymph nodes that were positive, or if they had primarily had surgery that the tumor was over 5 centimeters node positive or 4 or more positive lymph nodes. And moderate risk was defined as having either residual invasive disease any amount after neoadjuvant therapy, or after having upfront surgery, a tumor greater than 2 centimeters or lymph node positive. So what you can see is the median follow-up in this study was 20 months, and that at the 12-month time point, a lot of patients recurred, and 55% of patients in the high-risk group recurred and 11 in the moderate risk. And they basically, the problem is all of these patients had radiographic overt disease. About 72% of them had clinical progression. And of the 9 patients that were ctDNA positive and staging negative, 5 started treatment with pembro. So this is really, I think, the group that is of the most interest. And 1 of the 5 has had continued response to pembro. So these numbers are incredibly small, but out of the 5, there's a 20% response rate with pembro. So maybe this is of interest. And, you know, the Keynote trial is looking at pembro in the curative intent setting. I think it'd be very interesting moving forward to follow circulating tumor DNA in these patients that were positive, and if they convert to negative, if the outcomes are changed even in the curative setting. So we'll see what that data shows. And this is another slide basically showing that there was a high rate of overt metastatic disease. So this population was so high risk, we really did not detect the cancer by circulating tumor DNA. So in retrospect, everything's always easier in retrospect. The timing of looking at ctDNA in high-risk patients like triple negative really probably needs to start earlier. Is there a utility in patients that are this high risk for recurrence? Are we going to do anything different than we're already doing? And one thing that I'm thinking of is now in the triple negative world, there is data with pembrolizumab, there is data with capecitabine. If you're BRCA positive, there is data with adjuvant PARP. I'm wondering if looking at ctDNA can be a predictor of lack of benefit of these therapies, and maybe that will help us decide early on. For example, if someone's on capecitabine and then they develop circulating tumor DNA, do we change them to immunotherapy? Do we do something different? So I really think that is a place where the circulating tumor DNA may have a lot of utility. So this is my last slide. The other thing I want to kind of go back to is that original slide because I find this fascinating. we have all been so set on past CR. We want patients to get past CR, but maybe we don't need a full past CR. Maybe what we need is a near past CR with clearance of the circulating tumor DNA, because it looks like patients that have clearance of circulating tumor DNA do almost as well as those that have past CR. So I would be very curious if we can go back in some clinical trials that have looked at past CR to see if near past CR plus of ctDNA patients did much better. Thank you, everyone, for inviting me and for letting me discuss these cases.
Thank you very much, Dr. Nanjia, for this very informative review of the abstracts. For the sake of the time, we will end this session. For the sake of schedule of everybody, I would like to thank all speakers, Dr. Shahina Dawood, Dr. Hikmat Abdul Razak, Dr. Hamid Al-Shamsi, Dr. Shadi Khayyat, and Dr. Talal Abu Sanad, and Dr. Julie Nanjia. Also, I'd like to thank my co-chairs in the session, Dr. Hiba Al-Dawahri, Dr. Ahmed Al-Warith, and here Dr. Sad Al-Rifai. But we are promised to continue the joyful learning experience with the next session. And I would like to call Dr. Abdul Aziz Saif, who's professor in surgery and consultant endocrine and breast surgery and the program director of the Endocrine and Breast Surgery Fellowship Program in King Saud University.
Assalamu alaikum. Masā al-khair. Good afternoon, everybody. I would like to call my co-chair, Dr. Khalid, Dr. Jamila, Dr. Lulu, and Dr. Lubna. So without any further delay, we'd like to start this session, which is imaging and local therapy. We're going to have 6 very interesting talks. Our first talk will be delivered by Dr. Aida Al-Awadi. And Dr. Aida, it gives me a great pleasure to introduce her. She's a consultant, medical oncologist from MD Anderson. Dr. Aida will talk about the impact of race and ethnicity on the incidence and severity of breast cancer-related lymphedema after axillary lymph node dissection, results of a prospective screening study. Please.
I hope you guys can hear me very well. Thank you so much for inviting me to present in this conference, and particularly I would like to thank Dr. Al-Khair for this fabulous, well-organized conference. So my abstract will be on the impact of race and ethnicity on incidence and severity of breast cancer-related lymphedema after axillary lymph node dissection, which is the result of a prospective screening study. It was presented by Dr. Andrea Barrio from the MSK Cancer Center. So breast cancer-related lymphedema is frequent and feared complication following axillary surgery for breast cancer. It is also a chronic and disabling progressive condition which negatively impacts quality of life. It typically occurs within 2 years after axillary lymph node dissection, with recent study demonstrating peak incidence after axillary dissection and nodal radiation of about 18 to 24 months. Axillary lymph node dissection remains the main risk factor for lymphedema. Other risk factors, including older age, increasing BMI, systemic chemotherapy, particularly with taxanes, and radiation therapy, are inconsistent across studies. Epidemiological studies have reported an increased susceptibility to lymphedema in Black women. Prospective clinical data, however, is lacking. Lymphedema risk in other racial minorities has not been well studied, and the impact of modern therapy, such as neoadjuvant chemotherapy on lymphedema, is uncertain. So the aim of this study is basically to assess the incidence of lymphedema in a prospective cohort of patients treated with axillary lymph node dissection, to identify risk factors associated with lymphedema development, and to evaluate the impact of race and ethnicity on lymphedema incidence and severity. So they enrolled patients in this prospective cohort from November 2016 till March of 2020. Eligible patients included those female with breast cancer, patients were above or equal to 18 years of age, and those with unilateral axillary lymph node dissection in the primary setting or after sentinel lymph node biopsy. They excluded patients with prior history of unilateral or contralateral sentinel lymph node biopsy or axillary lymph node dissection. So they basically excluded these patients as these factors could interfere with the accuracy of the volumetric measurement. And obviously, all patients gave written informed consent to participate. So lymphedema was defined sorry, I jumped between slides. So yeah, so the volumetric R measurements were taken with a pyrometer, which uses a sliding bilateral measurement and an infrared line sensor to measure lymph node volume with high degree of accuracy. And the measurement was basically done at baseline, post-operatively, and then every 6 months for a total of 2 years. Lymphedema was defined as a relative increase in arm volume of more than or equal 10% from baseline diagnostic of lymphedema, as you can see, using the formula listed below, where A1 and A2 were the volume of affected arms at baseline, and follow-up, and U1 and U2 are volume of the unaffected arms at baseline and follow-up. Of course, the equation accounts for the arm asymmetry that naturally occurs at baseline, and use the contralateral arm as a control to account for changes in arm size other than lymphedema. So patient variables such as BMI and volumetric arm measurements were prospectively collected. Race and ethnicity was self-reported. And the clinical and treatment variables were retrospectively collected. In terms of the statistical analysis, clinical pathological characteristics were compared between racial and ethnic groups. Kaplan-Meier cumulative incidence plots were constructed to estimate cumulative incidence of lymphedema. Uni and multivariable logistic regression or analyses were used to identify factors predictive of lymphedema. Lymphedema severity was compared across racial and ethnic groups by evaluating the maximum relative volume change across all time points. So from November 2016 to March of 2020, they enrolled about 827 patients, of which 411 had sentinel lymph node biopsy alone, and they were ineligible to remain in the study. 112 patients were ineligible to begin with, and for a variety of reasons, and 304 patients remained in the study, and those who had axillary lymph node dissection. 276 patients had at least one longitudinal measurement after baseline and compromised study cohort. So in terms of patients' characteristics, median age was 48 years. Median baseline BMI was 26.7. 60% were white, 20% were Black women, 11% were Asian women, and 6% were Hispanic. Most of the patients had a clinical T2 and 3 disease. Most of the patients had node-positive disease. Majority of patients had ductal carcinoma in terms of histology, and obviously, most of the patients had hormone receptor positive, HER2 negative disease as expected. So 70% of the patients received neoadjuvant chemotherapy, and the remainder had upfront surgery, with majority had received adjuvant chemotherapy. Of all the patients who had chemotherapy, 94% of the patients received a taxane-containing regimen. 75% of patients had mastectomy, and majority had a reconstruction. 95% of the patient received radiation therapy, and 93% received nodal radiation. The median number of lymph nodes removed is 18, and the total number of positive lymph nodes was 2. So this table basically shows clinical characteristics stratified by race and highlights a characteristic that differs between the groups. White and Black women were older. Black and Hispanic women had higher baseline BMI. Black women were more likely to present with clinical N1 disease, whereas Hispanic women were more likely to have N2 to 3 disease. Black and Hispanic women were more likely to undergo breast conserving surgery. Also, Black and Hispanics had higher number of lymph node involvement or removed and more likely to receive a radiation therapy. So these additional factors did not differ by race and ethnicity. Most importantly, clinical T-stage, histology, receptor subtypes, receipt of neoadjuvant chemotherapy, total number of positive nodes, and of course, receipt of any radiation therapy. So at the median follow-up of 22.6 months, 56 of the patient developed lymphedema. 24 months lymphedema rate was 24.7%. So the incidence of lymphedema varied significantly by race, ethnicity, and highest in Black women with a 24 months lymphedema rate of 39.4%, followed by Hispanic 27.7%, Asian 23.4%, and White 20.5%. The incidence of lymphedema did vary by treatment groups, with 24 months lymphedema rate of 31% in the patient who received neoadjuvant chemotherapy versus 11.1% in those who received upfront surgery, which is very interesting. In the univariate analysis, increasing, as you can see, increasing age, increasing BMI, a Black race, number of lymph nodes involved, and number of positive lymph nodes were all associated with increased risk of lymphedema development. Also, neoadjuvant chemotherapy versus upfront surgery and time from surgery per 6 months increase were also associated with increased risk of lymphedema. However, mastectomy, when compared to breast conserving surgery and HER2 positive biology, were actually associated with reduced risk or were not associated with increased risk of lymphedema. However, these factors in the univariate analysis were not associated with lymphedema development, including change in BMI, arm dominance, clinical T-stage, clinical node stage, histology, extracapsular extension, and so forth. So in the multivariate analysis, Black race was the strongest predictor for the development of lower of lymphedema, with 3.5-fold increase in risk when compared to White women. Hispanic had 3.1-fold increase in risk of lymphedema. Receiving neoadjuvant chemotherapy was also associated with 2-fold increase in lymphedema. Increasing age and increase in time from surgery was associated with modest increase in the risk of lymphedema. However, BMI, receptor subtype, number of lymph nodes involved, number of positive lymph nodes, and type of breast surgery did not show any significant in terms of increasing the risk of lymphedema. And in these patients with lymphedema, there were no difference in severity noted across different race and ethnic groups, with similar volume changes noted. So here are the strengths and limitations of the study. The strength, including it's a prospective design, it's a large number of patients treated with axillary lymph node dissection included. There were, as you saw, strict measurement protocols, and the diversity of study population was apparent. In terms of limitation, short medium follow-up, although most lymphedema occurs within first 2 years, unable to assess independent effect of nodal radiation on lymphedema risk, as most receive a radiation therapy, and this is a very important point to highlight. So to conclude, higher incidence of lymphedema in Black women treated with axillary lymph node dissection and radiation therapy after adjustment for other variables, and similar findings observed in Hispanic women, but confirmation larger data set is definitely needed. Neoadjuvant chemotherapy significantly increased lymphedema compared to adjuvant therapy women undergoing axillary dissection radiation therapy, but the question is, why? So some theory behind that, so the obvious reason is unknown, but some theories behind that is that neoadjuvant chemotherapy may cause fibrosis of tumor-filled lymphatics, as well as lymphatic endothelial damage prior to surgery, resulting in higher lymphedema rate after axillary dissection. And in patient subset unlikely to achieve nodal PCR, example those with hormone receptor positive, HER2 negative, they concluded that alternative methods to neoadjuvant chemotherapy to avoid axillary lymph node dissection are needed. Also, etiology for higher observed incidence of lymphedema in Black women is unknown, but it could be due to race-based differences in inflammatory reaction, tissue fibrosis, lymphatic function, maybe genetics factors as well. So future studies should address the biologic mechanism behind racial disparities in lymphedema development. So with that, I conclude my presentation, and thank you so much again for inviting me to present in this conference.
Assalamu alaikum. Good day, everybody. It's my pleasure to introduce Dr. Stacy Carter. She's an assistant professor of surgery with a of surgical oncology with a special interest in breast. She's working at Dan Duncan Comprehensive Cancer Center, Baylor College of Medicine, Houston, Texas, United States. Her talk today, she'll present two abstracts today. The first one is about patient-reported outcome for the integrated group of Sentinel Mama study and the impact of axillary surgery on patient arm and breast symptoms. And the other talk will be about preservation of axillary lymph node dissection of axillary lymph node in comparison with completion dissection in T1, T2 breast cancer patient with limited lymph nodal metastasis. Dr. Stacy, the mic is yours.
Thank you very much. Can you hear me and see my slides? Can you hear me?
Yes.
Okay, great. Thank you to the conference organizers for the privilege of the podium this morning. My name is Stacy Carter, and I'm a breast surgical oncologist at Baylor College of Medicine. Like she mentioned, I have the honor to highlight two presentations this afternoon from the San Antonio Breast Cancer Symposium. Both abstracts are relevant to me as a surgeon, and I hope that you will find them equally as engaging to the care of breast cancer patients. The first study is the ENSEMA trial and patient-reported outcomes on the impact of axillary surgery on arm and breast symptoms. This trial was designed to look at de-escalation of axillary surgery in early breast cancer patients. This was initially presented by Dr. Gerber on behalf of the ENSEMA investigators. With regards to disclosures, most importantly, I want to highlight that none of the information I'm presenting today is my own data, and it belongs to the wonderful team of investigators leading these trials. It is an honor to present their work, and I hope that I can preserve their message this morning. We have seen a dramatic de-escalation in the extent of axillary surgery in recent years, as sentinel lymph node biopsy has replaced axillary lymph node dissection as the standard of care in clinically node-negative patients. There has been growing interest in abandoning sentinel lymph node procedures altogether, but we need good evidence to ensure that the benefits outweigh the risk. There is no level 1 evidence demonstrating that omission of sentinel lymph node biopsy will improve quality of life. And there needs to be, we need to validate suitable alternatives to sentinel lymph node biopsy as a guide to adjuvant radiotherapy decision-making. Previous studies have shown high local regional control rates even without axillary lymph node dissection. Despite increasing evidence supporting sentinel lymph node biopsy alone, axillary lymph node dissection remains part of breast cancer treatment guidelines. Current approaches utilizing tumor biology and more effective systemic treatment emphasize the need for ongoing reevaluation of the standard local therapy. Quality of life considerations are the primary motivation for abandoning sentinel lymph node procedures. The ENSEMA is a prospective randomized multicenter trial consisting of 2 randomizations. The primary objective of the trial is to compare invasive disease-free survival after breast-conserving surgery between no axillary surgery and sentinel lymph node biopsy. The second objective is to compare invasive disease-free survival after breast-conserving surgery between sentinel lymph node biopsy alone and completion axillary lymph node dissection. The topic of this talk is to highlight the quality of life for these 2 groups of patients. Now, looking at the study design, the main inclusion criteria include clinically node-negative disease, tumor up to 5 centimeters, planned breast-conserving surgery, and postoperative radiotherapy planned. The first randomization was between patients that had no sentinel lymph node biopsy versus sentinel lymph node biopsy, and they were randomized in a 1-to-4 fashion. The second randomization took any patient with a macrometastasis in the lymph node and randomized them in a 1-to-1 ratio between sentinel lymph node biopsy alone, that is no additional surgery, and a completion axillary lymph node dissection. Patients with micrometastasis were excluded from the second randomization. Patient-reported outcomes were assessed at baseline, pre-surgery, and at 1, 3, 6, 12, and 18 months after final axillary surgery using the European Organization for Research and Treatment of Cancer Quality of Life questionnaire and its breast cancer module. A high healthy level of functioning is represented by a high functional score. A high quality of life is represented by a high score for global health status or quality of life. More severe symptoms or problems are represented by high symptom scores or items. A score difference of 5 or greater is considered a clinically meaningful difference. With regards to statistics, the quality of life scores were analyzed using repeated measures of mixed time effects models leading to p-values for treatment and time and the interaction of treatment by time. Postoperative whole breast radiotherapy was mandatory for all patients. I want to point out that the authors of this study note that ipsilateral axillary region was not included in the target volume. In total, 5,202 patients were consented, with 348 later excluded for reasons noted in the top right, which left 5,154 patients in the intent to treat group. Of these, they were randomized in a 1-to-4 fashion between no sentinel lymph node biopsy and sentinel lymph node biopsy. Sentinel lymph node biopsy was negative. This has also included the patients that had micromets in 3,565 patients, and notably only 12 patients had more than 4 sentinel lymph nodes that were positive. 478 patients, which was 12% of the sentinel lymph node biopsy group, had macrometastases in 1 to 3 sentinel lymph nodes and were included in the second randomization in a 1-to-1 fashion between sentinel lymph node biopsy alone and completion axillary lymph node dissection. 40 patients were directly randomized. Now, this is a very busy slide, but you can see the treatment arms were well balanced with respect to age, tumor size, grade, and receptor status. As you can see, most patients had tumors that were small, under 2 centimeters. They were grade 1 or grade 2, and they were hormone receptor positive and HER2 negative. Taken together, as we can see that as a whole, the study population was a very low risk cohort. Questionnaire completion response remained high throughout the trial, with over 60% at all time points, and there was no significant difference in treatment arms with regards to response rate over time. The quality of life assessment for the first randomization, reminder, this is between the patients that underwent sentinel lymph node biopsy, which is the pink line, versus no sentinel lymph node biopsy, which is the green line. Each graph depicts a different assessment: global health status, physical functioning, role functioning, and emotional functioning. There was no difference between the curves, although the authors point out that because of the high case number in the first randomization, there was a small difference detected, but this was not thought to be clinically meaningful. Same is seen for cognitive, social functioning, and body image, but again, no clinically meaningful differences were detected. There was significant difference for breast symptoms and arm symptom scores favoring the no sentinel lymph node biopsy group in post-baseline assessments. However, these differences were clinically meaningful only for the arm symptoms shown on the curve on the right. Results of the second randomization, these were the node positive patients that were randomized in a 1-to-1 fashion between sentinel lymph node biopsy alone, which is the pink line, and completion axillary lymph node dissection, which is the red line. There were no relevant differences in the global health score, functional scales, and body scales between completion axillary lymph node dissection and the sentinel lymph node biopsy groups. As we might anticipate, there was significant and clinically meaningful differences only on the arm symptom scores favoring the sentinel lymph node biopsy group in post-baseline assessments, as you can see on the curves on the right. Now, the next 3 slides will consider arm symptoms separately. First randomization on the left, we see a meaningful lower pain in arm and shoulder favoring patients that had no sentinel lymph node biopsy compared to sentinel lymph node biopsy. The second randomization on the right, we can see a meaningful lower pain in arm and shoulder score in patients that had sentinel lymph node biopsy alone versus completion axillary lymph node dissection. The biggest difference was seen directly after surgery, and the difference remained stable during the whole follow-up period. The same advantage is seen for swelling in the arm and hand. In the first randomization, you can see the symptoms were higher in the sentinel lymph node biopsy group, again, that pink line. And in the second randomization, you can see that there was a significant difference, as expected, and more pronounced in the patients that underwent completion axillary lymph node dissection, again, in that red line. And finally, limited arm mobility favored those that had no sentinel lymph node biopsy and those with sentinel lymph node biopsy alone when compared to axillary lymph node dissection. The greatest difference was seen in the first 6 months, and after 6 months, the curves approached each other. In conclusion, the ENSEMA trial with over 5,000 patients is one of the first randomized trials and the biggest investigating omission of sentinel lymph node biopsy in clinically node-negative patients, and the first to report comprehensive quality of life data. For the first randomization, patients with no sentinel lymph node biopsy had improved breast and arm symptoms compared to those with sentinel lymph node biopsy. It is important that all observed differences for pain in arm and shoulder, swelling in arm or hand, and limited arm mobility persist over the complete follow-up period. Patients in the sentinel lymph node biopsy group had improved arm symptoms and functioning compared to those receiving completion axillary lymph node dissection, as we all might suspect. Patients in the sentinel finally, there was no relevant differences in other quality of life scales that were seen. We are very eager to see the follow-up of these patients. It is ongoing. We continue to support this trial. The invasive disease-free survival data, which was the primary outcome, are expected to be shown at the end of 2024. Again, I want to thank Dr. Gerber, who presented this data at the San Antonio Breast Cancer Symposium, and the entire ENSEMA investigator group, looking at what impact we as surgeons have on axillary surgery. Also, a huge thanks to the patients and their families for participating in this trial. It is their participation that is shaping the face of breast cancer care. Thank you. I will move into the next presentation that I have, which is the Synodar 1 trial, originally presented by Dr. Gentili, looking at the preservation of axillary lymph nodes compared to complete dissection in T1, T2 breast cancer patients presenting with 1 to 2 metastatic sentinel lymph nodes, a randomized clinical trial. Axillary lymph node dissection has always been a part of breast cancer treatment, as we just saw. However, the surgical management of the axilla has shifted to a more conservative approach. Axillary lymph node dissection is an effective procedure for staging, Although it comes at significant risk, we see pain, lymphedema, numbness, and restrictive shoulder movements. Sentinel lymph node biopsy has replaced axillary lymph node dissection as the standard of care in no-negative patients for axillary staging. But axillary lymph node dissection has remained the standard surgical approach for patients with macrometastatic disease in the sentinel lymph nodes. So as our adjuvant therapies get better and better, we have to ask, is complete axillary lymph node dissection over treatment for early breast cancer? Consider, diagnosis tends to be earlier because of screening mammogram. Less than half of patients with sentinel lymph node metastases present with additional metastases. The majority of sentinel lymph node positive patients that do not undergo axillary lymph node dissection will receive chemotherapy and/or endocrine therapy, maintaining a low local regional recurrence rates. ACOZOG Z11 randomized clinical trial questioned the therapeutic benefit of axillary lymph node dissection in patients with sentinel lymph node metastases. Patients undergoing breast-conserving surgery and whole breast radiotherapy with 1 to 2 metastatic lymph nodes were randomized to axillary lymph node dissection or no further axillary treatment. At 9.3 years, the overall survival for patients treated with sentinel lymph node node dissection alone was non-inferior to the overall survival for those treated with axillary lymph node dissection. Many have raised concern about the study limitations for the Z11 trial, including there was premature enrollment conclusion, too many patients were lost to follow-up, half the patients presented with micrometastatic disease. There was a lack of radiotherapy quality assurance with missing data for more than 2/3 of the patients. And there was a significant number of protocol deviations with regards to radiotherapy and the use of high tangent fields. Some have raised concern that these limitations make it difficult to generalize the findings of the Z11 trial and confound the interpretation of the final results, particularly with regards to being able to extrapolate the generalized findings beyond the low-risk study population. For these reasons, the authors of this study proposed the SYNODAR-1 trial, an Italian multi-center randomized clinical trial. Prospective non-inferiority multi-center randomized study, it is aimed at assessing the therapeutic role of axillary lymph node dissection in patients undergoing breast-conserving surgery or mastectomy for T1, T2 breast cancer presenting with 1 to 2 macrometastatic sentinel lymph nodes. Enrollment ended in April of 2020 and the follow-up is ongoing. So we can see here the study design of SYNODAR-1. It took T1 or T2 tumors that had 1 or 2 sentinel lymph nodes that were positive, that were undergoing breast-conserving surgery or mastectomy, and they were randomized to one of 2 treatment arms, the standard treatment, which was axillary lymph node dissection, or the secondary treatment arm, which was sentinel lymph node biopsy alone. Adjuvant therapy was determined according to the breast unit multidisciplinary meeting. Excuse me. You can see here the enrollment criteria. They looked at anyone between the ages of 40 and 75 with an invasive breast cancer that was unilateral and unifocal. The tumor size was under 5 centimeters. Important to note, all of these patients were clinically node negative as confirmed with an ultrasound assessment, and none of them received neoadjuvant therapy. So the randomization of the patients ended in April of 2020 with 889 patients randomized. The 2 treatment arms had a generous number of patients in each arm, with only a few patients excluded for missing data or errors in randomization. And here we can see the axillary treatment results. There was a mean of 2 sentinel lymph nodes excised between both treatment arms. With regards to the type of metastasis, a majority of the patients in each arm had macrometastasis. In fact, there were only 5 cases of micrometastasis among the two arms combined. Again, highlighting that this cohort of patients had a burden of disease that was greater than what we were really seeing in the Z11 trial. And in the blue table, the final row, this is what we want to know as a surgeon. How much disease is in the axilla beyond the sentinel lymph nodes? What would we be leaving behind? Well, 44% of the patients had additional positive macro metastatic non-sentinel lymph nodes with a mean of 1.4 non-sentinel lymph nodes that were positive and found. And then here you can see the type of surgery these patients were undergoing, with about 75% of the patients undergoing breast conserving surgery. The rest were getting mastectomy. I will remind you again that the Z11 trial, because of the study design, was only capturing patients that were undergoing breast conserving surgery. Here are the follow-up and survival data, only 16 events in the standard arm and 20 events in the experimental arm, 4 cases of mortality in each group, only 1 case of axillary recurrence in each group, 3 ipsilateral recurrences in the experimental arm. For distance recurrences, there were 7 cases in the standard arm and 8 cases in the experimental arm. Importantly, there was no statistically significant difference was found in terms of survival and recurrence between the 2 different treatment groups. The follow-up was similar between the 2 groups with 34 months overall. When they analyzed the long-term oncologic outcome in terms of recurrence-free survival and overall survival, we can see in the intention to treat and per protocol groups, there was no statistically significant differences between recurrence and survival. Additionally, when they analyzed the long-term oncologic outcomes and the intention to treat population, with the blue bar being the axillary lymph node dissection and the red bar being sentinel lymph node biopsy alone. Now, important, we all wonder, well, what is really the timing of an axillary recurrence? We remember that most events in the axilla happen within the first 3 years. We can see that the authors of this trial looked at a number of studies who examined this question, and the range is between 14 and 32 months. And the Synodar trial, which I have just presented, resulted with 34 months of follow-up this far. So when we put Z11 head-to-head with the Synodar 1 and compare the data, we can see that Z11 concluded with a median follow-up of 9.3 years. Synodar 1 enrollment ended in April 2020, and the follow-up is ongoing with a median time of 34 months. Looking at the differences in the micrometastatic data, we can see that nearly 40% of patients had micromets in the Z11 group, and only 5 patients overall with micrometastatic disease in the Synodar 1 trial. In Z11, there was detailed radiotherapy available in less than 30% of the patients, whereas the Synodar 1 trial, over 70% of patients had radiotherapy data available. With regards to surgery, per the study design, no patients underwent mastectomy in the Z11 trial. Synodar 1 included these patients in their study arms. So in summary, the study was designed to look at the oncologic outcomes in less versus more axillary surgery. The trial was really trying to revisit the North American Z11 trial, which had demonstrated and addressed some of what others may consider faults in the trial. Keeping this in mind, there is overlap between the results, and it begs us as surgeons to consider if it is reasonable to continue to propose axillary lymph node dissection in patients that meet this study selection criteria. I think the bottom line is that this study looked at patients that had macrometastasis, and regardless of whether an axillary lymph node dissection was done, the axillary recurrence rate or sentinel lymph node biopsy, the axillary recurrence rate was very low. And perhaps as a surgeon, we need to rely more on the systemic therapy than anything else. Again, I want to deeply appreciate the organizers for the opportunity to present these important surgical studies. I think we continue to move the needle in the right direction and appropriately de-escalate treatments and improve the outcomes and the quality of life of our patients. Thank you so much for having me.
Thank you so much for this excellent presentation. Good afternoon, everybody. And I would like to introduce Dr. Tamara Ortiz. She is an associate professor of radiology at the Breast Care Center at Dan Duncan Comprehensive Cancer Center at Baylor College of Medicine at Houston, Texas. She's also the program director of the Breast Imaging Fellowship at the same institute. And she's also a faculty inclusion ambassador for the Inclusion and Excellence Council at the Baylor College of Medicine. And she is going to present an abstract about the estimation of breast cancer overdiagnosis in a US breast screening cohort. Dr. Ortiz, the floor is yours.
Thank you so much, everybody, for having me here today, sharing this abstract presentation at the San Antonio Breast Cancer Symposium. I will be sharing my slides. Can everybody see my screen?
Yes. Okay.
Thank you. Thank you. So I will be presenting this abstract titled Estimation of Breast Cancer and Overdiagnosis in a U.S. Breast Screening Cohort. And this was presented by Mark D. Reiser, and it's work, a collaborative work with this team. They did not disclose any conflicts of interest. So breast cancer overdiagnosis has been defined in the literature as mammographic detection of breast cancers that would not have caused symptoms or other harms in the woman's remaining lifetime. There are two sources of overdiagnosis as identified by the researchers. The first one is the detection of non-progressive cancers, which are described as indolent or preclinical, meaning before the detection, before the development of symptoms, and the progressive cancers, which are, in the absence of screening, would not have become symptomatic before the patient dies from other causes. Breast cancer overdiagnosis arises from the competition between tumor latency and other mortality, other cause mortality. The onset of asymptomatic disease, which is delineated here in this graph as time 1, followed by tumor latency, and then subsequent presentation of clinical disease, which is labeled here as time 2. If the screen detected cancer, the screen detector cancer takes place at time 3. If this is diagnosed before onset of symptoms and death from unrelated causes before the end of the latency period happens, then this was considered overdiagnosis because it would not have happened without the screening, would not have happened in terms of like the detection. However, if the screen detected cancer at time 3 is diagnosed beyond the tumor latency period, then the screening detection at time 3 is not considered overdiagnosis. There is a lack of consensus about the true extent of breast cancer overdiagnosis, despite a large body of literature that is available. Published estimates of overdiagnosis, specifically in this graph that is depicted, is from Nelson et al., published in the Annals of Internal Medicine. The published estimates range from anywhere from 0% to 54%. Now, the reasons for this variability, there are different reasons for it, and they include differences in overdiagnosis definitions, in study populations and study designs, as well as statistical methods used for estimation. Excess incidence approach is one. There are two main statistical models that are used: the excess incidence approach and the model-based approach. The excess incidence uses the empirical comparison of cancer incidence, uses the empirical comparison of cancer incidence in screened versus unscreened populations to directly estimate the frequency of excess cancer cases, and then attributes all excess cancer cases to overdiagnosis. The other approach, which is the model-based approach, first learns the tumor latency from incidence patterns in its screened population and then translates the estimated tumor latency to overdiagnosis, while taking into account for the competition from all-cause mortality. The main critique for the excess incidence approach is that it probably leads to overestimation in most settings. The main critique for the model-based approach is its general lack of transparency and the use of oversimplifying assumptions, such as, for example, all tumors are considered progressive. So the objective of this work was to produce a reliable model-based estimate of breast cancer diagnosis that address the different limitations of prior studies. For it to be robust, flexible, transparent, and rigorous. So the methods for the study, first the study population. To ensure robustness of their estimates, they work with data from the Breast Cancer Surveillance Consortium, which is regarded as representative of the breast cancer screening population in the US. They considered an authoritative data source of contemporary mammography practice in the US, as well as a cohesive set of data assets that provide trusted, timely, and secure information to support a process. Inclusion criteria, the women between the ages of 50 and 74 were included, and those included had their first screening mammogram in a breast cancer surveillance consortium facility between the years of 2000 and 2018. At the individual level data, they use information regarding mammography screening results and breast cancer diagnosis. This data was then categorized in 3 groups, depending on whether the woman had negative screening results and remained cancer-free, was diagnosed with a screen-detected cancer, or was diagnosed with a clinical cancer that was not associated with a positive mammogram. Most previous models used to estimate breast cancer overdiagnosis only accounted for progressive cancers with a finite latency period before the onset or detection of symptomatic disease, which is an assumption that has been widely criticized because it does not allow for indolent tumors to remain in the preclinical state for an indefinite period of time. To address this concern, the researchers then introduced a mixture model that explicitly allows for a fraction of the cancers to be non-progressive. To estimate the tumor latency and the proportion of non-progressive cancers, they fit the model to the observed patterns of screen-detected and clinical cancers using Bayesian inference models. From a set of observed data points, they determined the maximum likelihood estimate of the mean. Bayesian inference is therefore just a process of deducing properties about the population of probability distribution using Bayes' theorem. A lot of the information about the underlying disease process is encoded in both the absolute number of cancers detected at each screening round and the relative frequency of screen detected versus clinical cancers within each screening round. Given the estimated fraction of non-progressive cancers and the tumor latency among progressive cancers, they predicted that overdiagnosis rate using different screening approaches. Following the breast cancer screening recommendations from the United States Preventative Services Task Force, for average risk, they focus on biennial screening between the ages of 50 and 74. Their final study cohort included almost 36,000 screening participants that underwent a total of 83,000 screening mammograms. The number of screening mammograms per participant ranged anywhere from 1 to 17. The majority of participants underwent a total of 5 screening mammograms or less. The median age at the time of the first screening mammogram was 56, and the majority of participants were white and of non-Hispanic ethnicity. They estimated the fraction of non-progressive cancers among all preclinical cancers to be 3.6%, with a 95% credible interval of 0.2 to 13.8%. Mean tumor latency among progressive cancers was 6.5 years, and the estimated screening sensitivity of mammography was 81.7%. Based on these estimates, they predicted that the rate of overdiagnosis in a cohort of women that started biennial screening at age 50. They assumed that women receiving a screening mammogram every 2 years until they either died from a competing risk or turned 74 years of age, whichever one occurred first. In such a cohort, they predicted that 15.3% of all screen-detected cancers will be the result of overdiagnosis. Accounting for the two sources of overdiagnosis, non-progressive cancers, 40% were attributable to overdiagnosis, and of the progressive cancers, 60% were attributable to overdiagnosis, whose tumor latency exceeded the time of death from other causes. They looked at the rate of overdiagnosis by screening round as well. In this graph, each bar represents the overdiagnosis rate for a single screening round of the considered biennial screening program. The blue portion of the graph represents the contribution of non-progressive cancers, where the yellow portion represents the contribution of progressive cancers. The screening round specific overdiagnosis rate doubled between the first and last screen, increasing from 11.5% at age 50 to 23.6% at age 74. This increase with age is due to the competition between tumor latency and competing mortality. Because older women are more likely to die from a competing risk during tumor latency, and then they're also more likely to be overdiagnosed. In summary, for biennial screening mammography between the ages 50 and 74, the researchers found that about 1 out of 7 women will be overdiagnosed, with very similar results for annual screening. Among those overdiagnosed cancers, about a third were attributable to the detection of non-progressive cancers. When putting the results in the context of comparable studies available in the literature, they found the overdiagnosis estimates to be higher than those reported in other modeling studies, yet smaller than those reported in prominent excess incidence studies. Of note, the 31% estimate of the influential study by Blatter and Welch was based on overdiagnosis among all breast cancers, which means that overdiagnosis among screening detected cancers would only be higher. They also explained that the fact that their estimate is larger than what's reported in other studies is likely due to a combination of factors related to the underlying study populations and the model specifications. Some of the limitations of this study include that their model groups both invasive and in situ cancers, which does not allow to make an estimation regarding whether or not all non-progressive cancers were due to in situ disease. And it does not distinguish between different molecular subtypes. And these are two important distinctions that have clinical relevance when having these discussions of perhaps the escalation of therapy. Their model assumes the same screening sensitivity for progressive and non-progressive cancers, and their model does not yet account for patient features such as race and breast density, which are very important factors that are being widely studied at the moment. Of note, the presenter reported that based on their data, their prediction is that there would be very little difference in the rate of overdiagnosis in annual versus biennial mammographic screening due to the sojourn period being approximately 6.5 years, which is significantly longer than both screening intervals. They also did not include in their study the impact of computer-aided detection or artificial intelligence. In summary, past modeling studies of breast cancer overdiagnosis have been criticized for lack of transparency and making simplifying assumptions, such as accommodating non-progressive cancers. In the presenter's work, they explicitly accounted for non-progressive disease, and they used what they refer to as an authoritative data source of contemporary mammography practice in the United States to conclude that overdiagnosis of breast cancer is likely higher than what has been reported by previously modeling studies and likely lower than what has been reported by prominent excess incidence studies. I would like to acknowledge the researchers, all the supporting entities, that allowed for this work to be presented at the San Antonio Breast Cancer Symposium. Again, I would like to thank you. Thanks the organizers for the invitation. Thank you for the opportunity to share this wonderful work with everybody in the audience. Hope you have a great rest of the day.
Good afternoon. Welcome to the fourth topics or the fourth abstract presented by Dr. Sherif Semani. He is the consultant and head of the medical oncology, King Abdullah Medical City, Makkah Al-Mukarramah. He will present the breast cancer atlas DCIS genomic signature, defined biology, and correlate with the clinical outcomes. It's an analysis of the Translational Breast Cancer Research Consortium and O38 and resource of archival breast cancer breast tissue cohorts. Please.
Thank you very much, Mr. Chairman. Of course, it's my honor to be part of this prestigious meeting, and I would like to thank Dr. Khair and all the organizing team for perfect selection of the topic and perfect organization. So it's my pleasure today to share with you this very interesting abstract related to a molecular classifier of DCIS patients. This is the title of the abstract. It's a breast pre-cancer atlas DCIS genomic signature that will define biology and correlate with clinical outcome. And this was assessed in 2 cohorts of patients. The first is TB-CRC O38, and the second cohort is RAHPT. For the simplicity, I will call rabbit cohort. Excuse me. Okay, just a brief background of the authors. As you know, in the last decades, we have a screening mammography, which is a routine in many countries overall the world. And the screening mammography definitely decreases the breast cancer mortality, but on the other hand, it leads to marked increase in the detection of DCIS. And many of DCIS detected by screening mammography may be not clinically relevant. They will not recur. They will not lead to invasive breast cancer. And the standard of care, as you know, for DCIS is to do lumpectomy plus or minus radiotherapy, and in some selected cases, mastectomy. Of course, hormonal therapy can be added in ER-positive patients. So having clinically irrelevant patients may subject to those patients to an treatment that may not be needed at all. And that's why we have ongoing clinical trial that address the concept of watch and wait policy for patients with low clinical or clinical pathological risk of DCIS. We have 2 ongoing trials in Europe and 1 ongoing trial in US. So it's increasingly important to classify patients with DCIS according to the risk of recurrence. We have different clinical risk factors, but as well we have in the last years genomic risk stratifying tools as well, and this will be part of them. And this is important to allocate patients to aggressive versus less aggressive treatment according to the risk of recurrence and the risk of developing invasive malignancy. So these are the 2 cohorts assessed in this study. They included 216 patients from TB-CRC O38 cohort, and 326 patients coming from the rabbit cohort. And they collected more than 700 samples, DCIS samples sampled from those patients with a median follow-up of 7.3 years. And we have data about the outcome versus recurrence or no recurrence in all patients coming from the TB-CRC cohort, but we have this outcome data from 97 patients only from the rabbit cohorts. And they will serve as a case control comparison to compare the genetic signature in patients having the recurrent versus a control patient with no recurrence. And the other issue, the next point, that they did different types of sequencing for the samples available. They did RNA sequencing, DNA sequencing for chromosomal number aberrations in addition to mutation. And they looked as well for protein expression using multiplex ion beam imaging. And all this work were done on archived sample from paraffin plots, not on fresh samples. So this is the genes identified to be correlated with recurrence after 5 years of follow-up. So 818 genes were correlated with recurrence. Mostly these genes are involved in cell cycle, cell metabolism, P53, MEK pathways, in addition to mTOR pathways. These are the genes identified. And the next step, we need to have a certain classifier, molecular classifier, to classify patient into low versus high risk. So when you have a complex data set like 800, more than 800 genes, we can use a predictive model called random forest predictive model. This model it creates a certain classification algorithms, and then you will be able to pick the best classifier to be correlated with outcome. Here, patients were classified into low genetic signature versus high risk genetic signature, and this will correlated with having any type of recurrence, either DCIS recurrence or invasive recurrence. And as you can see in the TBCRC cohort, the training cohort, it was strongly prognostic in terms of recurrence, as you can see, and this was replicated in the validation cohort coming from the rabbit patients. The other issue, they looked for the accuracy of this prognostic tool. And as you can see in the middle diagram here, the ROC curve, to predict the prognostic value or the accuracy of this prognostic tool. And the area under the curve was 0.72. Anything more than 5 and closer to 1 means that this tool is having good specificity and sensitivity for the prognosis and prediction of recurrence. And then they looked for the classifier low versus high risk genetic signature in terms of invasive breast cancer recurrence. And it maintains its very good prognostic value as well in the TBCRC cohort and the rabbit cohort, as you can see in this diagram. And even after adjustment for the type of local treatment given, either lumpectomy alone or lumpectomy plus radiotherapy or mastectomy, the prognostic bar was maintained after adjustment for the type of local regional therapy. And then they did multivariate analysis to assess the prognostic value of this molecular tool in comparison with or in the presence of other clinical pathological factors like the age, the ER status by immunohistochemistry, DCIS grade, and so. And as you can see in both the TBCRC cohort and the rabbit cohort, the prognostic value of the molecular classifier was maintained even after having this multivariate analysis with other clinical pathological prognostic factors. So after correlating this molecular classifier with the outcome in terms of all types of recurrence or invasive recurrence, they try to create something important. We know in invasive breast cancer, we have the band 50 to classify patients with invasive breast cancer into luminal A, luminal B, and basal-like, and so. Here they created something similar to that using RNA sequencing, and they could found 3 molecular clusters for DCIS. The first is ER high, the second is ER low, and the third they called it quiescent cluster. And the main drivers for this classification based on RNA sequencing was having expression of ESR1 and ERBB2, which you can encode for HER2 expression. And as you can see in this diagram, that in the ER high, there is high expression of ESR1, but low expression of ERBB2. And the reverse happened in the ER low category, while in the quiescent category in the middle, they have high ESR1 expression. However, they're very low expression of Ki67 and very low proliferation. So we have 3 clusters found in the TBCRC cohort, and the same clusters were replicated as well in the rabbit cohort, as you can see on the right side of this diagram. This classifier was based on RNA sequencing. The next step, they make another classification based on DNA sequencing. But before going to that, just a brief background about what's called integrated clusters of invasive breast cancer. This work was presented about 8 or 9 years ago, and it was based on classification or based on joint analysis of RNA and DNA assessment of invasive breast cancer patients. And they classified breast cancer patients into 10 subtypes. And each of these subtypes had a certain characteristic amplification, as you can see. For example, subtype 1 have amplification of 17q23 and so. And some subtypes have no amplification or very rare to have amplification. And this classification was found to have certain prognostic value, certain clinical, distinct clinical features as well. And if you look to this diagram, these integrated clusters have prognostic value in terms of disease-free and overall survival, with the best survival outcome in cluster 3 and the worst in cluster 5. So here in our work, in our abstract, they tried to make something similar, looking for DNA clustering for patients in the TBCRC and rabbit cohort. And they could found 6 clusters, not 10. There are 6 here in DCIS. For example, for cluster 2, there is this is characteristic by amplification of 8 B1123 molecular aberration, and this is a characteristic aberration of invasive cluster number 6. So here you can find 6 clusters. Some of these clusters have amplification that have been found in the invasive breast cancer clusters. But if you look to the right side of the diagram, cluster number 6, DCIS cluster number 6, this is a cluster having no amplification at all. And this represents the majority of patients of DCIS. And this indicates that DCIS for the majority of cases have no genomic instability. And this is, of course, something that we can expect from DCIS, that the proliferation and genomic instability is lower than invasive breast cancer. So the bottom line from these RNA and DNA clusters is we have different classes of DCIS. DCIS is not one disease. Biologically, they are different in terms of RNA and DNA sequencing. And the third important issue that they did as well, they classified or clustered the patient with DCIS according to stromal status as well. They used a technique called laser capture microdissection to pick the cells within the stroma, and they classified the patient into 4 stromal clusters. The first is normal-like, the second is desmoplastic, which is enriched with myofibroblast. The third is collagen-rich, which is rich in collagen metabolism and transforming growth factor beta, and the fourth is immune-dense cluster. So again, even in terms of stroma, we have different biology in DCIS patients. So this is the conclusion of the authors, that they could identify 1,812 genes that can classify TBCRC cohort into low versus high risk of recurrence. And this was validated in the rabbit cohort. And this was valid for any type of recurrence, either DCIS or invasive recurrence. And when they restricted the analysis for invasive recurrence, the prognostic power of this classified was maintained as well. And they found, similar to the invasive breast cancer, different clusters or different classes of DCIS when classified based on RNA sequencing, and they were 6 when classified according to DNA sequencing, and they could found 4 stroma-specific signature as well in DCIS patients. The other part of the conclusion of the authors is that they elected to go for assessment based on paraffin blocks, archived paraffin blocks, and this allows them to collect hundreds of samples and correlate the genetic signature with clinical data and the outcome of the patient in terms of recurrence. And this can be validated in further trials as they reported. And this is the acknowledgement of the authors. Just one slide about certain thoughts that we may discuss in the discussion part of this section. So what is the next step after having this molecular classified? Is it ready for clinical use? My impression is they missed in the analysis some important factors in the multivariate analysis, like the DCIS margin. It was not assessed in the multivariate analysis. The tumor size, the comedonecrosis, all these factors were not assessed in the multivariate analysis, and I think they need to do some effort about that. So, and the next step, this data were coming from retrospective cohort. So this needs to be validated in prospective cohorts, and it may provide the basis for stratification for future clinical trials for DCIS patients. And especially this molecular classifiers can help as well in watch and wait trial for DCRS. It will add to selecting of low clinical risk patient by adding as well low genomic risk patient to be justified for watch and wait without any kind of local regional therapy. Thank you very much.
Thank you very much, Dr. Sharif, for a very informative talk in a very controversial subject. We come to the discussion part of this session. If any one of the audience, whether in person or the audience online, have questions to the previous 5 talks. Any inline questions?
Just my question to Dr. Stacy Carter. The senior doctor study from Italy, they included only 2 macrometastasis sentinel lymph node biopsy. I mean, if they retrieve 3 and they excluded this from their study, or they just depend on only retrieve only 2 sentinel lymph node biopsy?
I think your question was, I just want to make sure that I understand, regarding the number of sentinel lymph nodes that were positive. In the Synodar
Just retrieve 2 or retrieve maximum 3 and based on the histopathology finding?
They said that it was 2 sentinel lymph nodes was sort of the threshold for the study. They were all, keep in mind, they were all clinically node negative at diagnosis, and at surgery, they randomized patients that either had 1 or 2 positive sentinel lymph nodes in the Synodar 1 trial. And keep in mind that essentially all of the patients that were really randomized in their study were patients with macrometastatic disease. Hopefully that answers your question.
Thank you.
Again, my question for Dr. Stacy Carter. Hello, you hear me? Okay. Like with the new study, would you recommend omission of axillary lymph node, completion axillary lymph node dissection in patient with mastectomy? We already, I know that Z11 trial prematurely, the practice was changed. However, in most mastectomy patient, do you still, do you think you have enough evidence to omit axillary lymph node dissection in case of limited metastasis?
That's a great question, and I will say I think this varies a lot by the practices in each different country and region. I will say that I think our practice here at Baylor is a very case-by-case basis. I think if we have a woman who fits sort of the Synodar trial enrollment, which was, again, remember that when I showed that sort of the inclusion criteria or the enrollment across the arms, that they were really patients with, kind of early stage breast cancers, very, under 2 centimeters in size, clinically node negative, primarily hormone receptor positive. So I think if I was doing a mastectomy in a patient like that who fit the Synodar 1 trial, and they had 1 or 2 sentinel lymph nodes that were positive, I certainly would probably bring that discussion to the multidisciplinary tumor board. And based on what other adjuvant therapies the patient was going to get, I would decide at that point whether or not a completion axillary lymph node dissection would truly benefit the patient. I think we're still a little ways away from the results of the B51 trial, which is looking at axillary radiation versus or axillary dissection versus the axillary radiation. And I think I think there is good evidence that you can probably avoid axillary lymph node dissection in patients based on the SYNODAR-1 trial. I mean, this is a very large trial. I think in many ways it tackled a lot of the faults that people have of the Z11 trial. I also believe that there's another trial underway that's looking at the same question that will POSNOC, which will report out later. So yeah, I think it's completely reasonable in that population to consider omitting axillary lymph node dissection.
Thank you. Dr. Stacy, this is Dr. Jamil Al-Azhari. I'm a breast surgeon from Dammam. Just a continuation of the same question. We already have data from the AMAROS trial that was presented in San Antonio Breast Cancer Symposium in 2018, along with the long-term follow-up of the Z11. So both trials had a 10-year long-term follow-up results presented, and they held the results consistent of the early follow-up results, that there was no difference in disease-free survival and overall survival between the two groups. So I think now with the, and of course the AMAROS, they included also mastectomy patients with the same criteria of early breast cancer, no negative disease. So I think now with the SYNODAR trial that is complementary to the Z11 and the AMAROS, covering the deficiencies in the trials, we have a strong evidence to be able to apply these two trials and omit axillary dissection in breast cancer with early disease and 1 or 2 positive node. My question is that how do you extend this to patients presenting with node positive disease? According to the recent 2021 and NCCN guidelines, now they allow you, if you have a patient who presented with early breast cancer, T1, T2, and going for upfront surgery, however, they have clinically positive nodes, low burden disease defined as 1 or 2 nodes only, you take them for sentinel lymph node biopsy, provided they did not receive neoadjuvant chemotherapy, even though we know in advance that they are clinically node positive. And you're allowed to apply Z11 and AMAROS. So are you adapting this in your practice?
Yeah, that's a great question. And yes, I think the practice here at Baylor is that we do consider these things looking on a patient by patient basis. I think you're right. I think that there's a, I think that we all probably feel as surgeons that we're over treating patients, especially these patients that sort of come in with a low burden of disease in their axilla, but we know that it's clinically positive. We are trying to, in some of those patients, we very strongly consider sort of a targeted axillary dissection in some of those patients. If we know that there is a node that's positive, we clip that node. If they're undergoing neoadjuvant therapy, after neoadjuvant therapy, during the sentinel lymph node biopsy, we will ensure that the clipped node is removed. And so when we do that, we think that we have a very, very low rate of a very low rate of false negative or false positive results. So I think it's something to consider. And yes, I think the way that we're treating patients that present with node positive disease with limited disease in the axilla, I think we should be careful about how much surgery we do in their axilla, knowing that those patients are going to go on to get other adjuvant therapies that are probably going to be much more useful in terms of controlling their disease burden than what we can do surgically.
Hello again. So what's your preferred method of localizing the clipped lymph node?
We at Baylor, we have 2 technologies that we tend to use. We use the Savvy Scout. It's a radar reflector. And then we have some colleagues that prefer mag seed, which is a magnetic seed. We also did it with a wire for probably the last 3 to 4 years. I would also do these with a wire. Just recently, we've lost the capabilities to do that. So now it's just one of these implantable sort of localization devices that we use. And I will tell you, I have, thankfully, knock on wood, I have found it in all cases where we've sort of localized the node. So I think they're very good at finding it and helping you localize the node, because it can shrink considerably after neoadjuvant therapy. And we try to put them in as soon as we know that they have, that we're going to do a targeted axillary dissection. We try to put these little localization devices in as soon as we can. So they undergo neoadjuvant therapy sometimes with the localization device in the node.
And you insert the refractor for the SAVI system, like just before surgery, or from the start you use it as a tissue marker?
That's a great question. For the breast, we don't tend to do it sort of in a pre-neoadjuvant or before neoadjuvant therapy. We tend to do it after neoadjuvant therapy, and that's a great question. I'm not really sure why we don't just go ahead and place it at the time of. The only reason I can think of is that when we use the mag seed, if we were going to get a follow-up MRI, and maybe Dr. Ortiz she jumped on, so maybe she's going to speak about this, but you can get sort of a bloom around the mag seed, and that's probably why we would hold off on doing it in the breast, but we will do it in the axilla from time to time. Dr. Ortiz, did you have anything you wanted to add to that?
Yeah, no, I want to say I agree with Dr. Carter. I think that it can produce significant artifact that will limit your ability to evaluate the extent of disease at the time of MRI. That is a very important consideration. But your question is a very good one. It's like if there is a very high chance that this is going to be cancer, why not go ahead and place it from the get-go? There is obviously, there is a small percentage of cases that we are pretty sure that are going to come back as cancer and end up not being cancer. Some of those, a lot of those end up getting surgical resections anyway, and may or may not be cancer. But the primary motivator is the limitations that it will impose on evaluation of extent of disease at the time of MRI.
Yeah, and specifically, what we're discussing is that oftentimes we will get a post neoadjuvant therapy MRI to evaluate sort of the response, and we wouldn't want the mag seed or one of the devices to sort of create artifact in the exact area that we're most concerned about.
Okay, thank you.
Thank you very much. That brings us to the last talk on this session. Dr. Jamila will present.
It's my honor to welcome Dr. Bano Aran. Actually, physically, she is present with us. Welcome to our country. Welcome to Riyadh. It's not very different from Texas. They're both cold deserts. So I hope you're adjusting very well. Dr. Aran is an associate professor, Department of Medical Oncology at the University of Texas, MD Anderson Cancer Center. And she's going to be presenting fine-tuning risk assessment and risk reduction.
Thank you very much for the introduction, dear chairpersons. I also would like to take the opportunity to thank the organizers and especially Dr. Omar Khair for tirelessly doing this meeting every year with increasing success. So what I will do within the next 30 minutes is summarize a session that I actually had chaired. It's an educational session, so not study presentations, that was called Fine-Tuning Risk Assessment and Screening. We've had 3 speakers. They talked about lifestyle, diet, and exercise, emergent pharmacologic non-endocrine breast cancer prevention, and imaging with artificial intelligence. Drs. Neil Iyengar, Drs. Brandy Heckman, and Drs. Constance Lehman were the speakers. This whole session was close to 2 hours. My talk will be 30 minutes, so I will be trying to highlight the messages of these educational talks. So with this, I will start with Dr. Iyengar's talk about risk assessment and exercise and diet. So needless to say, obesity-related cancers, multiple cancers are now officially defined as obesity-related cancers. Obviously, breast cancer, colon cancer, uterus cancer, gallbladder and GI cancers, kidney, even myeloma, ovarian, pancreas, and thyroid are all now related can be related to obesity. The other important information is body fat and risk of postmenopausal breast cancer has been also looked at. And when we look at the whole body percentage fat as well as the trunk fat mass, the higher the fat percentages, the higher the subsequent development risk of postmenopausal breast cancer. So now what I want to say is that obesity and weight is maybe not the same as having high fat tissue. And the next few slides will introduce that very interesting concept, actually, that the researchers have been working on recently. So a little bit about hyperadiposity and inflammatory microenvironment in the breast. When we talk about hyperadiposity and inflammatory microenvironment, studies have shown that in some breast cancers, there are increased crown-like structures in the breast. Crown-like structures in the breast is a dying adipocyte surrounded and circled by macrophages. It looks like a crown. And this is the immunohistochemical representation of this. But what we know from studies right now is that if you have this crown-like structure, that increases a stromal effect where increased production of cytokines or other growth factors such as interleukins, TNF, alpha, even cyclooxygenase 2 are produced. And also in the tissue, androgens are converted to estrogens. So all of these markers relate to proliferation, immunomodulation, and increased risk of breast cancer. And I have another slide showing that. But one study actually looked at women who've had these crown-like structures in their breast with breast cancer, and that women who've had more of these CLSs, the crown-like structures, their breast cancer recurrence risk was higher. So one study showed that having these structures was associated with increased risk of breast cancer recurrence. Then some other studies have shown that if women have these crown-like structures in their breast tissue, not only their breast cancer recurrence, but breast cancer risk, if they did not have any breast cancer, is increased. And here you can see the p-values with increasing numbers and percentages of these crown-like structures. So it appears that having these crown-like structures, which is a sign of hyperadiposity and inflammation, is associated with increased breast cancer risk. Now, I thought this slide was very, very important to see where we are with obesity and having fat tissue. So this is a picture of a woman with a BMI of 24. In a way, you think their breast cancer risk should be the same because they both have a BMI of 24, but one has a lower total fat and truncal fat, and the other one has a higher total and truncal fat. And this woman is postmenopausal. This woman has higher fat in the premenopausal setting. So if so what is the risk of breast cancer in these patients? So in women with normal weight, but more hyperadiposity, like this woman on the right side compared to the left side, has a higher risk of breast cancer. Again, their weight is the same, but the adipose tissue is more and inflamed in the premenopausal woman. And as you can see here by the quartiles, depending on the whole body percent fat or trunk fat mass, breast cancer risk is increased. These are the proposed mechanisms. This is a very exciting area of research that is up and coming, and there are a lot of studies now going on looking at. So these are the adipose tissues. With obesity, we see hyperplasia and hypertrophy of these lesions. And as I had mentioned, when there is increased adipose tissue, some of the dying adipocytes are surrounded by macrophages. These are the crown-like structures, and I've just shown this mechanism here where this can lead to stromal increase of several cytokines that are associated with increased breast cancer risk, increased levels of interleukin-6, as I mentioned, TNF-alpha, prostaglandins, and C-reactive protein. And then, of course, that's not the only thing. Most probably individuals with this situation have also hypermetabolic syndrome, where we see increased gluconeogenesis, increased lipolysis, and increased leptin levels and decreased adiponectin levels. All of these, together with the events happening on the right side, contributing to the risk of breast cancer. And furthermore, when you have more estrogen production, as in the previous slide, I have shown you conversions from androgens. When you put all of these pathways together, you have a metabolic syndrome, hypermetabolic state, inflammatory fat tissue state that can all increase cancer cell promotion, proliferation, and increase risk of breast cancer. Now, again, kind of what we so far, based on all of these mechanisms I mentioned. So, you see these 4 individuals, so normal weight to women and then obese to women, but their metabolic syndrome or lipid-related adiposity might not be the same. And indeed, you might have a normal weight woman who's metabolically healthy, does not have this fat tissue inflammation and all of the other events that I showed in the previous slide, but you might have another woman, BMI is not high, thin, but has all of these higher body fat percentages, and all of these things are ongoing in her body, and she's at increased risk for hypertension, diabetes, cardiovascular disease, as we see in the hypermetabolic syndrome, but also breast cancer and the other cancers I mentioned. On the other side, you might have a woman who's obese, but is metabolically healthy. Maybe the fat tissue distribution or percentage is not high compared to a woman who has all of these. Like in this, young woman whose BMI is actually less than 25, again, increased risk for cancer. And, studies, of course, these are mechanisms, but it's important to see how it relates to breast cancer incidence. What we have so far is not the whole picture, but we know, for example, that women or individuals with activity have a reduced risk of cancer. And I'm not going through all of these numbers. This is a publication in JAMA in 2016. You can see it, but as you can see in multiple cancers, exercise can reduce the risk of breast cancer based on BMI. Now, but again, as I've shown you, I think it's important to see, is it just you lose weight that reduces breast cancer risk? Because I showed in the previous slide, not all of the patients had a reduction in incidence, or is it with exercise, you can actually reduce the fat inflammation. And these slides just show that even with a normal BMI, you can reduce adipose inflammation with exercise that can reduce risk of breast cancer. Now, I'm saying this very carefully because there are really no prospective trials in this area. But what it tells us is that now trying to do weight reduction, lifestyle intervention to reduce cancer and other diseases is just not one continuous linear thing. We can now call this precision oncology or precision lifestyle interventions and reduction of cancer by attacking it in multiple ways, understanding all of the pathways. So obviously it's genetics, and we know it's weight, but it's not only the weight, as I've shown you. You can have normal weight, but inflammation of your fat tissue and still develop breast cancer. And I'm not going to go into this detail. We talked about the little proposed mechanisms, but I think what this slide is showing is that you have to put all of the information together, you know, what you inherited, your environment, your weight, as well as the status of your tissue or your fat tissue in the body, and come up with interventions targeting multiple precision oncology for a given person. So doing 5 times exercise, 1 hour aerobic might not work for everyone, because the reasons for the inflammation and weight and cancer risk is different. And we have, for example, as an example for the environmental and genetic factors, I think it's a little bit easier to identify those, right? I mean, you can look at your genes, you can look at single nucleotide polymorphisms, or you can look at some markers that you know that are associated with breast cancer, such as estrogen levels. We already know that those are associated with increased risk of breast cancer. Given all of this, the speaker, Dr. Iyengar, talked about the program that they are doing at their institution, Healthy Living Program at Memorial Sloan Kettering. So they are trying to target all of the factors I tried to show you. So they have a personalized risk assessment intervention with the idea to reduce risk of cancer, where they early engaged patients. They deliver risk stratified care. They assess the risk based on all of these risk factors, their BMI. They measure their lipid profile. They look at some hereditary factors. They measure their estrogen or any other risk factors that are related to breast cancer, put it all together, and then plan a personalized intervention. And they have several, I mean, this is just one simple slide, but they have implementation plans, diet and exercise and coaching and all of the modern things they do. And at the end, they monitor, follow up these patients and evaluate. This is an ongoing study, and some very preliminary design related studies were actually presented in the poster session at the San Antonio meeting. But most probably within a few years, we'll hear some of the results. So that was the part about diet and exercise. I mentioned that I have to cover everything in 20 minutes. So I want to talk, get into the second educational talk that was related to emergent pharmacologic interventions for prevention, mostly talking about non-endocrine, so not ER positive, but more ER negative or HER2 positive breast cancer. The speaker was Brandy Heckman. She is an epidemiologist and PhD in the breast and gynecology cancer research group in the Division of Cancer Prevention and the NCI. So the whole concept about prevention, and I had given previous talks, even at this meeting about prevention, is really to identify a risk. And again, based on the previous talk, we are talking about personalized risk, and the risk or the side effects or the benefits of a given intervention. So for a prevention intervention, and in this talk, it's mostly prevention drugs, of course, we need to balance the benefits to the risk of the patient has. So the risk of the patient has to be high enough so that an intervention is beneficial, and the intervention should not have too many side effects. And this balance, whenever a new drug comes out, even with the oldest drug, tamoxifen, we are always struggling. Now, the NCI has a potential prevention agent developmental programs. I think I did not cut out this slide because I think it's important. Prevention research is expensive. Prevention research takes a long time, and prevention research requires a large number of patients. When you remember the NSABP P1 trial, the P2 trial, the IBIS trials, it's thousands of women. The P2 trial was 20,000 women prospectively randomized to raloxifene and tamoxifen for 5 years and another 5 years or so. It's 10 years. So, and many drug companies do not cover or help with these studies. Some do, but not all of them. So there's definitely some governmental support needed for these type of studies. So that's why the NCI developed these three programs that kind of feed into each other. So the agent drug development, they call it the PREVENT, preclinical drug development program, because you need to find some agents. And in a minute, I will tell you how they, come up with some of the agents, and they have funding mechanisms to support that. Once a drug is identified in this program, then they move into another program that is called Cancer Prevention Trials Network. They have a funding mechanism for that too. So let's say there's a drug A that looks very promising. Then they start phase 1, phase 0, first in human, or phase 1 and phase 2 prevention trials with this funding mechanism. And if that agent is successful at this level, then through the NCI Community Oncology Research Programs, NCORPS, which is an R01 funding mechanism, phase 3 trials, these large prevention prospective trials are done. So first of all, it takes a number of years to get from here, from an idea, all the way to a cancer incident endpoint phase 3 trials. But it also takes a lot of patient numbers and a lot of money. And that's why there is an infrastructure to support research in that area. I'm not going to go through all of these programs in detail, but I will give you examples. The PREVENT projects, for example, the very first one, identified some agents that are now being tested in phase 2 studies. For example, the endoxifen gel clinical development or the 4-hydroxyfen tamoxifen gel study that we are doing at MD Anderson in high-risk women. Another one is targeting the mTOR pathway. Another one is a RANK ligand inhibition for potential chemoprevention in women with BRCA mutations, such as denosumab. And then also development of a multi-antigen, multi-peptide vaccine-based triple negative breast cancer prevention agent and some other vaccines. So these all come from the identification initial phase. I mentioned then the larger trials. A large phase 2 trial has been done with metformin, for example, in women with cytologic atypia. Another prevention ancillary study is looking at mammographic breast density changes in patients who receive an AI versus AI plus aspirin. I will show that. And then a prevention study in BRCA germline positive patients trying to prevent breast and or ovarian cancers with denosumab, which is a RANK ligand inhibitor. So these are all examples of how agents can come up to phase 3 studies when you start with that program. Now going through the agents a little bit, I want to start with the nutraceuticals. So these are natural agents or remedies that are out there, such as curcumin and others, or broccoli, for example. And the way you come up with the idea to study an agent is usually based on epidemiologic association. So you see, like, if a study is done with broccoli extract and let's say to decrease liver enzymes, and all of a sudden that cohort has less breast cancer incidence, you think, well, maybe this broccoli extract might be helpful for breast cancer risk reduction also. I'm just making this up as an example, but that's how it started. There is, though, we need, because these are natural compounds, a lot of preclinical work to look at drug levels, increase the drug levels that you otherwise cannot achieve by just eating the broccoli. So they need to be concentrated and produce it a tablet form. The drug product is not standardized. So you have some supplements out there, but they're all not very standardized. So you need to do that also. And also, we need to think not all natural products are non-toxic, right? You know, a lot of patients who come to our clinic say, I take this herbal, I take these vitamins, these supplements, because they're all natural, but they are not natural. And in order to take a natural product into a clinical trial, you need to not only develop the new formulation, as I mentioned, but also maybe do toxicology studies before you even start assessing that drug. So one natural product that made it all up is a green tea extract, looking at mammographic density changes in postmenopausal women at increased risk for breast cancer. I want to give just a 1 minute background here. So you can do studies, breast cancer prevention studies, give an agent for 5 years and then follow them for 10 years and then see whether cancer happens. Or you can identify a surrogate endpoint for breast cancer development. In this case, it's mammographic density. Mammographic breast density is associated with risk of breast cancer. And recently, several studies are using this as an intermediate endpoint in studies. These are called phase 2A, phase 2B studies, where you do placebo or the agent of interest and look at before and after breast density changes. And usually it's 1 year or 2 years. It's cheaper, it's shorter, and you get a signal. And in this study, they looked at green tea. And I'm not going to go through all of the side effects, but it was a large study, really, where they screened and at the end, came down to 1,000 patients. But they did not, unfortunately, see, you can see the p-values. There was maybe a trend, but it was not significant in reducing breast mammographic density in women with dense breast tissue, very high risk for breast cancer. So based on this, green tea, based on the study, is, for example, not being developed for a major phase 3 study. But if this study would have been positive, I think investigators would have continued a prospective phase 3 study. Now, there are other agents also. And again, this is an educational session, so it's going through some examples. Non-steroidal anti-inflammatory agents. This area in itself is a 1 hour, very exciting lecture, not only for breast, but also colon cancer. Inflammation and cyclooxygenase pathway is very much looked at in cancer development and potential cancer prevention. And as you know, celecoxib, the cyclooxygenase 2 COX-2 inhibitor, is actually approved for polyp formation for patients to prevent colon cancer with polyps. So it may clinically its way up already a little bit. But celecoxib, aspirin, sulindac are agents that are being studied for breast cancer prevention. With celecoxib, there are obviously multiple preclinical models. There are so many preclinical studies, and this is just one that everybody likes to show. In a MMTV, new mice were treated with celecoxib or different concentrations or placebo or sulindac. And as you can see, the celecoxib really reduced the risk of breast cancer development. But in the clinical setting, so the lower part, there were 4 prospective clinical trials. One of we did, actually, our group did, and we published it, I think in 2019 or 18, where in high-risk women, we gave celecoxib for 6 months and did periareolar fine needle aspirations of the breast to look at the tissue changes. Does it decrease cytology? Does it decrease Ki-67? And we could not see a reduction. Other investigators, such as Fabian and Brown, also looked at celecoxib with the endpoint being Ki-67 or mammographic density in either surgical, pre-surgical model or high risk of ER-negative breast cancer, high risk premenopausal breast cancer. And again, they did not see any major changes. That was a huge disappointment because celecoxib is approved for colon cancer prevention in patients with polyps, but for several reasons, it did not really give us a signal for breast cancer. But a lot of money and time has gone into celecoxib. Aspirin is another cyclooxygenase inhibitor. We didn't give up on aspirin yet because there are 2 trials. These are prevention ancillary studies. So in the Alliance study, they use a very practical model. So in this study, patients with breast cancer, HER2 negative breast cancer, are randomized to an AI, of course, which is their treatment, or AI plus aspirin. And they want to look at the contralateral breast cancer incidence rate in the AI plus aspirin group to see whether aspirin can reduce the risk of new cancers in the opposite breast. And the UK aspirin study has a similar study. We are awaiting the results of these studies. And finally, the third agent, Sulindac, is another non-steroidal inhibitor. Again, it inhibits the COX pathway. It reduces, and this study was positive, so it reduced breast cancer density in postmenopausal women with breast cancer who were treated with aromatase inhibitors. You can see a significant p-value when patients received Sulindac plus an AI versus to the AI only group. So there is a signal with Sulindac that if you add it to the treatment, your breast density reduces, and breast density reduction has been associated with breast cancer reduction based on several trials, including the prospective tamoxifen prevention trial. And now switching a little bit to HER2 targeted prevention and immunoprevention, there are different agents that are being studied right now: lapatinib, trastuzumab, and HER2 targeted vaccines. Lapatinib is a premalignant lesion study in HER2 positive breast cancer, placebo controlled. It's a very small study, and it did show that Ki-67 was decreased. This is a very indirect small study showing that yes, you can reduce Ki-67, but whether that will translate into breast cancer prevention of HER2 positive breast cancer, we don't know. Another study was looking at trastuzumab in HER2 positive DCIS. And here again, there was a reduction in the, this was a pre-surgical study, reduction in the findings of DCIS, and that was published in JCO. Again, it's not a prospective study. And finally, a lot of excitement is out there related to vaccines. The HER2 pulse dendritic cell vaccine, a very small study that was done pre-surgically, did weekly injections. They prepared the cells to increase antigen specificity, and that then led to interferon gamma secretion of CD4 and CD8 positive cells. Again, this was more a understanding study where patients were injected, and then the microenvironment was looked at under pathology. And another ongoing study, we don't have the results, the final results of these, is a phase 2 trial of a S-peptide vaccine in women with DCIS. It's called Nuvax. Again, the slide shows the preparation of these vaccines, and the idea is to induce positive changes in the breast tissue. These are all very early studies, by the way, not prospective clinical phase 3 trials. So for non-endocrine breast cancer prevention, I can say that there are many agents under study, and I didn't even go into ER positive. So, tamoxifen, aromatase inhibitors, and others, of course, are out there, but we are trying to target ER negative and triple negative and HER2 positive breast cancer. I think what is needed is best risk models, and that ties into really the first talk, where we can do individualized risk assessment with genetics, environment, polymorphisms, obesity, as well as the body, fat tissue, and inflammatory state. And also to remind you that there are certain regulatory pathways, at least in the US, from time zero until you have approval of a drug takes 10 to 20 years. And finally, within the last, I think, 1.5 minutes, I'm going to talk about artificial intelligence and imaging. It was a very great lecture, but it is very technical. So I'm just going to show you the highlights, the thoughts, because I think you need to be a radiologist to really talk about the details, and I'm not a radiologist. But the main message here is that whether we want it or not, artificial intelligence is in our lives right now. It's in medicine, whether we use it a little bit or a little bit more or completely, depends on the scenarios, whether you are in cancer or cardiovascular disease or metabolic or diabetes, but it made its way up there. There were some studies looking at use of artificial intelligence for image analysis in breast cancer. They looked at 130,000 patients between 2010 and 2021. And they actually showed that 34 out of 36 artificial intelligence systems were less accurate than a single radiologist, and all were less accurate than the consensus of two or more radiologists. So again, artificial intelligence is there. We started using it right away, but when we did retrospective studies, did it help or not? It didn't really help a lot right now. And this is publication from 2021. Of course, you can criticize this study that looked at 130,000 patients. It's retrospective, obviously, and high risk. There's a bias on whether cancer samples were enriched, because these were all-comer screening patients. There were differential variations in outcome, biopsy, no biopsy, recall, when did the patient come back, and insufficient follow-up. Now, the computer-aided detection application to evaluate mammographic density was actually, believe it or not, approved by the FDA in 1998. So we have been actually using some type of AI, computer-aided detection of density for our breast cancer patients. And multiple studies looked at this, but most of the studies are retrospective reader studies, and the prospective studies are only single institution small studies. What does computer-assisted detection does? It identifies areas of density, and then the radiologist looks at it a little more carefully. So it's not completely AI, driven, but it helps the radiologist to guide it. But when they did this, with the computer assisted or without, the sensitivity, specificity, and recall rate was actually the same. So the radiologists were pretty good by themselves, here on the left side, identifying these dense areas with the sensitivity, specificity, and the recall date. One problem started when the FDA said that a woman with breast density need to be informed. It needs to be put in the letter, because breast density increases breast cancer risk. So then identifying qualitatively or quantitatively breast density became very important, because now it's in the reports, and the woman, if she has extreme dense breast tissue, she has to discuss breast cancer risk and risk reduction with the provider. So again, it would be great if you could apply AI technology to this. These are just some examples the speaker showed with, rather non-dense, a little bit more dense, and then extremely heterogeneously dense breast tissue. This all needs to be reported now in the report, so that the patient can discuss with her physician risk and risk reduction. But it's very complicated. I'm not a radiologist, but even I can say that there's a problem. So they did a study amongst 83 radiologists, and one radiologist only called 6% of his mammograms dense. Another radiologist called almost everything dense, all of his patients. So, and I do not absolutely want to offend any great radiologists we have here, but it tells you that it's like the KI67, right? The pathologists, like they call grade 1, grade 2, even intra-observer difference. This is important because we clinicians will be basing our recommendations based on what the radiologists put down there. So quantification with AI would be very helpful. And indeed, when they did deep learning model to enhance the screening test performance for density, now this time there was a 97% agreement with the expert readers in the test setting. So when you kind of, do the deep learning for density assessment, I think this works in radiology. This all leads to, of course, risk assessment, right? Breast density, whether the physician identifies it or with the help of deep learning AI technology. What it means to us is that breast cancer risk is high, but we still have to individualize risk. And also race is very important, because all of these risk models were based on Caucasian patients mostly. Therefore, it's recommended, and this was published last year at the New England Journal of Medicine. That's why I wanted to show this slide is, we have all of these risk assessment tools, we have breast density, but all of them were done on Caucasian women. So here in this paper, a adjustment by modeling for race is included. And I think this is a very, very important and helpful paper that you can read. So basically where we are right now is that I just want to go back here. Here is the radiologist only. This is radiology with some computer assisted. And here is AI. There's no radiologist. The AI does everything. And, we are going somewhere in between. I want to now go to my two conclusions. So I talked about lifestyle. I talked about chemo prevention and imaging. So lifestyle, we know that obesity increases cancer risk. We know that adiposity and inflammation also increases cancer risk. But we just learned that obesity does not equal to adiposity and inflammation. You can have a non-obese woman with all of this inflammation going on in her body. And it's important that we understand the mechanisms, but also come up with interventions to reduce inflammation, metabolic syndrome, and ultimately reduce breast cancer risk. For the chemo prevention part, what I want to highlight is that there are multiple new agents being studied. It takes a very long time for a drug to start from phase 0 to all the way to phase 3. And it's very expensive. I want to mention that. That's why progress in prevention really takes time, and we are behind compared to the clinical oncology trials. And in the imaging, I just showed that artificial intelligence is being integrated in screening, diagnosis, and breast cancer risk assessment. But technology is moving faster than knowledge of clinical implications. We have seen that in the review where 130,000 women, AI was used, but it was really not that much helpful. So we need to understand how we can implement these technologies, new technologies in our clinical practice and standardize so that we can give the patient the best answer. I'm so sorry I went over. Thank you very much.
Thank you very much indeed for such an informative talk. And soon, I'm sure these things will be true in a due course of time, especially the IA. Okay, that brings us to the conclusion of this section. And may I call the chairperson of the next section, which is triple negative breast cancer update. And I would like to thank the organizers, the audience, and the chairperson. Thank you very much.
So welcome again to the 16 Middle East Best of San Antonio 2022 hybrid event. This is the day 2, and the session will be started titled Triple Negative Breast Cancer Update. We have 3 chairmen and 4 speakers. The chairmen are myself, Nasser Lahloubi, Professor of Medical Oncology, NCI University, and Dr. Talib Bouhadika, Consultant Medical Oncology, Prince Sultan Military Medical City, Riyadh. And we have Dr. Basselman, is a Consultant Medical Oncology at King Fahd City, Riyadh, Saudi Arabia. I think we are going to make an announcement for the first speaker, Dr. Kausar Suleiman. She is an oncology consultant at King Faisal Specialist Hospital Research Center in Riyadh. She will present the GS4-09 abstract, which is the quality of life results from the Olympia, a phase 3 multi-center randomized placebo-controlled trial of adjuvant oliparib after neoadjuvant chemotherapy in patients with germline BRCA1 or 2 mutations and the high-risk HER2-negative early breast cancer. Dr. Kausar, the floor is yours.
Thank you very much for organizing committee to invite me for participation. And I would like to congratulate Dr. Khair for arranging for this excellent meeting for last 16 years continuously. And I'm attending since last 10 years along with this. So I would like to discuss today the quality of life result from Olympia trial, which was presented by Dr. Patricia Gens in San Antonio Breast Cancer Conference. This Olympia is a randomized double-blind placebo-controlled trial of adjuvant therapy with olaparib in high-risk breast cancer patients with germline mutation in BRCA1 and BRCA2 patients. This international trial Olaparib or placebo were given for 1 year after eligible patients has completed adjuvant chemotherapy or neoadjuvant systemic therapy. An interim analysis earlier this year, the boundary for reporting invasive disease-free survival was reached, favoring olaparib. However, the overall survival was not reached and study was still continued. Researchers have demonstrated the patients who are getting the early stage breast cancer systemic chemotherapy, they take 1 to 2 years to recover from pre-treatment, treatment on pre-treatment level because of the toxicities what they face with the chemotherapy. In Olympia patients, reported outcome were collected to inform discussion between the physician and the patients regarding risk and benefit of this additional adjuvant systemic therapy. The central question for the Olympia Pro study is to understand whether or not olaparib might increase end of treatment symptoms such as fatigue and possibly delay improvement in quality of life after chemotherapy. This slide shows the overall trial design, which was more focused on the pro assessment. For the pro study analysis, outcome from the 2 separate chemotherapy groups, as you can see, the neoadjuvant group as well as adjuvant group was given, and the potential for having baseline pro scores that might differ. As you see that before randomization, all of these patients has to go through the baseline pro assessment. Pro assessment were planned in an all-enrolled Olympia trial patients prior to randomization, as I mentioned earlier. This is schedule captured pro assessment at the time of randomization, then during the therapy every 6 months, for 6 months and 12 months, and post-therapy 18 months and 24 months. Until the treatment was ended, and then the follow-up after 1 year to make sure that their symptoms are improved. Primary hypothesis of this pro study focused on whether or not the patients treated with olaparib might experience greater fatigue severity during the treatment compared to those receiving placebo. This was based on a preliminary evidence from phase 2 studies of olaparib that reported a higher frequency of fatigue as an AE during the treatment of olaparib. A secondary hypothesis evaluated whether the fatigue experience on treatment of olaparib would resolve after the end of treatment on 18 and 24 months. And there was also a hypothesis, greater severity of gastrointestinal symptoms during the treatment with olaparib because of the phase 2 data have shown the patients face significant diarrhea during the olaparib therapy. And additional secondary hypothesis focus on improvement in quality of life over the 24 months of observation. And we expected no difference between olaparib and placebo. So primary objective of the study focused on the effectiveness of olaparib on treatment reported fatigue compared to placebo at 6 and 12 months after randomization using the FACIT fatigue questionnaire, which is a standard questionnaire. Secondary objective, examine whether the fatigue persisted during the 12 and 24 months time after the treatment and also assess severe gastrointestinal symptoms and various dimensions of quality of life across the entire 24-month data collection. These pros assessed using the URTC quality of life questionnaire. These 2 questionnaires were selected because they are reliable and they have been validated in multiple trials and they are available in multiple languages, and it was excellent to use. In this statistical analysis, the early reporting of the PRO study outcome was not planned for the many patients enrolled in Olympia trial. It provided sufficient statistical power for analysis of primary endpoint, which was comparison of fatigue scale score between the olaparib and placebo at 6 and 12 months. There was a greater than 90% power to detect a 3-point difference on the facet fatigue scale between olaparib and placebo patients, which can be a clinically meaningful. You can see this concert diagram of Olympia Pro, and here they show the flow of patients, included the current Pro analysis, although 85 patients were excluded from this. Here you can see initially 1,836 patients were enrolled, then 85 patients were excluded because there was no baseline quality of life or Pro assessment was done. Then after this 1,750 patients, there was a no quality of life follow-up data was available. So 216 patients were further excluded. And after that, about 1,500 patients were left and who had at least one evaluation before as a baseline. And then they all had initiated therapy and they consented for the Pro sub-study group. And you can see the neoadjuvant and adjuvant group both have a equally balanced divisions. You can see the demographic baseline characteristic include everyone enrolled in the Pro sub-study group demonstrate good balance between the two treatment assignments, including distribution by the race and geographical status. Clinical characteristics are based on everyone enrolled in the Pro sub-study and show a similar distribution of clinical characteristics by treatment assignments. This is an interesting thing, summary of the baseline Pro score means. You can see the facet fatigue score has been mentioned as a primary endpoint, which was a primary objective was. This slide, you can see that the division in the neoadjuvant chemotherapy group as well as neoadjuvant chemotherapy group. They have mentioned EORTC quality of life 30, C30 symptoms and their functioning scale, as well as the facet fatigue score. Within each chemotherapy group, there is no difference in the scores by the treatment assignments. However, the neoadjuvant chemotherapy group has a slightly worse score on the facet fatigue score. You can see the 39 and 39, and here on adjuvant chemotherapy score is the 40s. EORTC functioning skill compared to the adjuvant therapy group as well, there was a little bit higher side effects in the functioning scales also. You can see in the neoadjuvant compared to the adjuvant data. Facet fatigue score at this baseline assessment highlighted in blue is 3 points lower, lower or worse than the healthy woman. Healthy woman, facet fatigue score is 0 to 50, and if you have a higher the score is the less fatigue. So if you see that the normal healthy woman usually have a 43 is a fatigue score, and in this patient, you can see the baseline fatigue score, even starting of systemic therapy as a baseline, they have a lower fatigue score, which means they have a baseline toxicity secondary to their systemic chemotherapy for early stage breast cancer as a neoadjuvant and adjuvant. And especially in neoadjuvant setting, you see worse than adjuvant setting. Similarly, here is the EORTC scores are here, and they also describe the 0 to 100, and higher the score shows the worse the symptoms. If you see in the primary objective of the Pro analysis focus on comparison of facet fatigue score as 6 months and 12 months, and they are divided in neoadjuvant and adjuvant setting, you can see the difference is in minus 1.3 and 1.5 in 6 and 12 months in neoadjuvant, as well as in adjuvant is minus 1.3. This is statistically significant, but they are not clinically meaningful. In this study, the objective was it should be -3, which will be clinically significant, and it did not meet the criteria. If you go on the secondary endpoints now, on FACIT-Fatigue score at 24 months, you can see baseline is -3, is in the neoadjuvant setting, olaparib, and then at 6 months and 12 months is -1.3, 1.5, and 18 months and 24 months, it became normal as a baseline. So it means that the FACIT-Fatigue score did have a worsening of that score, but it did not reach the clinical significance, which was objective was supposed to be -3. But on 18 and 24 months, it became back to the baseline setting. In adjuvant setting, also you see the same finding, though they have a lower than neoadjuvant setting, and they all were again back to the 18 and 24 months baseline level they reached. In EORTC scores, nausea and vomiting, if you look at this graph, in EORTC, there is in neoadjuvant setting 6 months and 12 months, you can see higher nausea, vomiting, and they were statistically significant. In the adjuvant setting, especially at the 6 months of olaparib therapy, you see a higher nausea, vomiting. But they were on 24 months, all of these things reached to the baseline level. Similarly, diarrhea, if you look at this, which were expected that the patients will face much more diarrhea during the EORTC scales, but there was no difference during the treatment timing as well as after recovery time, 18 to 24 months. So which was pre-specified during this study that it might show a higher nausea, vomiting. If you look at the functional, there was no clinically meaningful difference between the olaparib and placebo in physical functioning over time for either chemotherapy group, neither on emotional functional status was not different for the overtime for chemotherapy group and olaparib group. There was no clinically meaningful difference between the olaparib and placebo on global health status in either chemotherapy group. So in conclusion, the primary quality of life outcome measured by the FACIT-Fatigue and difference between the olaparib and placebo at 6 and 12 months did not meet the protocol specified clinically meaningful difference. And secondary output, patients that received olaparib had greater severity of nausea and vomiting than the placebo treated patients, which was consistent with the clinically reported AEs in the phase 2 data in the olaparib. However, these symptoms were completely resolved on 18 and 24 months, and they reached to the pre-treatment level in the patients. The limitations of this analysis, which has happened because of the all quality of life data was not available and the trial is still continued. And once the trial is completed, we will have a full analysis of quality of life data. In summary, olaparib was well tolerated as adjuvant therapy and no clinically meaningful increase in the fatigue during the treatment and no significantly impact on the quality of life. While olaparib treatment lead to the slight increase in severity of nausea, vomiting during the treatment timing, and it did resolve completely at 18 and 24 months of follow-up. As we know, that's a normal patients who are getting the systemic therapy, they do take 1 to 2 years to recover from their acute toxicities. So in conclusion, that 1 year of olaparib did not meaningfully affect the recovery and the patient can tolerate this therapy. This is my end. And this is the acknowledgement by the group who presented this study.
السلام عليكم ورحمة الله وبركاته والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. I would like first to thank Dr. Al Khair and her organizing committee for inviting me, and also Dr. Nasser for introducing me. I would actually to apologize, I could not attend physically because I got COVID. Without further delay, I will introduce Dr. Adhar Sayed. He's a head section of medical oncology in King Faisal, the Oncology Center, King Faisal Hospital and Research Center. He will give us an update about the Keynote 522, which is about the event-free survival, sensitivity, and subgroup analysis about the new adjuvant pembrolizumab plus chemotherapy versus chemotherapy alone, followed by adjuvant pembrolizumab and also placebo for early stage triple-negative breast cancer. Dr. Adhar?
Yeah. Sorry, Dr. Talib. Dr. Adhar Sayed is apologized today. He cannot attend. So we would like to skip this session and we will present Dr. Ala Qandil. So I'm honored today to be with you in the moderating of this session for the update of triple-negative breast cancer. And we'll skip the second session and we'll start the third abstract, which will be presented by Prof. Ala Qandil. Prof. Ala Qandil, he is professor of clinical, so he's professor of clinical oncology. And he will present today an abstract about the final result of Keynote 355, which will be randomized double-blind phase 3 study of pembrolizumab with chemotherapy versus placebo chemotherapy for previously untreated, locally recurrent, inoperable, or metastatic triple-negative breast cancer. So welcome, Dr. Ala.
Bismillah ar-Rahman ar-Rahim. Thank you so much, actually. Before I start, I can ask the chairpersons, actually, because I see an email or a note from Dr. Hoprogo, and she's mentioned something about going to present the 522. I'm willing to wait for her, or I start by the metastatic. It's up to you, up to the chairpersons. Actually, I don't mind. What do you think?
Go ahead, Dr. Ala.
Okay.
I think the Prof. Ala, you can start, and then one session, Prof. Hober will present both.
Yeah, she's around. Okay. Thank you so much. So I'll share the screen first. Can you see my slides now?
Not yet.
Not yet.
Can you? I already shared the screen.
Yes. Yes, doctor. Yes.
Yeah.
You can see the slides now. Okay. First of all, I'd like to thank Dr. Al Khair and the rest of the organizing committee for giving me the opportunity. It's my pleasure and honor to be around with you. دكتورة أم الخير ربنا يوفقك. الميتنج ال 16 ده شيء أكتر من رائع. Okay, the title is already being presented. This is a Pembro versus chemotherapy in patients with metastatic triple-negative breast cancer, going by the score of the PD-L1, the Keynote 355. These are the disclosures of Dr. Cortez, who presented that at the San Antonio meeting. And this is an introductory slide mentioning that we have data that we have improved clinical activity in patients with higher PD-L1 expression, and responses to Pembro are more durable than those with chemotherapy. And we also know that Pembro plus chemotherapy showed anti-tumor activity and manageable safety in early triple-negative breast cancer. with a statistically significant and clinically meaningful improvement in event-free survival with neoadjuvant pembro plus chemo, followed by adjuvant pembro versus chemo, as will be presented shortly by Professor Rogo, the keynote 522. Now in the keynote 355, addition of pembro to chemo resulted in statistically significant and clinically meaningful improvements in both progression-free survival and overall survival versus chemotherapy alone for patients with PD-L1 combined positive score 10 or more, metastatic disease.
We cannot see your slides, please. For those
you cannot
who
see
are
my
following
slides
online, we cannot see it online. No.
So I mean, what
No,
should I do? I mean, I already shared my screen.
We can see online.
No, we can. Your slide is already online. So
okay, you can see my slide.
Yeah, you can
Okay.
continue.
Okay. So, and there was no statistically significant benefit, neither in progression-free survival or overall survival with patients with low combined positive score. And this is the design of the trial. And you can see on the left-hand side, the key eligibility criteria for patients' age and with a central determination of triple-negative breast cancer PD-L1 expression, previously untreated, locally recurrent, inoperable, or metastatic, de novo metastasis or completion of treatment with curative intent for a period at least of 6 months or more, good performance status, and the rest. And you can see that the investigational arm included the pembro and plus chemotherapy versus placebo chemotherapy with more than one stratification factor, chemotherapy on study, taxane or gemcarbo, PD-L1 tumor expression, and prior treatment with the same class of chemotherapy in the neoadjuvant or adjuvant setting, yes or no. And treatment was given to progression of progressive disease or cessation of study therapy. These are the primary endpoints, progression-free survival and overall survival with different levels of combined positive score, in addition to more than one secondary endpoint of objective response rate, duration of response, disease control rate, and safety in all treated patients. These are the treatment disposition. This is a 2-to-1 randomization with 566 patients in the pembro chemo arm, and these are the disposition of the patients with the different combined positive score level. And you can see this is 1 to 9, more than 10, and the intent to treat population, whether the patient completed or discontinued. And these are the patients with placebo, 281 in total, with a median follow-up in both groups of 44.4 months. A very good, very balanced PD-L1. And you can see between the two groups in the yellow, the pembro, the investigational arm, and then in the red or violet placebo arm, you can see that on the right-hand side, almost 40% of the patients had high combined positive score, 10 to 19, and more than 20 in 14, and almost 25% of the patients. And about 60% of the patients had below the cutoff point, or what showed the cutoff point to be the cutoff point, 10, less than 1, or 1 to 9. And that was very well balanced between both groups. These are the baseline characteristics of the study groups. And you can see that this is a relatively young age patient profile, as the median age was almost 53, good performance status, and 75% of the patients had low combined positive score, 10 or more was there in about 38.5%. Taxane was given in about 45% of the patients, and gemcarbo in about 55%. And the prior same class chemotherapy was given in almost 20% versus change of the chemotherapy schedule in about 80% of the patients. Going to the results, overall survival, as you can see on the left-hand side, you can see a very convincing effect, positive effect of adding pembro to chemotherapy with the hazard ratio of 0.73, meaning 27% improvement and a statistically significant p-value. However, that was not observed in patients with a low combined positive score, 1 to 9, with a hazard ratio of 0.86 and no significant p-value. And on the left-hand side, you can see the intent to treat population data. Looking into the subgroup analysis, you can see very clearly that the benefit was there for patients with 10 to 19 and more than 20, more or less the same actually and a very convincing effect in favor of adding pembro to chemotherapy as opposed to chemotherapy alone. Further cutoff points, you can see again on the lower part, a significant improvement with 0.71 of 10 to 19 and more than 20 in 0.72 hazard ratio, very convincing. However, with no in low combined positive score levels less than 1 or 1 to 9, where the hazard ratio was almost 1.09 here and 0.97. So actually the benefit was in the lower cohorence, high combined positive score of the patients. In terms of progression-free survival, again and again, in patients with 10 or more combined positive score, you can see a very convincing hazard ratio, 0.66, and a significant p-value. And I'm sorry, I don't see the significance of p-value was not there. And for patients with lower combined positive score, you can see a hazard ratio of 0.75, but with no significance. And on the right-hand side, the intent to treat population. Again, 10 to 19 and more than 20 combined positive score, you can see the difference, a very little difference between 1 to 9 combined positive score, but this is progression-free survival and not overall survival. And further cutoff points showed more or less the same data as being seen in overall response, overall survival actually, 10 to 19, 0.7 and even 0.62 for 20 or more or higher combined positive score. PD-L1 showed even better, but not in patients with low combined positive score as per the upper part of the slide. In terms of toxicity profile, you can see that in terms of any grade was very comparable, 96 versus 95, grade 3 to 5, 68 to 66 or 67, a little bit more serious event, 17.8 versus 12. 2 patients, 0.4% died due to the treatment or during the course of treatment led to death, and the discontinuation was 18.3 in the investigational arm and 11% in the control arm. But most importantly is the immune-related toxicity. You can see definitely a high level in the pembro arm, 26 versus 6.4. Grade 3 to 5 was there in 5.3% with 0%. And most importantly, as mentioned by Dr. Cortez, that the majority of the immune-related toxicity was hyper or hypothyroidism. And these are the summary and conclusions where it was concluded that pembro plus chemotherapy resulted in statistically significant and clinically meaningful improvements in progression-free survival and overall survival versus chemo alone for first-line treatment of PD-L1 combined positive score 10 or more metastatic triple-negative breast cancer that is meeting the dual primary study endpoints. Combined positive score equals or more than 10 is a reasonable cutoff to define the population of patients with metastatic triple-negative breast cancer expected to derive treatment benefit from pembro plus chemotherapy. Safety was consistent with the known profiles of each regimen with no new safety concerns, and these results provide further support for pembro in combination with chemotherapy as a new standard of care treatment regimen for patients with locally recurrent, unresectable, or metastatic triple-negative breast cancer whose tumors express PD-L1 with a combined positive score of 10 or more. Last but not least, these are the acknowledgements shown by Dr. Cortez. And at the end, I'd like to thank you so much.
Yeah, thank you, Prof. Ala, for this interesting data and abstract. Now, I would like to introduce our last speaker, and he is Prof. Hobrogo. She...
Okay. Do you want me to introduce? Because I got messed up. Yeah. Thank you.
Dr. You can introduce Prof. Hobrogo for presenting the keynote 522.
Yeah. Actually, it's my honor to introduce Dr. Hobrogo. She's a professor of medicine and director of breast oncology and clinical trial education at University of California and San Francisco. Dr. Rogo, mic is yours now. You will give us a talk about update about keynote 522. Already I mentioned it in the previous talking. So Dr. Rogo.
Hi, Good evening and good morning for me to everyone. I understand that what you want me to do is to do the keynote 522 presentation and then do my discussion, correct?
Yes.
Okay.
If you don't mind.
No, not at all. Let's see. But I only got that email. I think it came in at 1 a.m, so I only just saw it.
And even for me, it was confusing. I don't know that Dr. Adhar Sayed is apologizing. Sorry for that.
Yes. All right. And I have to get, okay. So it's certainly a pleasure to talk about Keynote 522 first, and then to discuss these 3 different abstracts that were presented. So this was presented by Peter Schmidt, and it was first, the main data was presented at an ESMO freestanding plenary session, and then was discussed at the ESMO formal meeting. So this was really an event-free survival sensitivity and subgroup analysis. And actually, there was supposed to be more data presented here, an RCB analysis, et cetera, but they couldn't get all the data together. So instead, they presented this particular analysis. So I expect that we're going to see more data at ASCO. So these are Peter's disclosures. I think everybody here knows about pembrolizumab and TNBC, and I'll show you a little bit more of that when we go to the discussion. But there was the first data was actually our trial, I-SPY2, where we showed that just 4 doses of pembrolizumab with neoadjuvant chemotherapy was only given during the taxane portion, improved PCR rates. And then Keynote 173 was a phase 1b trial looking at different combinations and extending through AC or EC, which also, although they wasn't randomized, showed that it was tolerable. So then Keynote 522 was developed from that as a prospective randomized placebo-controlled phase 3 trial. And the Keynote 522 decided to use a carboplatin paclitaxel induction, although in I-SPY we used just a paclitaxel induction. And the reason for that was because many of the investigators felt that based on data showing improved PCR, that platinum was a required component in order to really adequately analyze the added benefit of pembrolizumab. And then, of course, the data shown in the summer showed an improvement in event-free survival, which was one of the co-primary endpoints. And based on that data in August of 2021, the US FDA approved pembrolizumab in combination with chemotherapy as neoadjuvant and then adjuvant treatment for early stage high-risk triple-negative breast cancer. And this is a study design. Patients had to have, if they had T1C disease, they had to have a positive node. Otherwise, you could be node negative if you had a tumor greater than 2 centimeters and up to N2 disease. You had to have a tissue sample provided before you started treatment for PD-L1 assessment because stratification wasn't done by PD-L1, but it needed to be obtained. Patients were randomized 2-to-1 to receive a backbone of carboplatin paclitaxel, followed by AC or EC with either pembrolizumab or placebo. Almost 1,200 patients were randomized, so it's so far still the largest neoadjuvant trial, and that's because, again, it was powered at looking at both EFS as well as PCR. PCR was designed to be looked at in the first 602 patients randomized, and then event-free survival in the entire population at various interim analyses. After surgery, patients continued on their randomized arm with either pembrolizumab or placebo to complete 3 weeks. Just to mention that the AC or EC was given every 3 weeks as opposed to every 2 weeks in order to match up with the pembrolizumab. And then also the physicians had a choice about the way carboplatin was given. It could be given as an AUC of 1.5 continuously weekly or an AUC of 5 every 3 weeks for the 4 doses. So the study endpoints, as I mentioned, were PCR and event-free survival. PCR was no invasive disease in breast and node, and it was done in by the local pathologist in the entire ITT population. Same with EFS. And then secondary endpoints are the standard classic secondary endpoints for these studies, and as well as looking at the same endpoints in the PD-L1 positive population and safety. And then the sensitivity analyses were exploratory analysis. as well as subgroups. And I think because they didn't have the more meaty data for San Antonio, they presented this, which was reasonably lightweight data. So they did these pre-specified sensitivity and subgroup analyses. So here's the flow of the patients randomized in the trial, 1,174 patients enrolled. As you can see, the enrollment took just a year and a half. There's a lot of interest in this. And then you have the safety evaluable and analysis populations here. I think it's quite encouraging that most of the patients actually who started finished and went to surgery. So 390 allocated, 381 had documented surgery, 784, 768. So the numbers are quite high. So even if you look at patients who didn't have great surgery or didn't have surgery, it's just a tiny number, so it didn't affect anything. Interestingly, less patients started adjuvant treatment. So the reason for that, there was a big fall off here in the number of patients who started adjuvant treatment that affected this arm more than this arm. So more the Pembro versus placebo, and they still saw a positive outcome. So the patients who were enrolled in this trial, I think they looked at HER2 IHC because of the interest in HER2 low, but I don't think it really plays any role in this particular disease study. But if you look at node positive or negative, about 50% node positive and negative, stage 2 and 3. So 75% of patients had stage 2 disease and 25% stage 3. As you know, the primary event-free survival showed a significant improvement in event-free survival. Here's the 36-month landmark analysis showing this difference, 76.8 versus 84.5%. The p-value boundary for this was 0.005, and the p-value here was 0.00031. So it's a big, highly statistically significant value. And the hazard ratio is 0.63, which is a 27% relative improvement, really very exciting to see. So this funny analysis that they did for San Antonio is the primary and sensitivity analysis definitions of event-free survival. So people may be aware of the STEEP analyses initially published by Cliff Hudis and then updated by Sarah Tallaney from the National Cancer Institute in the US, where it just defines what you mean by the different terms we have in the early stage setting. And so this is kind of a similar thing. It's where they say that the way they decided event-free survival had local progression of disease that preclude definitive surgery. So people didn't have surgery, and that included all the sensitivity analyses: local recurrence, distant progression, distant recurrence, death from any cause, positive margin at last surgery, and second primary breast cancer. So what they did was they looked at all the different analyses. So this is the sensitivity number 1, which is primary, right? So then for number 2, it included anybody who got a new anti-cancer therapy. They didn't allow capecitabine. So number 2 included anybody who took capecitabine. Number 3, if a patient did not have a positive margin, so if it didn't matter what the positive margin was. So at the surgery, you could have had a positive margin, but it wouldn't be an EFS event. Whereas for the primary analysis, if you had a positive margin at the last surgery, that counted as an EFS event. So sensitivity number 3, people said, well, maybe that just skewed your results. So what happened in number 3? In number 4 and 5, which turned out to be a little bit less important, this is somebody who gets a second primary breast cancer. It doesn't count as an EFS event. And then here we're having a second primary breast cancer, a second primary breast cancer counts as an EFS event. And here having a second primary any cancer doesn't count as an event. So there are just different definitions that you can have as you go along. And so what they were doing was just looking at all the different definitions of how you could assess event-free survival. So it turned out it didn't really matter, and I'll show you why in just a moment. But here are all the different analyses. This is the analysis 1, is similar to the primary analysis, but you decrease a few numbers of patients. And so if you look at the number of patients just in the Pembro arm, you can see that the lowest you get to out of 123 is 112. So the number of patients that you're dropping is just a little over 10. And understandably, this didn't affect the hazard ratio or the confidence intervals. And then they showed the specific sensitivity analyses. So this is the one with capecitabine, and I'll show this more in my discussion. So I won't talk about it a lot here. So you can see here sensitivity analysis number 1. patients who received adjuvant capecitabine. And if you see, these are, the number of patients here is 31 and 13. So in a trial of almost 1,200 patients, it didn't make any difference. And then sensitivity analysis number 3 that they focused on, which was positive margin at last surgery, again, because people were worried that if you said somebody had an EFS event by positive margin at last surgery, those patients have a greater chance of being cured of their disease. So you're really skewing the results. But if you can see that here, the number of patients who had a positive margin at the last surgery was 6 and 10. So it was skewed more towards the placebo. There were more patients with a positive margin in the placebo arm. Remember, this was a 2-to-1. So it's like 20 versus 6. But that goes along with the fact that they had a lower PCR rate. And then you can see that the distant recurrence, there's absolutely no difference. So this didn't impact the results at all. And then if you looked at the subgroup analysis, the second part of their presentation was looking to see whether it made a difference with node status, disease stage, menopausal status. This is kind of a silly analysis in my mind. The number of patients very small, so you can't really tell the 2+ patients who are so-called HER2 low. And then LDH, which had been a prognostic marker for other cancers and advanced disease, didn't make a difference. And then they looked at node status specifically, which I already showed you. And you can see that although patients who have positive nodes have a relatively worse event-free survival, everybody did better with the addition of Pembro. It didn't matter whether or not you had a positive node or not. And then again, by disease stage, I actually don't think that we had this information quite as well looked at by node status and stage, regardless of the study before this trial, because there are so many patients. So almost 1,200 patients, you can see the patients with stage 3 disease had a worse outcome overall than patients with stage 2 disease. And then it wasn't shown by PCR, but if you get a PCR, you do very well. But if you have higher stage disease, you have a worse outcome. And this is in the overall population. But everybody benefited from pembrolizumab, so that was very encouraging. In terms of treatment-related adverse events, again, as shown in the previous presentation, actually the standard adverse events were no different whether you got Pembro or not. And you can see that by just looking at the green versus brown. And they always use green versus brown. Some of the toxicities, if you look at the lighter colors, were higher grade. You can see were low neutrophils and neutropenia and anemia were a little bit greater, but there was no difference with the addition of Pembro. And then treatment-related adverse events, as you would expect in the adjuvant phase that are not immune-related, were very, very low. And no different, between whether you got Pembro or placebo. If you look at the immune-related adverse events, which are our interest, and infusion reactions, you can see there are, of course, more adverse events with Pembro than with placebo. Again, these are listed essentially by percent, so it takes care of the 2-to-1 randomization. There were more infusion-related reactions, and the most common immune-related toxicity was thyroid. And you can see there was hypothyroidism, hyperthyroidism, and thyroiditis. And then adrenal insufficiency and hypophysitis, which are both low cortisol, also were increased, but the numbers are less than 5%. Skin reactions is the most common second toxicity. Severe skin reactions were seen in almost 6% versus 1%. And if you looked at grade 3 to 5, most of the skin toxicities were grade 3 to 5. That's because if you have a rash that it covers more than just a tiny bit of your body, it's already grade 3. So that has to do with the grading for skin toxicity. And this was all incidents of 10 or more patients. So then the question is, did any lead to death? And there was a small number of events that did lead to death. And we'll talk about that again more in the discussion. There was one patient from pneumonitis and one patient from autoimmune encephalitis. And the FDA thought these were all related, but the investigators waffled a little bit, as did Merck. And then if you look at the adjuvant phase, you can see, first of all, there's a lot less events, which is great. And the number of events with use of Pembro or not, in terms of thyroid, are no different. And why would that be? I mean, look at this is hypothyroidism and hyperthyroidism. And basically it's because there's so much of a carryover effect from prior, from any treatment that you get. And also that thyroid disorders are so common. So overall thyroid disorders are increased with immune therapy, but when you get single agent Pembro, you don't really add much onto that toxicity outside from what people get from just having Hashimoto's thyroiditis. And then you can see that the main differential here is skin reactions. There was a little bit of pneumonitis, and there is ongoing adrenal insufficiency that you can see, as well as colitis and myocarditis, but the numbers are extremely low, which is encouraging. And then leading to death, 0.2%, it's always worth looking at again. There was one patient who died from autoimmune encephalitis. There was also one patient who died on day two out. The surgery was day one, the patient died the second day. And the FDA assessed this to be due to acute adrenal insufficiency because the patient had a cortisol of 0. But Merck did, and the investigators thought that it was unclear exactly what that death was because the patient had sepsis and multi-organ system failure. So that's sort of the fourth event that the FDA considered in mortality. So Keynote 522 showed neoadjuvant Pembro and chemo showed a significant and clinically meaningful improvement in EFS. Regardless of the sensitivity analyses or subgroup analysis, everybody seemed to benefit. Safety was similar and there were no new safety concerns. And this supports pembrolizumab plus a platinum taxane followed by ACEC as a new standard of care for patients who have at least node positive or T2 early stage triple negative breast cancer. And of course, the acknowledgements of the patients and their families, without whom this study would not have been possible, as well as multiple investigators worldwide. Okay. So that is Keynote 522. So now I'm going to share with you my discussion. If that's okay, I'll go right into the discussion. If I can figure out which one this is.
May I start the discussion, please? Right now we have already the 522, and we have in the neoadjuvant adjuvant, and we have the Olympia as an adjuvant, and we have previously the Create X as using the capecitabine in the adjuvant setting. How would you go or find your way between these three different studies in triple negative breast cancer?
Well, it's a pleasure to talk about that now. As you know, I was the discussant for the 2 keynote studies at San Antonio.
I think hope you start discussing the 3 abstracts, then you can respond to the master question.
Right, that's what I'm doing. So as you know, I was the discussant for the 2 keynote abstracts at San Antonio, which is on the first morning. And then, of course, we're all very interested in the Olympia trial. So what I'm going to do is talk about the neoadjuvant trial, Keynote 522, and the Olympia quality of life, just to discuss them, and then finish with Keynote 355 in the metastatic setting. So the 2 abstracts about checkpoint inhibitors included Keynote 522. And the question that this abstract asked was, did censoring by sensitivity analyses impact event-free survival for Keynote 522? And the second question was whether subset analyses defined who benefits from pembrolizumab. The second abstract was Keynote 355. This data with the looking at overall survival, I had the honor of presenting at ESMO this last year. And so this was an updated analysis to try and understand whether subset analyses or the specific value for PD-L1 expression defined who benefited from pembrolizumab. The overarching questions was the association of PCR with event-free survival and why PD-L1 was only important for metastatic disease. As we had seen in previous presentations, PD-L1 did not impact the efficacy of, and in this not shown so much in this subset analysis, that PD-L1 status did not at all impact the efficacy of pembrolizumab in the neoadjuvant setting, but PD-L1 positivity is absolutely required for any benefit of pembrolizumab in the metastatic setting. So that's a big question. So Keynote 522, I just showed you the study design and the patient population, just to remind you, 51% node positive, 3/4 had stage 2 disease, and 56% were premenopausal. The primary event-free survival at the fourth interim analysis showed a 7.7% improvement in event-free survival and a 6.3% improvement in distant recurrence-free survival, both of which I think are clinically very important, with a highly significant p-value and a hazard ratio of 0.63. So the event-free survival sensitivity analysis showed that regardless of censoring, with the standard censoring of a variety of different endpoints, that adding pembrolizumab to neoadjuvant chemotherapy and continuing after surgery improved event-free survival. And the hazard ratios are shown here. And if you just take a look at these hazard ratios, you can see that they're all identical. So somewhere between 0.63 and 0.65. So very encouraging that all the censoring did not impact outcome. So let's look at this in a little bit more detail. So analysis number one were patients who received adjuvant capecitabine. As I mentioned earlier, the number of patients was very small. So people were really following the study design. 31 patients received capecitabine in the pembro arm and 13 in the placebo arm. So actually somewhat unintentionally, because this couldn't, of course, be a stratification factor, with a 2-to-1 randomization, there was a relatively similar number of patients in each arm who received capecitabine. This did not have any impact on event-free survival, as you would expect. And actually, capecitabine on its own hasn't had a huge impact in many populations, although we saw a survival benefit in CREATE-X in the Japanese and Korean population, and in the Chinese population treated with metronomic capecitabine after adjuvant therapy for triple-negative breast cancer, we saw an improvement in disease-free survival. And one of the hypotheses about why we're not seeing such a great benefit in the ECOG trial that Ingrid Mayer published early this year before leaving academics for AstraZeneca is that the subtypes or intrinsic subtyping of triple-negative breast cancer may vary geographically and racially, so that we see relatively less basal and more non-basal like triple-negative breast cancer in the Asian population, and that therefore capecitabine has a bigger impact than in the largely Caucasian population enrolled in this study and in the Ingrid Mayer study, which was US-based, where they looked at capecitabine versus carboplatin. In terms of the last positive margin, thankfully, most of these patients did have a clear margin. So there were only 6 patients with a positive margin in the pembro arm and 10 in the placebo arm. And as you can see, there was no difference in outcome, and it did not impact the hazard ratio. So for me, the more clinically interesting area is the subgroup analyses. And I think this is really fascinating and is teaching us something that we need to understand better looking at some of the biomarkers that we'll see over time. But if you look at the node positive and the state by node status and by stage, what you can see is that although if you're looking at the hazard ratios here, they're both clinically relevant. So there are some differences. So in node negative disease, the hazard ratio is 0.58, in node positive 0.65, in stage 2 disease 0.60, and stage 3 0.68. And if you look at the deltas here, you can see that all of these, I think, are clinically important to us in terms of the absolute benefit. But you see a greater benefit relatively in node positive disease, where the PCR rates were relatively lower and the outcome is worse, but the delta is greater. So it seems as though patients who have more disease, node positive or stage 3 versus node negative or stage 2, have higher PCR rates in the control arm. So although you're improving outcome, you have the opportunity to improve outcome more in the patient population who have more burden of disease. And maybe that's because the higher burden of disease actually suppresses the host immune response. And so by giving pembrolizumab, you can overcome that impact of disease burden. And then if you look at the PCR status as a way to better understand that, you can see here at the first interim analysis and the second interim analysis, this included more patients, about 1,000, and this was the first 602 patients. What you can see if you just take a step back is that relatively the PCR rates were lower in patients. The PCR rates were lower in patients who had node positive disease in the control arm versus node negative disease, and worse here, so in both. If we focus just on IA2, what you can see is the differential benefit is greater in patients with node positive disease. And actually in IA3, which is the entire population that was presented to the FDA ODAC, they only presented the entire population, where the difference in PCR was about 7%. But when you break it down by node status, which wasn't presented there and hasn't been published, in the positive node patients and in the entire patient population, the difference in node positive disease is about 12%, but the difference in node negative disease is less than 5%. So it's really fascinating. It teaches us something about the biology of the disease. And we see the same impact by stage. So here you can see stage 3A and 3B disease. Overall, if you just look at the green and the brown, you can see that the PCR rates are lower in higher stage disease. But the benefit is greater in higher stage disease versus lower stage disease. So it does appear that there's something to do with the higher burden of disease that impacts the host response with the same treatment. So what about event-free survival? So what we saw in Keynote 522 was a curious finding, really important. So patients who had a PCR did pretty well. Not perfect. I mean, 92.5, 94.4%. There's no difference here. These are the same numbers. And we'll see what happens longer out, but this curve definitely seems to be flattening out over time. So there's still people who develop new events, even who have a PCR. So that brings up the question about continuing what you do after surgery in these patients, which we'll talk more about in a minute. But these patients did well regardless of whether they got PCR. So you have more patients with a PCR and a very good outcome with PCR. But no PCR is really interesting here. You can see that there's a big difference here, more than 10%, that favors patients receiving pembrolizumab. We don't know whether this is the impact of the preoperative or postoperative pembrolizumab, since of course they received it in both settings. But the question is, why would this be the case? Is it a change in the immune environment, or does it actually change in the PCR rates? And it's actually a change, I think, in the response, and we're going to see this at ASCO. But what we've seen is, and this is IA1, so remember this is only the first 600 patients. What you see here is that you see a relative shift in residual cancer disease burden. So although you see this improvement in RCB 0 and 1, the improvement, I mean, the differential here, what you see actually is a shift. So there are less patients who have RCB 2 and 3. And with that frame shift, if you would look at prognosis in the next slide, in I-SPY 2, what you can see is that patients who have, of course, a PCR did very well in I-SPY 2, but patients who had an RCB 1 did almost as well, and patients with RCB 2 do a whole lot better than RCB 3 in terms of event-free survival. So what I think we're seeing here is a shift in RCB. So here's the RCB when you have paclitaxel followed by AC. Mean RCB is 1.68 when you think about 0, 1, 2, and 3. But if you add pembrolizumab, just 4 doses, you shift the mean RCB to 0.46. And what you can see is this big increase, shifting away from RCB 3 to RCB 2, and then 1 and 0. So that will improve the event-free survival significantly. And we'll see whether or not that actually was the difference, that you just are getting rid of a lot of disease by adding pembrolizumab to standard neoadjuvant chemotherapy, causing an RCB shift. So we always want to talk about toxicity. So what's the patient cost of toxicity? Here's in the neoadjuvant setting, and I've highlighted the ones that should really be categorized together and not separately, because they all involve the same thing. So patients who develop hyperthyroidism and thyroiditis almost universally go on to become hypothyroid. And it's thought by our endocrinology colleagues that this is due to underlying Hashimoto's thyroiditis that's subclinical, and that the patients who don't develop hypothyroidism are those who just don't have an inflamed thyroid. Severe skin reactions, of course, we talked about earlier, and then adrenal insufficiency and hypophysitis are essentially the same disease in terms of the patient, but all of those patients present with a low cortisol. And the only difference is that with hypophysitis, you have low ACTH. Almost all of the patients I've diagnosed with adrenal insufficiency have had secondary adrenal insufficiency or hypophysitis, where they have 0 ACTH. So I think that that's probably more common than is represented here in my personal experience, where we have now almost 2,000 patients who've gone surgery in I-SPY 2, where a large proportion have received immune checkpoint inhibitor therapy. And then I think this is actually really nice to see these two together. If you look at the adjuvant setting, remember that all the patients in green were continuing to receive pembrolizumab. The only thing you did was drop chemo. So if you give pembro on its own, and this has been seen in other studies and other diseases, with checkpoint inhibitors, you see much less immune toxicity than when you combine it with chemotherapy. This actually fulfills the hypothesis of giving checkpoint inhibitor with chemotherapy, and that is that you enhance the host immune response. So you also enhance immune toxicity. But when you drop the chemotherapy, that difference goes away. So it's actually really interesting. Again, we talked about the fact that you see very little in the way of immune toxicity after surgery. And then this is just a cool picture to show you. This is the hair effect here is called poliosis, where you see loss of pigmentation in the skin in a patchy format in the hair, in the scalp. And the hair that grows in that patchy hypopigmentation of the skin has no pigmentation in it. And although poliosis before checkpoint inhibitors has been described, it's said to go away over time after a trauma or chemotherapy. But in these patients now, they continue to have hypopigmentation of their skin and hair. And there's interesting because I've seen it now in 2 patients and treated a lot of patients with neoadjuvant checkpoint inhibitor therapy. Both of these patients had a history of vitiligo, the patchy hypopigmentation of skin. And for both patients, vitiligo flared significantly, huge vitiligo after surgery, along with their hair finding. And for both patients, none of these side effects have completely resolved. And actually, they haven't even improved that much. This patient who had the patchy hypopigmentation also had patchy hypopigmentation in her eyebrows and eyelashes. She came in recently, she'd started dyeing them because they look so funny to her with actually completely white, patchy eyelashes and eyebrows. So where are we with checkpoint inhibitors in early stage triple negative breast cancer? So these are all the trials that have been reported. And I think obviously the biggest trials in Keynote 522, we also saw in the smaller phase 3 trial in Passion 31 an improvement in PCR. This trial is not powered for event-free survival, but of course they will report it over time, not yet reported. I think one of the interesting things is to look at these areas in red and pink. So I-SPY 2, tiny trial, but only 4 doses of Pembro. Jepar Nuevo, also a very small trial, 174 patients with more than a third stage 1. And I told you the impact is greater in stage 2 and 3 and node positive disease. So they sort of shot themselves in the foot without knowing it for the PCR endpoint. But they only gave 8 cycles of durvalumab, so it was all given before surgery. They saw a numeric improvement in PCR. You can see here, it just wasn't statistically significant because they have small numbers, but they did present a significant improvement in event-free, distant disease-free, and overall survival at ASCO in 2021. So it brings up the question about how many cycles of checkpoint inhibitor you really need to get a benefit. And then the NEO-TRIP trial, 280 patients, primary endpoint event-free survival, and included N3 disease, which the other studies did not, gave 8 doses of atezolizumab and showed no benefit in PCR. Numerically, the difference was about 4%, so a little benefit. They haven't yet reported event-free survival, but they didn't give anthracyclines. And there was a really interesting poster discussion. Bianchini has done all of the correlative studies for NEO-TRIP, and they had a very interesting poster discussion about the role of anthracycline on immune response, showing that patients who got anthracyclines had this marked increase in their killer T cells and the T cell receptor, et cetera, all sorts of different endpoints, which I don't have time to show you here. So it does suggest that anthracyclines play a big role in higher stage disease when you're using a checkpoint inhibitor. And we already know they play a role in outcome in higher stage disease based on other trials. So what are the unanswered questions for early stage disease? Who needs checkpoint inhibitors? One question is whether we could identify a group of patients who do well with chemo alone. Right now, that's stage 1 disease with negative nodes. So T1, A, B, and C with negative nodes. We do recommend neoadjuvant therapy for T1C disease, but no checkpoint inhibitor. We don't know which patients should not receive a checkpoint inhibitor. So if you had like an old autoimmune disease, should you get the checkpoint inhibitor or not? And I think you just have to be cautious in those patients. Based on the brightness study, we believe that platinum salts improve PCR rates and event-free survival, but we didn't see an improvement in overall survival. So you have to balance the toxicity against the impact on EFS. So for patient, I use the lower dose, AUC 1.5, because people tolerate it better. And the idea is to finish your chemotherapy so that if you have problems that are related to platinum, you want to hold the platinum and not minimize the amount of chemo you give with taxane and anthracycline because of platinum toxicity. You can hold the platinum, you can reduce the dose. There are many ways to manage this, but you don't want to drive the platelets down into below 100,000 because then you can't deliver the AC, which is so incredibly important. We don't know the optimal duration if a checkpoint inhibitor, if you achieve a PCR, and the Optim ICE PCR study, which will be led by Sarah Taleni and our alliance, will randomize patients who have a PCR to receive pembrolizumab or observation. So that's really important. And then optimal post-neoadjuvant therapy, we just don't know what the right thing to do is, but that's a nice lead into the Olympia trial, which of course had a median follow-up of 2.5 years with the addition of olaparib in patients who had BRCA1 or 2 mutation and high-risk disease, showed this remarkable improvement in 3-year IDFS with an absolute improvement of 8.6%. and a 7.1% improvement in distant disease-free survival. Overall survival is early and hopefully will be presented in the next couple of years. Importantly, Olympia showed no increase in myelodysplasia or leukemia compared to placebo, which was a big concern. The main toxicity, grade 3, is anemia in almost 10%. And some patients required transfusions, but the patients who required transfusions mostly required one. There were a tiny number of patients who required more than one. And patients report fatigue, of course, but 2% grade 3 fatigue and neutropenia at 5%, and a small number of patients had thrombocytopenia. If you look at the patients who are eligible for Olympia, I think it's important. Neoadjuvant group, you just had a non-PCR of TNBC, any amount of residual disease. For hormone receptor positive, you had to have high-risk features as well as no PCR. In the adjuvant setting, you had to have a tumor that was greater than 2 centimeters or positive nodes, and in triple negative disease, and for hormone receptor positive disease, 4 or more positive lymph nodes. So we know that this event-free survival difference, I think, is practice changing, although I've had some arguments with insurers. One of our insurers, Anthem Blue Cross, decided not to include it in their pathway. And the argument with them was sort of circular because it was all by email, with me saying, what? Why did you say this? And they said, well, there's no survival difference yet. And the follow-up was too early. But I will show this is not too early follow-up for triple negative breast cancer. Now, hormone receptor positive disease, we'll see what happens. But the majority of patients, more than about 80% of patients in Olympia had triple negative breast cancer and a BRCA1 mutation. And this is a very clinically meaningful difference. So I definitely would not agree with the insurance company who are motivated by a number of factors. So the data that was presented by Patty Gans is really important, trying to look at what is the cost in terms of toxicity other than our standard toxicities. This just shows you how to interpret these, and it's always a little bit messy. But the bottom line is that there was a little more fatigue, and I think anybody who's given adjuvant PARP inhibitor or metastatic PARP inhibitors knows that these patients do have more fatigue, and they do have more anemia, and the anemia may relate to the fatigue. But I think most of our oral agents cause fatigue, the CDK4/6 inhibitors, et cetera. In 2002, a really long time ago, we defined the pre-specified clinically meaningful difference being 3 points in these scales. And that's sort of been kept to with like concrete. And it really had to do with associating the number of difference in points with your ability to function. And so they didn't meet the difference of 3 points. So although the difference was statistically significant, the conclusion is it's not clinically meaningful. But I think for people who are working in the early stage setting, that this may indeed be clinically meaningful for some patients, and that this definition was really based on treating patients who had advanced cancer and weren't working the way patients do now with their treatments. So it's a little bit hard to know. Also, I think it's important that it didn't matter whether it was a neoadjuvant group or an adjuvant group, as you would expect. And then these secondary outcomes, which are really nicely discussed in the presentation of the primary data just 2 presentations ago, showed that adjuvant olaparib had this impact both on fatigue and on nausea and vomiting, but that it resolved completely after finishing treatment. I think it was interesting for me to look at the 12 versus 18 months. So remember, they're just taking it for 12 months, but it takes about 6 months to get better. And that's sort of similar to what we see with chemotherapy in and of itself and radiation in early stage disease, that it takes between 6 to 12 months to really recover from toxicity. In the 6 to 12 month time after finishing, most of the patients didn't have any more side effects that could be attributed to olaparib. So that they described as being rapidly resolved. And I think this is a new standard of care, and the toxicity just needs to be discussed with patients. You could have anemia. There's a chance you could need to have a transfusion, and you will be more fatigued, as you would be anyway from the chemotherapy and radiation, but it appears to be a little more enhanced, but doesn't appear to affect functioning. And then nausea, it can be managed fairly well, as can severe fatigue, by dose reduction and dose holds. I had already actually given olaparib to some patients who had
Dr.
primary. Yeah.
You have 2 minutes just to conclude your discussion, if you don't mind, because we are delayed in the schedule.
Okay. So I won't go through this then with the roadmap of what we would do for early stage disease, but it was presented at San Antonio as well. And there are a number of ongoing trials. NSA-BPB59 is the most important, 1,520 patients that we will see results of hopefully later this year. The adjuvant trial, hopefully we won't be giving adjuvant treatment to most patients, and the pembrolizumab post-neoadjuvant trial. So those are the largest numbers. And then Keynote 355, a 6.9-month improvement in overall survival, as well as a 4.1-month improvement in PFS in patients who had PD-L1 positive disease, defined as a combined positive score of 10 or greater, representing 38% of these patients in the first-line metastatic setting. And the data, which I think conclusively showed that PD-L1 of 10 or greater is the right cutoff. 20 or better didn't do any better for overall survival or PFS. And patients who had a score of 1 to 9 didn't seem to benefit from pembrolizumab. So there are a number of questions for metastatic disease. Again, we don't understand why PD-L1 is only important for metastatic disease. You should use the right test because there is incomplete overlap. I just saw a patient who is SP142 negative and had a CPS of 50. So you should definitely do the test for the checkpoint inhibitor you want to use. We don't know how long to continue checkpoint inhibitors when to drop chemotherapy. The withdrawal of atezolizumab was due to a statistical design flaw, but it's encouraging that the benefit in overall survival is quite similar between those two phase 3 trials. And there are a number of other studies going on looking at checkpoint inhibitors in hormone receptor positive and HER2 positive disease, as well as numerous studies looking at ways to amplify the immune response, which I think are really important with antibody drug conjugates, as well as sequencing of therapy. And in terms of the metastatic triple negative breast cancer, you can see here that, we do have checkpoint inhibitors as our first approach in PD-L1 positive disease. We don't know the appropriate sequencing with PARP inhibitors, but certainly we would want to give them early in the PD-L1 negative population. And we're trying to move antibody drug conjugates earlier in the course of therapy. Thank you.
Thank you, Dr. Rogg. Let's move to the discussion and question. Any question? The panelist, Dr. Bassam, Dr. Nasser.
I tried to ask Dr. Hope about the finding our way perfectly within these different trials of neoadjuvant versus we have two, the Olympia and the Zachariot X. So if you can just identify how can we approach patients with early triple negative breast cancer for either doing it in the neoadjuvant adjuvant with Pembro, and if we ask for the germ test and then it came with BRCA, should we combine the Pembro with the olaparib? And you have mentioned something about the capecitabine in the adjuvant, but in these trials there are a very small number of patients who receive both. So what's your way, please, Dr. Hope?
Right now, it's pretty much a data-free zone. And since we're discussing it, I will show you just this roadmap that I set up. And I think that mostly people are agreeing with this. Again, we did a little Twitter poll in terms of what people would do, which I think is interesting. Capecitabine is still the recommended standard of care in patients who have residual disease and do not have a BRCA mutation. So we're just talking about the no PCR patients here. We feel very comfortable here, although we don't know if they should get Pembro or not. Most people complete a year of Pembro. So no PCR. If you have wild type for BRCA, And there's a question about whether or not PALB2 mutation should be included in this germline BRCA mutation. I think they should, but we don't have the data for it yet. But if you're wild type, CAPE is still the approved. Now, in the SWOG trial, the ECOG trial that Ingrid Mayer presented, the event-free survival at just 30 months was less than 50% with capecitabine or carboplatin. So this is not a great outcome. So I think that we do need to consider whether or not we'll continue pembrolizumab in these patients. We know it's safe based on metastatic data. If you have a germline BRCA mutation, to me, you should receive olaparib because this is targeted to a specific defect in the tumor. And in those cases, the question is, should you continue pembrolizumab or not? And we don't know the answer, but we know it's safe from a number of trials, including the Mediola trial in the metastatic setting. So I think that you could potentially combine pembrolizumab with both of these options to try and optimize outcome for those patients, because even though the studies show that we've improved outcome, we're still seeing this. If you just go to what the outcome was, 67%, that means that a lot of patients had an event-free survival event. So I think that we do want to try and optimize outcome. It's just that we don't have the data yet. And hopefully there will be information in the future that will help us more with this understanding these combinations. But there's not going to be big phase 3 trials. So I think we're just going to have to operate based on what we think the best approach is for a patient.
Okay.
I think by this we'll conclude our session because of the time. Thanks for all the moderators and all for the speakers, and we'll start for the next session.
Take care. Nice to see you all.
Thanks.
Thank you. Welcome for all the attendees, the moderators. We are 35 minutes delay, so please, we should be on time. We'll start our last session for today. It will be about the HER2 positive breast cancer updates. We have 3 presentations followed by a short discussion, hopefully. We'll start with the first presentation that will be presented by Dr. Hulayl Al-Harbi, which is a known consultant of adult medical oncology at King Fahd Specialist Hospital, Dammam. Dr. Al-Harbi will present the GS3-01 trastuzumab deruxtecan versus trastuzumab intamethasone in patients with HER2 positive metastatic breast cancer, subgroup analysis from the randomized phase 3 study Destiny. The mic is yours, doctor.
Okay, thank you. Thank you for the Dr. Mulkhair and the organizing committee. So I hope you can see my slide now.
Yes.
Okay, so I'll present. Sorry, let me just share my slide. Okay, so I will present the subgroup analysis for the Destiny Breast 03, which was the trastuzumab deruxtecan versus the TDM1 in patient with HER2 metastatic breast cancer. It was presented by Sarah Harvey's. These are the disclosure of the primary presenter. As you know, the Destiny Breast 03, it was presented in the ESMO in 2020, which is the first phase 3 study for DTXT versus TDM1 in the metastatic breast cancer in the subsequent line, the first line. It was an open label multi-center clinical trial, and the randomization was 1-to-1 for patient who's unresectable or metastatic HER2 positive disease. In this trial, they were allowing patients who have clinically stable treated brain metastasis with more than 2 weeks between the end of the whole brain radiation and the study enrollment. Just to remember that the stratification factor was not included the brain metastasis, but it was including the hormone receptor status, prior treatment with pertuzumab, and the history of visceral disease. The primary endpoint was the progression-free survival by blinded independent reviewer, and the key secondary endpoint was overall survival with other secondary endpoints, including the overall response rate, the duration of response, and the progression-free survival by the investigator. So this is the baseline characteristics prior to the therapy. As you can see, the regional distribution was including almost 57% from Asia. And for hormone positive disease was almost 50%, they have ER positive disease. For the brain metastasis, patients who have a history of brain mets was 23 in the DTXD group versus 19.8 in TDM1. And patients who have target lesion at the study enrollment where they can be monitored was 16.5 in the TDXD and 14.8 in the TDM1. This group of patients, they are the one will be presented in the subsequent slides, including the progression-free survival and the response rate. Patient who received pertuzumab was almost 60% in both groups. Sorry. So this is the primary endpoint, which was the progression-free survival by the blinded independent reviewer. That's the one was presented by in ESMO, was showing clearly a separation of the curve with the median progression-free survival in the TDXD was not reached compared to 6.8 in the TDM1 with hazard ratios 0.28. And the rate of 12 months progression-free survival was 75% of the patient population in the TDXD compared to TDM1. At the data cutoff, 32% from the DTXD were progressed compared to almost 60% of the TDM1. So when they look for the progression-free survival in the key subgroups, was almost maintained the same magnitude of benefit in hormone receptor, whether they have positive or negative, whether they receive prior pertuzumab in the first line setting or not, whether they have a visceral disease, and the number of prior line therapy, which is 1 or more than 2. For the patient with the brain metastasis, the benefit was almost 15 months compared to 3 months compared to TDM1. So when you look for the confirmed overall response across patient subgroups, it was almost around 70 to 75% in the all groups in hormone receptor positive, pertuzumab, visceral disease, or prior line therapy. For patients with brain metastasis in TDX subgroup, they almost have a 67% overall response rate compared to 20% in the TDM1. Patients who have no brain mets was 82% compared to 36.6. So when you look, this is the Kaplan-Meier of the progression-free survival curve for patients with and without brain mets. Patients who have a brain metastasis at baseline, the median progression-free survival when they received the TDXD was 15 months compared to 3 months to TDM1. With a 12 months progression-free survival rate was 72% compared to 20% in the TDM1 group. Hazard ratio was 0.25. For patients who have no brain metastasis, the median progression-free survival was not reached by the TDX group compared to 7.1 month in the TDM1. So this is the confirmed overall response at best overall response in both groups. This is at the level of the whole body rather than the intracranial one. For the TDX1, the complete response was documented in patients who have brain mets is 4.7. Patient who without brain metastasis was 18.3 compared to 0 in TDM1 for brain metastasis and 10.3. When you look for the overall response rate was with patient with brain metastasis was 93% compared to 76% in the TDM1 group, including a complete response, partial response, and stable disease. This is for the intracranial response rate per the blinded individual, blinded reviewer. For the TDX group patient who have brain metastasis, the level of the response rate was documenting a CR around 27% compared only to 2.8% in the TDM1, and the partial response at the level of the intracranial lesion 36.1 compared to 30.6 in the TDM1. This is about the safety data, which did not show much change compared to the previous presentation. So the overall and exposure adjusted safety showed that the median treatment duration in the TDX group was 14.3 months compared to 6.9 months. And though the rate of any side effects or any grade 3 or more side effects were generally similar between the two groups, and the rate of adjusted incidence of adjusted treatment related to treatment-related side effects or discontinuation were greater with TDX versus than TDM1, were almost generally similar. So when you look for the side effects for grade 3, in TDX was the neutropenia more common than the TDM1, although the neutropenia, the thrombocytopenia was more in the TDM group. For GI symptoms, also for grade 3 was higher in the TDX, although the rate of more than grade 3 was the maximum for nausea is 6.6%. This is also including fatigue, which is around 5.1 compared to less than 1 for the TDM1. One of the most important or serious side effects was the pneumonitis or interstitial lung disease. For the TDX, it showed that there is no difference between the Asian group for the total group. For the Asian group, grade 3 was only 0.7. And if you look for grade 4 and 5, there is no documented interstitial lung disease or pneumonitis in the TDX group, whether they are Asian or for the total group population. Sorry, so at the conclusion, the TDXT treatment demonstrate consistent efficacy, benefit in progression-free survival and overall overall response rate over the TDM1 across all patient subgroups. The progression-free survival was a hazard ratio of 0.28, with confirmed overall response rate for the TDXT was 79.7 compared to 34.2 in the TDM1. In patients with and without metastatic brain disease, the TDXD treatment resulted in greater efficacy compared to TDM1. Patient with brain metastasis, the median progression-free survival was 15 months compared to 3 months in the TDM group, with a confirmed overall response rate 67.4 of the TDX versus 20.5 for the TDM1. For treatment associated with TDXT, it's associated with substantial intracranial response and the reduction in the CNS disease. 27.8% have intracranial CR versus only 2.8 in the TDM1. And only 2.8% have intracranial disease progression, the TDXT, compared to 22.2 for the TDM1. The trastuzumab deruxtecan demonstrate a manageable and tolerable safety profile. There is no difference between Asian and non-Asian patients at the level of interstitial lung disease or pneumonitis, with no grade 4 or 5 pneumonitis have been reported. So these data conclude, and the presenter was concluding that these data support that TDXD becoming the standard of care for second line in HER2 positive metastatic breast cancer. This is an acknowledgement from the group of from the study for the patient participant and their family. Thank you.
Thank you, Doctor, for this impressive presentation. I think we'll keep the questions to the end of the sessions.
So thank you very much. So it's my great pleasure to introduce our next speaker, Prof. Hisham Al-Ghazali, who's a professor of clinical oncology at Ain Shams University. He will present the next abstract about the updated overall survival from the phase 3 FOBI trial of Birutinib versus Labatinib in combination with capecitabine in patient with HER2-positive metastatic breast cancer. So, Prof. Hisham.
Thank you very much. I'm very happy to be with you. I hope to be in person, and thank you very much for Dr. Khair for inviting me. Thank you for all the organizers. I want to share the screen, but I think there is still a problem. Is Dr. Hulayel removed his presentation or not?
Yes, I did.
Okay. So, okay. So I think I shared my screen now.
For online, we see it.
Okay. So thank you very much again. And this is the updated overall survival results from the phase 3 FOBI trial of Birutinib versus Labatinib in combination with capecitabine in patients with HER2-positive metastatic breast cancer. Was presented in the San Antoniao Breast Cancer Symposium by Professor Bing Zhu from Cancer Hospital Chinese Academy of Medical Science in China. And this is the disclosure of the principal investigator. And we all know that the HER2-positive population is almost about 20% of all patients with breast cancer, with the HER2 is well established as therapeutic target for drug to be treated with in the HER2-positive breast cancer patients. And the second line is the TDM1, as just mentioned by Professor Hulayel, and after trastuzumab-based therapy is the preferred regimen recommended by international treatment guidelines. But TDM1 is not approved for use in the metastatic settings in all countries and region worldwide. This country-specific issue should be considered. Because of this, the go for discovery of this small molecule, which is the Birutinib, which is a small molecule pan-ERB receptor tyrosine kinase inhibitor targeting the HER2, the HER4, and the EGFR. And in the phase 1 study, showing the Birutinib plus capecitabine showed good tolerability and preliminary efficacy in HER2-positive metastatic breast cancer patients. In the randomized phase 2 study, NCT 024-22199, the Birutinib plus capecitabine showed clinically meaningful benefit and acceptable tolerability in patients with HER2-positive population. Look to the overall response rate, 78.5% versus only 57.1% compared between the Birutinib with capecitabine versus Labatinib. And you see also how beautiful the progression-free survival, 18.1 months versus only 7 months with hazard ratio of 0.3. So it is very important to propagate to phase 3 study. And this is the 5 study design of the comparing randomized patients who have pathologically confirmed HER2-positive metastatic breast cancer with prior trastuzumab and taxane and or anthracycline with up to 2 prior lines of chemotherapy for metastatic disease with at least 1 measurable lesion with ECOG 0 or 1, randomized 1-to-1 to receive capecitabine with either Birutinib in the dose of 400 milligram orally 4 times per day, or Labatinib in the dose with a dose of 1,250 milligram orally 4 times per day. Stratification factors including the hormonal receptor status, either negative or positive, the prior lines of chemotherapy for metastatic disease, 1 or less or versus 2, and the primary endpoints, as you see, the progression-free survival with the blind independent reviewers, and the secondary endpoints including the overall survival, overall response rate, duration of response, clinical benefit rate, time to progression, and safety. And this is a multi-center open label randomized controlled phase 3 trial. As you see here, these are the patient characteristics. The patient enrolled between July 2017 and October 2018. And you see here the median age is almost 50 years. The characteristic is like balanced between the two groups, including the echogestated, the hormonal receptor, metastatic sites at screening, the previous trastuzumab therapy, duration of prior trastuzumab for advanced disease, and resistance to the trastuzumab therapy. And you see here that almost about 30% of the patients have trastuzumab resistance, and while 72% of the patients have no trastuzumab resistance. And again, the previous lines of chemotherapy, and as you just mentioned, that it is a stratification point. So it is so some have more than 2 lines, and some have 1 line, and some have 0. So it is a first line treatment. And this is the interim analysis of the key efficacy endpoints, including here the progression-free survival and overall survival. The data cut off in March 2019, the progression-free survival was longer in birotinib and capecitabine than the labatinib capecitabine, reaching about 12.5 months versus only 6.8 in the labatinib arm, with the very beautiful hazard ratio 0.39. And based on the study, on July 9, 2020, China National Medical Product Administration granted full approval of the birotinib in combination with capecitabine, a second-line standard care treatment in HER2-positive population. And this is the patient disposition and updated overall survival. As you see, patient included or eligible for the study are 424, and then 157 are out, 267 randomized, 134 patients receiving a birotinib, while 133 receiving the labatinib, and then going for this study. And this is the updated overall survival. You see here the median overall survival, as you see, not reached in the birotinib arm, while it is only 26.9 months in the labatinib arm, with the hazard ratio of 0.69. And the overall survival in the subgroup, you see here that almost all the subgroups have improvements in the birotinib arm, except in those patients with non-visceral disease. They have improvement in the labatinib arm. So almost all patients, either those patients with trastuzumab therapy for metastatic disease less than 3 months or more than 6 months, or between 3 and 6 months, with trastuzumab resistance and without trastuzumab resistance, as you see, with HER2 amplification by FISH, whatever the pathological grading of the disease, whatever the alcohol or smoking use, if the patient is visceral, so the birotinib have a better overall survival in this subgroup analysis, whatever the estrogen receptor status and whatever the previous line, but higher lines, so the birotinib have better survival, overall survival. Again, a beautiful diagram showing there is improvement in the progression-free survival in patient with birotinib plus capecitabine, reaching about 12.5 months versus only 5.6 months in the labatinib arm, with the hazard ratio, as you see here, of 0.49. So again, if you see the beautiful subgroup analysis, that improvement in the birotinib arm in all patients with all the subgroups, including the trastuzumab therapy for metastatic sites, the trastuzumab resistance, either no resistance or there is resistance, the pathological grading, the visceral or non-visceral metastatic sites. Sorry. And this again, more clarification of the subgroups with this trastuzumab resistance. As you see here, the overall survival improvement in the birotinib in the patient without trastuzumab resistance, with hazard ratio of 0.6, and less applicable in those patients with trastuzumab resistance with hazard ratio of only 0.9, while there is improvement in both a subpopulation without trastuzumab resistance or with trastuzumab resistance with birotinib. You see here the progression-free survival is 0.44 in the patient without trastuzumab resistance, and the progression-free survival is 0.59 in the patient with trastuzumab resistance. So there is very clear improvement in the progression-free survival, while the improvement in overall survival is more clear in the subpopulation without trastuzumab resistance, but less clear in the patient with trastuzumab resistance in overall survival. According to the previous lines of chemotherapy, you see here that the more lines of chemotherapy, that there is improvement in overall survival in the patient receiving bioretinib versus labatinib with hazard ratio of 0.7 in 0 line. In first line, they have the hazard ratio of 0.7, while in the second line, it has improvement of 0.5 in patient receiving bioretinib, while it is very clearly better in the progression-free survival with the bioretinib arm, showing that improvement with progression-free survival with 0 line of 0.4, in the first line 0.49, and in the second line of 0.56. So the author concluded that with extended follow-up, bioretinib plus capecitabine demonstrated statistically significant overall survival improvement compared to the labatinib plus capecitabine in patients with HER2-positive metastatic breast cancer. Overall survival not reached versus 26.9 months in the labatinib arm with a hazard ratio of 0.6. Progression-free survival 12.5 months versus only 5.6 months in the labatinib arm with hazard ratio of 0.49. The benefit of bioretinib plus capecitabine were observed in the most clinically relevant subgroups for the updated analysis of both overall survival and progression-free survival. And these results show that the bioretinib plus capecitabine may be established as treatment option for this treatment population. And the primary investigator acknowledged the patient and their family and all the investigators from all over the group and the supporting company. By this, I want to thank you very much, and I try to be rapid as much as I can to try to be short. I know that you are short of time. Thank you.
Thank you very much, Prof. Hisham. So I'll give the mic now to my colleague, Dr. Abdel Nasser, to introduce the next presentation.
This is the last presentation for Best of San Antonio 16, GS4-6 neratinib plus fulvestrant plus trastuzumab for hormone receptor positive disease and HER2 mutant metastatic breast cancer, in addition to batinib plus trastuzumab for triple negative disease. This is the latest updates from the summit trial presented by Dr. Munira Husseini.
Yes, sure. Shall I start? So, Assalamu alaikum. Thank you, Mrs. Chairman, Dr. Al-Khair, for your kind invitation and to the organizing committee. So this is a presentation from Javier in San Antonio, looking at the expansion of cohorts included in the Summit trial, previously reported in 2017, looking at the effect of addition of trastuzumab to neratinib and fulvestrant for hormone receptor positive, HER2 mutant breast cancer in metastatic setting, and neratinib plus trastuzumab for metastatic triple negative disease. I have no disclosures. This is Dr. Javier reported research grant in association with Puma. The HER2 mutations have been studied over the last 2 decades as functional mutations, as an analog for gene amplification and driving an oncogenic addiction to HER2 signaling.
The HER2 mutations are known to be rare in solid tumors. They have been reported in 2 to 12% of solid tumors, but with variable incidence based on tumor histology, being mostly recorded in the neuroendocrine prostate cancers and squamous cell carcinoma of the lung. They have been noted that the diversity in functional HER2 mutations confers differential sensitivity to targeting agents. And the reversible pan-tyrosine kinase inhibitor, neratinib, has been selected in the SUMMIT trial based on preclinical evidence suggestive of its activity as a single agent and in combination with fulvestrant in HER2 mutant and HER2 non-amplified metastatic breast cancers. Also that has been studied in view of the early data reported in 2020 San Antoniao. The incidence has been noted previously. It's low in primary breast cancer, reaching around 2%, 2 to 4% in metastatic setting, 8% in ER positive. It has been enriched in lobular histology and luminal A tumors, and different functional activating mutations have been identified in the kinase domain, the transmembrane domain, and the extracellular domain. Most common variants reported as a single nucleotide variant in the kinase domain, an exon 20 insertion, and S310FY in extracellular domain. The presence of activating mutations has also been studied in presence of co-mutations such as TP53, PI3 kinase, HER3, and CDH1, with potential influence on the treatment sensitivity and resistance. The initial SUMMIT trial is a phase 2 open multi-histology trial that, as mentioned, studied the neratinib as a monotherapy in different histologies. They included tumors with HER2 mutation and patients with ECOG performance ranging between 0 and 2. They excluded patients who have been exposed to pan-tyrosine kinase, such as lapatinib, afatinib, and neratinib. They also excluded symptomatic and unstable brain metastasis. The dosage applied was 240 milligrams per day, looking at the primary endpoint of objective response rate at the first 8 weeks after baseline tumor assessment. The secondary endpoints looked at the clinical benefit rate, the duration of response, progression-free survival, and the safety of the drug. They applied the Simon two-stage design, i.e. if more than one response in first evaluable 7 patients weren't reported, they could expand the cohort to stage 2, and if more than 4 responses in the stage do, they can expand further or break out. So looking at the evolution of the expansion cohort, they subdivided the patients in the breast category to hormone receptor positive and triple negative with HER2 mutant breast cancer, and giving the reported resistance secondary to acquisition of new mutations and changes in the downstream pathway. They studied the biopsies prior and after the neratinib monotherapy, and they identified different new mutations in multiple domains, the keratine kinase domain, the transmembrane, and extracellular domain. The combination of and since the combination of neratinib and trastuzumab was associated with a stronger response and potential enhancement of neratinib monotherapy in versus of the new mutations, they looked at the effect of adding trastuzumab to neratinib in both subgroups. Those with triple negative histology and the ones with hormone receptor HER2 negative disease in conjunction with fulvestrant. So they They had a non-randomized cohort with a previous with a new inclusion criteria of a previous exposure to CDK4/6 inhibitor based on the new guidelines. And they had them in randomized and non-randomized group. The non-randomized group looked at the compared neratinib plus fulvestrant plus trastuzumab to single agent fulvestrant and fulvestrant in combination with trastuzumab. They allowed crossover to neratinib, fulvestrant, and trastuzumab at progression of disease in in these two categories. The triple negative histology, they treated the patients with neratinib in conjunction with trastuzumab. Looking at the criteria, characteristics of the included patients, majority of the patients had zero good performance status, ranging between 0 to 1. In the non-randomized and randomized neratinib, fulvestrant, trastuzumab group, the patients were majorly of lobular histology, while in the fulvestrant, trastuzumab, and single agent fulvestrant group, they were majorly of ductal histology. The patients were indeed heavily treated, but more heavily treated in the fulvestrant, neratinib, trastuzumab groups compared to the rest of the patients. All the patients had been treated with previous lines of endocrine therapy, and the previous exposure to chemotherapy was reported in 57 to 84% of patients. So the neratinib, fulvestrant, trastuzumab group had the reported overall objective response rate of 46.2%, noted in 12 out of 26 patients. And the overall response rate was 15, and it was noted in 15 patients. The median duration of response was 14.4. The clinical benefit, i.e. the stability of the disease, plus the partial response and complete response, was noted in 15% of patients and 15 out of the 26 patients, with median progression-free survival of 8.2 and median duration of treatment of 8.7. So why this is not moving? So compared to single agent fulvestrant and fulvestrant plus trastuzumab, we see that the addition of neratinib has enhanced the activity of the treatment regimen with increment in the complete response and the overall response rate by 28.6%. The median duration of the clinical visit was noted in 28.6% of the patient, and median progression-free survival increasing from 4 months to 6.2 months. The addition of trastuzumab has also been associated with an increase in the activity of neratinib and fulvestrant regimen, with an objective response rate increasing from 28.6 to 42.4%. Which is very encouraging in heavily treated patients with median duration of response of 14.4 months, clinical benefit noted in 15.5% of patients, progression-free survival of 7 months, and median duration of treatment increasing from 3.7 to 6.5 months. Here they're showing the enhancement in activity of the treatment regimen and with addition of trastuzumab and neratinib compared to single agent fulvestrant and trastuzumab alone. In terms of safety of the treatment regimen, the main toxicity noted was diarrhea, as expected, in 90.9% of patients, approaching grade 3 and 4 in 45.5%, with vomiting reported in half of the patients and fatigue. Fewer patients experienced abdominal pain and muscle spasms and asthenia. The adverse events experienced were responsible for discontinuation of treatment to 6.1% of patients. They looked more at they analyzed more the diarrhea as an adverse event, looking at the timing of the diarrhea and the duration of the diarrhea. Where
Still, we have 1 minute.
Also, in the triple negative histology, the addition of neratinib has enhanced the activity of, the neratinib trastuzumab has produced good objective response rate of 33.3% with median progression-free survival of 6.2 months in heavily treated, which is encouraging in heavily treated patients. So again, the diarrhea was mostly most predominant adverse event, where discontinuation, but did not cause any discontinuation of treatment in this category of patients. This is a waterfall analysis looking at tumor shrinkage and correlation to different activating mutations, and where the kinase domain mutation has been noted in the majority of the patients. But I don't believe, for looking at this graph or the other, that there has major influence, or we can say with accurately that there is a good correlation between different the type of activating mutation and the tumor shrinkage in response to treatment regimen applied. Here they looked again at the distribution of HER2 mutations across different regimens, and identified with partial and with more specific categorization of the treatment response in terms of whether complete response or partial response, stable disease has been achieved. So in conclusion, the combination of neratinib, fulvestrant, and trastuzumab is an encouraging modality of therapy in HER2 mutant metastatic breast cancer with hormone receptor positive histology. The objective response rate achieved in the study was 42.4%, with 1 complete response and 13 partial responses, median progression-free survival of 7 months. The treatment regimen of neratinib trastuzumab has also shown promising clinical activity in triple negative histology with objective response rate of 33.3%. The grade 3 diarrhea has been noted in majority of the patients, as shown, which necessitates strict compliance to loperamide prophylaxis based on the control study. So it will be very interesting to look at the effect of at the results reported in extended cohorts at longer term follow-up and in the both triple negative and hormone receptor positive subtypes, and to assess whether patients with hormone receptor and assess the response in the crossover groups. Personally, I think that we should interpret the results with caution, since several activating mutations has not been associated with increase in the protein expression likely because of their dependence on the para-oncogenic pathways, the changes in downstream, the secondary because of secondary mutations, and that we should look more at the effect of the coexisting mutations. That's it. Thank you.
Thank you, Dr. Husseini. So we will end by the discussion. That will be a discussion for the first or the previous 3 presentation will be done by Professor Muzaffar Rimawi, well-known professor at the Department of Medicine section of Hematology and Oncology at Baylor College Medical Center, Houston, Texas. The mic is yours, Professor.
Assalamu alaikum. Good morning and good afternoon. Can you all hear me and see my slides?
Yes, the slide.
Excellent. I want to start by thanking the organizing committee for inviting me to be among you virtually. I would have really loved to be there in person. But hopefully in the future. I want to especially thank Dr. Khair and the team of exceptional people who organized this meeting. The material has been really exceptional. I was asked to discuss these three abstracts, and I was thinking, what is really the theme that we can tie those three abstracts with together? And I think probably it's that there are new frontiers for HER2-directed therapy in breast cancer. And by no stretch of imagination am I going to try to, re-present all the data that was presented by my colleagues in a fantastic way in the prior three presentations, but maybe retouch on them and see what we can conclude together. These are my disclosures. So, needless to say, the HER2 pathway is a really attractive therapeutic target. It is overexpressed or amplified in about 15% of breast cancer, and is really associated through its process of homo and heterodimerization with activation of very potent transcriptional and translational pathways that lead to cancer behavior being aggressive, like migration, dedifferentiation, and metastasis, as well as resistant to apoptosis. And in the what we now call the HER2 positive realm, and as we'll see, that may be a flexible term in the future, we have seen that there are many treatments that were developed, be it antibodies, tyrosine kinase inhibitors, or antibody drug conjugates to target this pathway, and it's been very successful in overcoming the advantage that this pathway presents to tumor cells, and as a result, transformed the way we think about HER2-positive breast cancer. Of course, I'm not at all hinting that our work is done. Actually, the presentations I'm about to discuss show us that there are actually remain many challenges. For example, CNS metastasis, I think all of us would agree that that is an exceptionally difficult challenge because of both the location of the metastasis and the difficulty in managing them. And of course, the devastating results of the disease and sometimes of the treatment. Treatment resistance, despite the multiple options, remains a major factor that we have to always contend with. And of course, the fact that these wonderful, effective treatments have only been limited to about 15% of breast cancer. And maybe that is about to change, both in the abstracts that I'm going to discuss with HER2 mutations, but also, as you all know, with more potent antibody drug conjugates being explored in the HER2 low, which is a topic for another discussion. So CNS metastasis, again, despite progress, they're a major challenge. And what has really been both interesting and disappointing is that despite improvement in the early stage setting, think of the addition of all these wonderful anti-HER2 agents. Most recently, for example, TDM1 in the Catherine trial for patients who have residual disease after neoadjuvant treatment, we did not touch CNS metastasis. These agents don't affect them. And is it because of the location of the disease again? Is it the role of the blood-brain barrier, which I think is not as straightforward as some people think, or just the fact that we don't understand the biology of the environment in which brain mets live and thrive? It really limits our ability to address this disease. So we've heard the presentation about the Destiny Breast 03 that was presented at San Antonio by Sarah Hurwitz. And essentially, we all have been, I would say, very impressed, maybe blown away by the efficacy of TDXD in the second line setting as compared to TDM1, which has been so far the gold standard. I mean, to think of really look at these curves and a hazard ratio of 0.28 and a p-value that has over 20 zeros to its left is absolutely impressive and I think transformational. And the biggest question that many of us asked, or many people were wondering about, so what now? What happens when with brain mets? And that has been a challenge that I think has been thought of, because do antibody drug conjugates affect it? And if we think of the blood-brain barrier as a true barrier, these molecules are too big to cross it. And some people were popularizing that idea after really Catherine. trial showed that TDM1 does not touch CNS mets. But there are two things to think about. First of all, is grossly or clinically detectable metastatic disease may be different than micrometastatic disease, and that the blood-brain barrier is probably not as simple or straightforward barrier as we maybe traditionally thought of it. So essentially, if you look at the subgroup analysis as was presented by Dr. Layl 30 minutes ago or so, the brain mets seem to be, brain mets subgroup seem to be deriving the same advantage from TDXD as the group that had no brain mets at baseline. I'm arguing strongly that the presence of CNS metastasis is not limiting the activity of TDXD, which should be welcome news, of course. And if we look at the intracranial response, importantly, you could say, okay, the patient has CNS mets, they respond elsewhere, but not in the brain. Well, it looks like they do actually respond in the brain. I would interpret these with caution. The numbers are small, but they are quite reassuring that there is some activity. And if we add that to the data that was presented from Destiny Breast 01, which is also with small numbers, I think it gives us at least the consistency of the finding that there is some activity for these agents in CNS metastasis. Now, the issue, of course, of ILD has been always hanging over the head of TDXD, and I think the good news, as my colleague presented, was that really there was no difference between the age group and sub-Asian group, because there was a question about the ethnic and racial backgrounds being predisposing patients more for lung toxicity. That doesn't seem to be the case, and I think the fact that we didn't see a lot of grade 3 and we saw no grade 4 and grade 5 has to do with the fact that we are now more knowledgeable about ILD, more knowledgeable about how to screen for it and to manage it proactively. And I'm very happy that I've been involved with an effort to standardize this approach in the United States nationally, and hopefully to the benefit of our colleagues and our patients across the world. So with regards to CNS metastasis or this abstract, I think we can probably be reassured that TDXD has robust activity in CNS mets of HER2-positive breast cancer. I think this raises many questions again about the blood-brain barrier role in micromets versus macromets, and even the fact of, do we understand the blood-brain barrier very well? I think, to be clear, this doesn't rise to the level of activity or the level of evidence that we've seen in HER2CLIMB for the role of tucatinib in brain mets, because these patients were allowed to be on untreated and they were followed, and the numbers were higher and the activity was very impressive. So it's not at that level, but it is reassuring that there is activity while more data is being reported. Being involved with Destiny Breast 09, I can tell you that I think it is, there are discussions right now about the role of allowing patients with untreated brain mets onto the study. And I think it should be. I think that study should incorporate these patients, because we want to see for sure the activity against CNS metastasis. And it's good news that the ILD incidence is consistent across ethnic and racial groups, and that it was lower than before. It's hanging around 10%. Question is, how do we identify these patients, screen for the side effect, and mitigate it if possible? And I think it is possible, because think of when trastuzumab, for those of us old enough to remember when trastuzumab came on or was being developed, cardiac toxicity was a scary, scary thing. But then we learned how to screen for it. We got more data. We know how to mitigate it, and in a sense, despite the fact that there is no antidote to cardiac toxicity of trastuzumab or any anti-HER2, we know how to mitigate it and overcome it. And the overwhelming majority of our patients are receiving treatment with anti-HER2 therapy. I predict that the same will be true for ILD. Switching gears to the second abstracts and staying on the theme of expanding the horizons of HER2-directed therapy is really the update on the Phoebe trial. there's really no question whatsoever that despite the maybe embarrassment or abundance of riches that we have in HER2-positive disease, we do have still treatment resistance. And the fact that patients with metastatic disease, as long as they live, unfortunately, in the end, succumb to their disease. And so we have to remember that we always need to do better. Now, until a few years ago, lapatinib was kind of that only tyrosine kinase inhibitor that had some activity, and it was limited to to maybe the third line or second line, depending on how you look at it, and even beyond third and beyond maybe. But then with the reporting of the tucatinib, which I have to note actually went up against trastuzumab and capecitabine, did not go up against lapatinib. And neratinib in the NAILA trial that actually went up against lapatinib, we at least know that we have better options or more active options than lapatinib. With tucatinib, you just can surmise it from the fantastic activity it has that it would probably surpass lapatinib had they gone up head-to-head. And with neratinib, you know that up front, albeit in a less impressive way. So the question is there room for another tyrosine kinase inhibitor? And I think many of us like tyrosine kinase inhibitors in the sense that they can be they're oral and they could be well tolerated, but active. But on the other end, we were excited about tucatinib because it was well tolerated. I think with neratinib and other TKI, there's some concern about toxicity, which I think should be manageable, but still not negligible. So we heard the update from the Phoebe trial that was presented in San Antonio by Dr. Xu. And essentially, Dr. Sham went over this in a superb manner. The study essentially went up with a traditional design of lapatinib capecitabine versus pyrotinib capecitabine, which pyrotinib is another pan inhibitor, tyrosine kinase inhibitor that was approved in China. And the updated overall survival seems to continue to favor pyrotinib with its activity over lapatinib. When combined with capecitabine, the median overall survival was about 27 months, with lapatinib not yet reached with pyrotinib. And if you look at 24 months, you'll see that about 2/3 of the patients on pyrotinib were still alive, while that number was 59% for lapatinib. So I think that this is really very reassuring about the activity of pyrotinib in this setting. And if you look again at the progression-free survival, you see really an impressive improvement with 12.5 months with pyrotinib over a little over 5.5 months with lapatinib. So that's about a 7-month difference and a hazard ratio that is 0.48. Again, very impressive. And I think, and the authors concluded that this is really good data, robust data, reassuring data, and I agree with that. I think that this is another option that we have in our armamentarium, wherever it's available, to counter metastatic disease in the HER2-positive setting. Now, what do we know? We know that pyrotinib is more active than lapatinib, but so is neratinib. Tucatinib is also very active. So what do we do now? How do we sequence those tyrosine kinase inhibitors? I heard earlier in the previous session a question that was, in a similar way, given to Hope, Dr. Rugo, asking, what do you do with capecitabine and olaparib and pembro? Well, in a different venue, what do you do when you have neratinib, tucatinib, and pyrotinib? And I think we have to think about them in terms of the activity and toxicity, the site of the disease, and the availability. So, like I can tell you, in the United States, pyrotinib is not available. I'm not sure if it is available in Saudi Arabia or not, but it's not available in the US. So for us, neratinib, tucatinib. And I think many people, say, well, listen, I'm impressed with the activity of tucatinib. I'm going to start with it because it's better tolerated. And then I'll go to a different regimen. And then I'll see if I want to do a neratinib-based regimen. Of course, the fact that all three were combined with capecitabine, the chemotherapy backbone, can also play a factor here. And there are ongoing studies that I think are going to maybe help us understand a little more about that, if tucatinib moves up to the second line as a result of HER2 climb 2 or the front line as a result of HER2 climb 5, that could affect it. If Destiny Breast 09 includes patients with brain mets and reports active activity in the front line, that could also affect it. But I think more importantly, we need more data on the mechanism of resistance. These tyrosine kinase inhibitors are different. Although they all inhibit the HER2 tyrosine kinase domain, but they vary otherwise, whether they're pan inhibitors or not, whether they basically are reversible or reversible, or whether the toxicity profile and so on. So the last abstract that I want to discuss was the role of HER2-directed therapy in HER2-negative disease. So we talked about activity in the CNS, how do we basically go with resistant disease and later lines, and now can we take HER2-positive disease, HER2-directed therapy into HER2-negative disease? And as you heard in the previous presentation, activating HER2 mutations are present in about 2 to 4% of HER2-negative disease. By the way, we've also looked at it in our research, and it is also mutated in HER2-positive disease, but that's a topic for a different discussion. In preclinical models, HER2 mutations are associated with resistance to lapatinib, but not neratinib. Again, the idea that TKIs are not all the same. And trastuzumab is not active as a single agent, but somehow appears to increase the efficacy of neratinib when given together. And so these is, we're talking about HER2-negative disease. So HER2 is not overexpressed, it's not amplified. So why is it driving the cell growth? And I think the idea behind that is if you get a HER2 mutation, activating mutation, of course, it actually switches the receptor on. So it does become the dominant pathway for these cells, as if you kind of made them, HER2 positive in a signaling perspective. Of course, not exactly, I'm not saying it's the same, but it really activates, turns the pathway on, and it starts driving cell processes. And so I agree with, I believe it was Dr. Munira who said that we need to, think whether these mutations are driving mutations or passenger mutations. I think there's plenty of preclinical evidence to suggest that with specific HER2 activating mutations, they are driving tumor growth. And so trastuzumab doesn't work. The question is, would neratinib work? And that's really what the excellent summit trial was presented by Komal Javeri in San Antonio. And you've heard a detailed description of the trial. I'm not going to go over it other than to show you about the breast cohort. Essentially, there was a non-randomized ER-positive, HER2-negative cohort and a randomized cohort. And then, of course, there was the triple-negative disease. The difference between the triple-negative and the ER-positive is that ER was targeted as well. And I think this is a very smart strategy. And essentially, you see here that there is really an ER-positive disease, very nice activity. I concede that these are small numbers, but it is very nice activity, both in terms of response, clinical benefit, and the median overall survival, as was presented a little while ago. And if you look also at the people who have received prior CDK6 inhibitors, it is lower as a benefit because these are more resistant tumors. But again, let's remember, these patients don't have a lot of therapeutic options, at least in a targeted perspective. And this is the spider plot for the individual tumors. And if you look here, you'll see on the upper left, the randomized neratinib, fulvestrant, trastuzumab, and they seem to be either stable or responding for the most part. Also right below it, the non-randomized cohort, again, showing a good amount of clinical benefit, I would say, particularly looking at the prior treatment that those patients got. While if you look on the right hand of the slide, fulvestrant, trastuzumab, or fulvestrant alone, you see very, very modest activity, almost no effect. And if you look in the triple-negative disease, again, a small cohort of patients, but when you look at it and you see that they've been treated before with 3 to 4 lines of treatment, and you look at the efficacy of the regimen, with a clinical benefit, that was, in 7 out of those 18. It's really, again, not earth-shattering in the sense that it didn't really reverse the course of the disease of these patients. But again, these patients, we have to think of them as not having a lot of options, because what do you do for a patient who's 4th line or 5th line triple negative disease? So from that point on, you can buy them a 6-month progression-free survival. I don't think that is a bad thing. If you look at the distribution of the HER2 mutations and the best response, the message here is the active, it seems to be activity across the activating mutations. And again, I agree that we need to make sure that these are activating mutations and that there is biologic evidence that they drive the tumor growth. And, we could do that in the lab to actually, and there's also in silico models that could predict whether these mutations are activating or not.
Sir, can we conclude?
So neratinib-based regimen with endocrine therapy is active in these patients, and for selected ones, I think, with limited therapeutic options, this regimen is reasonable to consider. I'm going to be very measured here. I'm not saying it should be across the board, but I think for these patients, we can think about it. Diarrhea control is key, of course, and I think this is a small subset of breast cancer, but in the age of precision medicine, as we understand more about biology, I think we are going to convert all cancers into a group of small and rare diseases. So with that, I think that the only point I want to say is that with further drug development and research into mechanisms of resistance, we have and we will refine our approach to individual patients and individual tumors. Acknowledgement to all the patients and their families who participate on clinical trials to derive our knowledge, donating their data and their tissue for that. Dr. Khair and the organizing committee, fellow speakers at San Antonio Breast of Middle East, and the presenters at San Antonio Breast, and all of you for your attention. Thank you.
Thank you, Professor Rimawi, for the interesting presentation. Maybe we can take 1 or 2 questions before ending the meeting and the session. I don't know if there is anything in the chat box.
Can I ask Dr. Rimawi a question, please?
Please go ahead.
Yeah. Thank you, Dr. Rimawi, for your presentation and discussion for all these time. So now, I mean, I think it tends to be more difficult to us how we ride the pathway, how we can judge approving all these medications in the setting of metastatic HER2 breast cancer. Do you think brain metastasis per se is an important factor? Which drug will be approved in the 2nd line or 3rd line setting?
This is very important question, and it's a very tough one. I think what you're alluding to is as tucatinib, both tucatinib probably as the leading TKI right now, and TDXD kind of progress through getting earlier and earlier. How do we prioritize them? And I think it is really a question about the presence of CNS mets versus not, but it's not the only factor. I think the burden of disease is one. And I think, the degree of symptoms from the CNS metastasis is another. For example, a patient whose disease recurrence is mainly CNS, not a lot of burden of disease outside the CNS, and I'm talking about the 2nd or 3rd line, you could select, tucatinib more for these patients because, we have very robust level 1 evidence about its activity. But by the same token, someone who has small brain mets that are not symptomatic, but a huge amount of disease in the liver and the lung, and you really want to, get that high response rate that you see from TDXD, may be more appropriate or maybe reasonable to give that patient TDXD. So that you could shrink that disease down, and then you could monitor that CNS disease and treat it when you need it, when you need to, or really reserve tucatinib for later when you actually its activity against this disease is important. So, and these are just 2 extreme examples, and I know that most patients sit in between, but I think also we have to think of the side effects of the treatment and the risk factors of the patient. The patient have, prior lung disease that we're really worried about lung toxicity, or does the patient have problems with diarrhea or skin toxicity? So a lot of factors, and then availability, what is available, in this day and age. We have to also see what the insurance plans cover. So many factors to consider there, but it is tough, and they seem to be going up 3rd line against each other, 2nd line against each other, and now front line against each other. tough decisions, but I think at least we know that we have more than one active options for the patients. And I just want to say one last thing. I don't think anyone can go wrong. I think these are just, decisions that are not really right or wrong, but, dependent on the circumstance.
Thank you.
Oh, very interesting. Thank you very much. So we conclude now this session. So I'd like to thank all the speakers, the attendee, and the moderator. And I would like to thank Dr. Khair for this successful meeting. So I'll give her the final speech.
Okay, we conclude our 16th Middle East Best of San Antonio. And finally, I would like to invite the attendee who are here and the speakers, the chairperson with us to take a photo. And of course, this event will not be successful without the distinguished speakers that participate in this conference, whether international, regional, or national, as well as the chairperson and the attendee, of course. And finally, I would like to thank Donabel, my secretary, that with me for the last 16 years with this Best of San Antonio, and the Eventotrope company that organized the meeting now for the last 5 years. We're together, or almost 5 years. And now we'll take a photo.